Check. Hey, check one, check. Check, check. Hey, check one.
இதா
Check. Hey, hey, check one, check.
Which you're totally able to. That one. 20, वो भी है 24 नहीं 25 25 और एक आया एंजियोग्राफी अपग्रेडियो बोल के है शायद 25 बोल के लगा 25 वाले
Geography basics
हाँ
view
that one
Upgradio.
that one ऊपर वाला हाँ ठीक है वो नहीं और एक अपग्रेडियो रहता
एक मिनट में पहले ये तो
हाँ
कॉपी कर लेता
ठीक है ये हो रहना चाहिए
हूँ। हाँ मैं इसमें प्ले करके चेक कर your name
डॉक्टर श्रीनिवास
हाँ हाँ वो दो आ गया वो दो पीपीटी आ गया
और एक भी है
लिपिड्स लिपिड
अपग्रेडियो यार
ये लिपिड्स लिपिड्स थेरेपी है
अपग्रेडियो अपग्रेडियो बोल के मारो अपग्रेडियो 25
लिपिड्स आना
बेसिक्स
और एक ये
बेसिक
Hey, 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 hey.
Very good afternoon, all, and a very warm welcome to every one of you for the third session, or I would say the third uh, the third event of this Upgradio. And on behalf of Lupin's cardiology team, I, Dr. Vivek Kolapkar, take this opportunity to welcome you all for this Upgradio 2025, which has been conceived with the help of CRF TCT USA and Facts Foundation. Before we start with the program, we would be seeking the blessings of the Almighty, and we would be having the lamp lightning session. So for that, I would invite Dr. A. Srinivas sir, and also our faculty, Dr. Chabi, we have Dr. Mishra, and Mr. Rohit Manro. I would also request all the business unit heads of Lupin, Mr. Sandeep Sharma, Mr. Pradeep Dubey, Ms. Deepan Ambiar, Mr. Krishna Rao, Mr. Neeraj. Thank you so much, everyone. With this, coming on to the next part of the session, I would invite Mr. Rohit Manro, who is the Vice President at Lupin Cardiology, and I would request him to please give the Lupin corporate overview.
A very good evening to all. Let me have this privilege on behalf of entire team Lupin doctors. This is a third program Upgradio that we are doing for young cardiologists. And in Lupin, I want to say my heartiest thanks to Dr. A. Srinivas. I think last 3 years, he is crafting this academic feast for all cardiologists. Thank you to you, sir, for your time that you have given to us and craft such a beautiful program. Before we will start with the proceeding, I will just take a couple of slides just to give you the overview of Lupin. Lupin is being founded by Dr. Deshbandhu Gupta. Dr. Deshbandhu Gupta is from a very small village of Rajasthan and crafted a multinational organization. Lupin journey started in year 1968 by Dr. Deshbandhu Gupta. Inspired by the resilience of Lupin flower, Lupin is committed to the mission of making quality healthcare accessible globally. And we are having 15 manufacturing sites in and around the world with 11 US FDA approved plants. We keep on manufacturing more than 20,000 million formulations in a year, and with more than 3,200 metric ton API formulation, which Lupin manufacture. Not only that, with our CSR initiative, we are being connected with more than 2 lakhs patients. And not only that, our expenditure on year basis is 256 million. We are also contribute to cleaner and better tomorrow. So we are having 21% reduction in absolute GHG emission. And not only that, our 6 sites are zero liquid discharge. We are having 15 manufacturing sites in and around the world, 7 R&D with the strong field force of 22,000 plus employees that is working within Lupin. Lupin ranks 7th in India, and we rank number 3 in US by prescriptions. In our R&D portfolio, we are having 866 active patient applications filed. We are being connected with more than 14 lakh 20,000 patients with our patient support program. Not only that, we are being connected with 78,000 plus healthcare professionals with our doctor education programs. We are in generics, we are in complex generics, we are in biotech, API, as well as in OTC. In India, we are having extensive presence in 25 therapeutic areas and with 30 plus specialized teams delivering excellence in every segment with more than 10,000 workforce which is working in Lupin in India. In India, we are a very strong player in cardiology, anti-diabetic, respiratory, GI, and anti-infective. Lupin India revenue, 75% comes from these 5 therapies. We are going stronger in other therapies like vitamins, neuro, pain, anti-TB, and others. We are collaborating with a lot of scientific initiative like International Speaker Program. And for cardiology, the program which we keep on running, one is Upgradio and another is PCR Live. This we are keep on doing for intervention cardiologists. And this program we are conducting from last 3 years. We are also being connected through CMEs, webinars, advisory board, and panel discussions. Not only that, coming to the patient centricity to support patient by offering a holistic approach of lifestyle management and therapy adherence. There are 2 programs which we are running for patient supports. One is Hamrahi, which is for cardiometabolic patients, and another is Jai, which is for our respiratory patients. And I'm happy to announce through our Hamrahi program, more than 140,000 patients has been enrolled and connected with more than 35,000 doctors. We are expanding our wings. Lupin subsidiary, Lupin Diagnostic Health, is now having all India presence, and our 50% of our labs are NABL accredited. Not only that, we have a collection center in a span of year, which has moved to 750 to 1110, and our labs, which has moved to 40 to 47. Another subsidiary of Lupin, which is Lupin Digital Health, under the brand name of Lupin, which is first remote cardiac rehabilitation platform, which we have launched 1.5 years back. And we are happy to announce that 10,000 plus patients we have served so far with 94% success rate. More than 1,000 plus cardiologists who believe in this program, and 50 hospitals we are having that tie-up. Lupin is being awarded by one of the other organizations. Recently, last year, our flagship brand of Sequitral Valsartan, that is Valentus, has received the Best Launch Award. Not only that, our CEO, Mrs. Vanita Gupta, has received the Top 100 Powerful Women Award by the India Today. So, and so on and so on. This is all about Lupin. So go ahead with the proceeding. Now I will again hand over the session to Dr. Ovik. Thank you to all of you.
Thank you so much, Mr. Rohit. So I would now like to introduce the man behind this program, Dr. A. Srinivas Kumar. So Dr. A. Srinivas Kumar is a senior consultant cardiologist director at Apollo Hospitals, Jubilee Hills. He is the chairman of the FACTS Professional Services, founder, director, and CEO of FACTS. He is the founder and co-director of ACVS, founding director of TCT India. He has been specialized in TAVI as well as TAVR. And to date, he has performed more than 15,000 angioplasties and over 100 TAVIs and TAVRs. And he has a rich experience in research as well as. So I would like to I would like to applaud Dr. A. Srinivas Kumar, and please give a loud round of applause to him. So to felicitate Dr. A. Srinivas Kumar, I would invite Mr. Rohit Manro. Before I hand over the session to Dr. Srinivas Kumar for this subsequent talks, I would invite Dr. Chabi Satpathy, and I would request Mr. Sandeep Sharma to please felicitate Dr. Chabi. I would now hand over the session to Dr. A. Srinivas Kumar. Over to you, sir.
First one.
Yeah, good afternoon, friends. Thank you, Lupin, and all the people involved in organizing this Upgradio. It's a pleasure to do it educative program on behalf of ACTS Foundation and in collaboration with the Cardiovascular Research Foundation. Our aim and motto is this pure education and probably covering some of the basic aspects of postgraduate training and concentrating a little more on the clinical aspect, more on the interventional aspect rather than clinical aspect. A lot of other programs are there for clinical cardiology. And then this year, we also thought we would introduce this OSCE type of conceptual questions which are being asked, which play important role in the exam passing. So that is a thing we wanted to highlight this year. And it is, I thank all of you, all the postgraduates and some of the young cardiologists who just passed out for taking interest and to coming over here to attend this course. The most important thing is all of you who come to learn, and it can be mutually interactive discussion rather than only didactic talks. And all the faculty, Chabi Madam and others, Mishra over here, and all others who joined. Again, I'm extremely thankful to all of them because the course cannot be completed without the help of all these good faculty. And at any point of time, if you want to intervene, ask any question, feel free to do it. It is not an official conference or anything. It's more of learning platform, I would say. And then there's a slight change in the program which has been circulated to you before for sake of some of the faculty who are coming and joining a little late because of work pressure. And so what we do is cover up the basics in the first session as it is. And then probably the drug talks, obviously when you're meeting and such of expenditure involved, you need to take care of some of the business interest of Lupin too. The Ivabradine talk and then probably Inclisiran talk, we'll have it after these basics. And then we will go on to having PCI related optimal PCI talks. And then we will have OSCE presentations. Then finally, we'll have interesting complications talk at the end. That will be the course of events, flow of the program today. So to take it forward, the first thing I would start is basically to start on the basics of angiography and angioplasty. It is very important for all of us to be very comfortable because nowadays, though it is not correct whether you like it or not, most of the fellows are interested in learning how to do good angiogram and angioplasty. And the basic of bread and butter of our interventional cardiology is this. So that's why I thought I would start with it and then probably take it forward further, showing how to do a good angiogram, how not to do, and all that will be covered in this. And then I'll request again to feel free. And then if time permits, I'll cover a little about access. And then also some of the cath lab material, which Madam, subsequent speaker will be speaking on, If required, again, I'll cover up with some of the interesting things. In between the sessions, I would also throw up some snippets like things to show some interesting cases or interesting learning points in between the various talks. And this slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across Apollos and try to gather data. If we are together, it becomes huge strength. Together, we never thought that Apollo is a leading player in the country, doing about 96,000 plus angioplasties per year. But if we network and collect our data, it will be huge strength. It can become further better. Then our group of colleagues, we work together, cover multiple hospitals. That's how if I'm doing the program here, my other colleagues are taking care of patients there. That is a good way to simulate. I always keep telling this example to youngsters. This has been appreciated in European Heart Journal too, that solo practice to group practice is the way to go. And then Apollo was also happy because that also came in European Heart Journal. I'm extremely thankful to our organization for the support in entering any of this program. And many of you must be aware of TCT program which we conducted, which again, Lupin is a great help in doing it. And without companies' collaborations, we cannot do a good program. Other thing which is very important, all of you must be having some links with the US or Europe or any problem. Fortunately, to this good friend of me, Sushil Kodali, the facts could establish Cardiovascular Research Foundation, Columbia Heart Valve Therapy Partnership. That's together we brought the Tower program and TCT India and other programs too. And they're always ready for any educative programs. I pay my respects to regards to my educational institutions here locally, Usmania, and then probably SGPJ where I got trained. And I feel very happy Mishra and other SGPJ alumni are also being involved. I always take it as a pleasure to do it. With this, again, what I would do is basically in the coming 20 minutes or so, start up with the intro, tell you about principles of angiogram, then what are the basic views we take, what is a good and bad angiograms, then go on to lesion assessment. Then if time permits, we'll see about access and the various other materials used. I'd like to share my thoughts on some work-life balance, how to lead a good and healthy life. Then what the mind does not show, the eyes cannot see. And what eye does not see, mind that does not know. That is basically, if you know how to interpret good angiogram, then you do it well. Otherwise, you may not. And the same thing applies to radiation, which happens in the cath lab too. The principles of coronary angiogram, actually, basically angiogram, coronaries envelop the heart in 3 dimensions. You have to view that the coronaries are engulfing the heart. Then know the anatomy, the outline, the chambers, and we need to always keep this in mind. At least 2 orthogonal views have to be taken. Distance and parallax concepts need to be kept in mind. So this is important for us to uh, angiogram and see the heart behind the coronary angiogram which is coming. Then interpret each of the vessel millimeter by millimeter. And then orthogonal views, again, basically because you see it from 2 different angles, the eccentric lesions and all could be profiled better. So angiogram is actually a collection of images and not a snapshot. Understand the flow pattern. That also gives a lot of information for us. The critical stenosis, the flow will be very slow. And good angiogram performance lead to interpretation of successful intervention later. If you perform a good angiogram, know that there is a patency of a faint trickle, which happens in 50% plus of the patient, then probably it becomes easy for the successful, rather than patients like have bridging collaterals where it will be difficult to perform the intervention. So that's how it is very important to have a good interpretation. The basic views of the angiogram, I think you know. Right side of the heart, you put it as a RAO views. On the left side, it goes to LAO view. This is basically done to see each of these vessels are seen in particular images, the better. So this is a surface anatomy, which type of projection show what is mentioned here. Many of you would already know it, but if you see this heart, this is a right coronary artery, this anatomy, you know it. But this basically LAO cranial view, how many of you sitting here, you must have already got exposed on doing angiograms yourself. And many institutes, this pattern varies. So can you tell, one of you can tell which is the first view which you do while taking an angiogram in your place? Institute, somebody can get up and tell? Sorry? RAO caudal. Then anybody else does anything else? India is funny, you see, everything is possible. People do AP, people do LAO, people do RAO, anything is possible. Because final message is we have to get the information about each of the vessel in total, agreed. But why particular views are required is, which is the most important vessel in the heart? As you know, it is left main, isn't it? So if we have to image the left main, ostium is starting. So left main ostium gets profiled between the best in the elevocranial view. That's why originally in the interpretation of coronary angiograms, the recommendations wise, elevocranial, and again, nowadays technicians are also lazy and they don't put the views properly, which we need to educate them. LO means it has to go at least to minimum 45 degrees plus or 50, and cranial caudal means at least 20. People put 20, 30 and then 5, 10 caudal and cranial, then that won't serve the purpose. So why it is recommended is left main ostium, not the division which is divides into LCX and left main. That gets best profiled in elevocranial view. I will touch upon those, show some case examples. Then the distal division, again, you show in caudal. So whenever you're taking elevocranial, the counterpart view you have to take in caudal. So that is how the next view will be that. Then AP cranial and AP caudal or sometimes caudal. So these four views are generally good enough. But if you have sometimes doubt, you might need to extend the views depending upon the. So imagine inside the brain that you either interpreted all the parts of the vessels or not. That's very important. Angiogram doing is not a great thing, but again, if you miss out something, you can't get the patient back. That's why you need to have the complete information of the every segment of the heart. That's why I said inch to inch visualization of the artery has to be done. So you completely have that in mind and then take the patient out. The patient, again, once you miss out something, you can't get him in again. So it doesn't go in good sense. So if you see some of the other views which are sometimes optional are also mentioned here. So if it is the right coronary artery, most of us are comfortable doing LAO and epicranial views, sometimes right lateral views. And each of the views show what it is all available in the net too. But I wanted you to become aware of the concepts of doing an angiogram. And then how many of you know there's a basic difference in the heart structures between the RO views and LO views? If you see, the RO views separate atria from the ventricle. Please understand this concept. And the LO views separate both atria from both each other, both ventricle from each other. That's how LAD runs in between. So right side of it will be the right ventricle, left side of it will be left ventricle. But as RO view, the top will be above the portion will be atria, below will be ventricle. This is a conceptually things you have to understand it. Some of you are all who are already aware, final years, please excuse me because I don't know how basic what needs to be covered. See this angiogram. So basically, can you dim the lights? This is a tight ostial left main. You see this? So it's coming out. Initially, people could think it is a streaming or what. Then, but it is if you see this view, the caudal view, you may miss it. But whenever you find a haziness like that there, you please check in the contralateral view. You could be missing the tight lesion there. See the importance of elevocranial. Very critical disease is noted here. See that it may be missed there if you take only caudal. That's why, in general, recommendations wise, elevocranial could be taken first. Especially, again, the importance is you should not, also checking the pressure becomes very important. Then if it's getting damped, you should be careful enough not to take too many pictures. Then this is again, cranial view, caudal view shown here. Cranial also again shows the next best, probably epicranial, cranial also. That's why when you're positioning the stent in the left main, you're supposed to check in the elevocranial or the epicranial views. And the elevocaudal sometimes, again, it could be misleading. So please be mindful of this. And then left main ostiums are best profiled as an elevocranial view or epicranial view. This is the right coronary artery again. Sometimes non-selective injections you need not accept correctly because some of the important information could be missed. So always try to get a selective pictures of the coronaries. See this, when you inject it selectively, I don't know what, selectively, then you make out the lesion there. So if it is non-selective, you could miss out those lesions. So this patient effectively turned out to be left main, the proximal RCA, severe dysfunction. Also, I didn't get that, whether the bilateral carotid disease. Surgeons refused. Such sort of sick patients who are not fit for surgery also are being tackled. We did multivessel revascularization, include left main and carotid, and patient is still doing fine on follow-up. And then this is about right coronary artery views, which are depicted here. And then some of the things, when in any place the vessel is not seen in that entire myocardium, you need to be careful. Some of the vessels could be occluded. And motion also gives us idea about it. The story of missing vessels I called. Suppose some vessel is 100% occluded. That area won't be filled at all. So you have to carefully see, are we missing any of the vessels or any vessel is arising anomalously? So if that time, sometimes of independent origins, all that. So this missing myocardial territory is an important clue for you to see that you are not missing out any vessels. A word about catheter handling, the damping. I see nowadays some of the physicians doing good and bad is there everywhere. I'm not criticizing, but damped, some people forgot the habit of checking pressure also before injecting. It is actually negligence. Please don't do it. Always check pressure. And whenever there is a damping of the catheter, please don't inject. It could lead to dissections. So how to handle the damping is try to see why is it happening. If it is LED, if you have to go selectively into LED, rotate clockwise. If it is LCX, rotate anti-clockwise. RCA also, you should try to see and rotate anti-clockwise and see to prevent sucking in and getting damp. And if you lead inject without checking pressure or when it is dissected, when it is damp, it could lead to dissection. So please check pressure and handle the catheters carefully. Though the later generation catheters, which are very soft, are much good. So if this direction, sometimes if you're taking amplats or a complication session, one of the snippets I will show, dissection, if it inject abnormally, then you could get falsely, or the vessels could get dissected. So if you turn it slightly clockwise, then it goes selectively and you get a good image. That's about how to do a good angiogram. Then if you see, this is a real world case I'm mentioning, not in our place, but nowadays other centers which are busy, this is actually TKR, a very strong TKR center, knee transplant. Before that, they do angiograms, some reports are interpreted, and they send with this. So there are 2-3 problems. Don't inject when the catheter is too deep. And once you start the cine, then only you start imaging. The first frame itself, you always have the filled contrast. There should be also good coordination if suppose a assistant is doing it or yourself doing it. First, let the cine come, then start injecting. Some of the things could be basic, but I thought I'd briefly cover. We see it. The catheter is too deep in, again, it could land in trouble. You don't know whether it's missing the proximal lesions if the catheter goes too deep in. So always let the cine start, then start injecting. Trace the catheter contrast right from the starting to distal portion. Non-selective shots, this is the other extreme. That was too deep. This is actually nothing is seen. These shots, 2-3 shots like this are given, and patient is advised for PCI. He comes to us, and I can't make out anything. And I told them, oh, no, whatever are there, we are not able to see much. And then that's how I can't do it. Then when we did a selective angiogram, there's nothing. Then patient was actually very happy. I didn't show what we did. That is a good angiograms, what we do. But all these are non-selective shots. Then you tend to misinterpret and get into advices which are streaming left main was noted in this. All that is there. So if you advise it, intervention, how can you do it? So poorly performed angiograms always leads to commitment of mistakes. So please check and probably do selective angiograms and start cines, then image properly. And then probably the imaging also should continue till the contrast clears. And then whenever the late filling of the vessels collaterals are happening, please continue to expose. So those are some of the things. And sometimes the contralateral vessels filling, the CTOs also gives you a lot of information. Nowadays, many of you are exposed to CTOs where you have dual injections helps a lot. Then finally, in these areas today, we don't do LV angiograms, but if you follow it up, a lot of venous phases, you still get a reasonable idea. And the movement of coronaries also will tell you whether the coronary LV function is normal but by and large, always make it a point to do an echocardiogram assessment of LV function before you take up these patients for an angiogram. It is important because many of the times you can avoid complications happening if a proper good echocardiogram is done. There's no point taking on multiple views. We keep seeing in patients with CKD, contra creatinine, little borderlines also 10, 15 views are taken. If you get information of inch by inch of all the vessels, 3 vessels, then that's where you can stop. You obtain it in 3 views, 4 views, or up to you. But finally, don't keep on taking a lot of injections if you have already information. The interpretation of the vessels, again, as I said, the branching patterns, the myocardial value, how much it is supplying, the stenosis assessment. I'll tell you about that, lesion principles. I think when the contrast is filling, assess the filled vessel. Don't assess when the contrast is layering. Then identify the reference vessel and compare the stenosis with that. Sometimes in ectatic vessels, you tend to get confused. And whenever the stenosis segment is more than the catheter size, by and large, the lesion will not be important. So you can see that and understand that and see these vessels as half full. Life is also like that. You should be happy with what you have and don't see the negative things as half empty. So analyze when what are the filled portions of the vessel. And then moderate long segment diffuse disease sometimes could become important, especially when there is the proximal vessels. So these are the things which is, we should assess accordingly, lesion length and things like that. And mild lesions look more mild, severe lesions look more tight. This is the MAC effect is what when it crosses, artery crosses the diaphragm, it tends to look more tight. So please keep this in use. And generally you have QCS as cross-check. And believe it if it matches our thoughts. That's what I say. And if it is fitting into your thought process, it's okay. But otherwise, generally QCS underestimate the vessel sizes when we are taking these examples for stenting. So these are some of the lesion assessment principles. I think all of you are aware of this Grossman's diagram. When I was just started, I used to think this diameter area, why is it like that? Why the 60% is equal to 90%, 50% is 75% is if you know this concept. It's a diameter stenosis. When it goes to circle, which is the area, it becomes like 70 will become 90, 50 will become 75, and 33 will become 50. This process, I think many of you are aware already, but I thought it's very important. Suppose nowadays people are saying 70% stenosis. What is it? You think it is area or diameter? Generally, we express it in diameters because we see two-dimensional structures. But if you imagine inside by imaging, by intracoronary imaging, IVUS, that's where we get circular areas. So in one view, it is tight, looks tight. Other view, it looks mild. That means the lesion is eccentric. We know it very well in left mains. When you are covering the imaging topic, we can see more. Why this 50-70% has become important is, I think, this physiological principle. Beyond the 50%, less than that, it doesn't become physiologically important. 50 to 70, that's where it starts ischemia. And if it's less than 90, that's where at rest also you get into ischemia. That's why that is the basic of 50-70. Somebody asked you in exam, I think one of few of the candidates founder. That's why I thought I'll mention this. Then also how to overall prognostication of CAD, whether it's single vessel, double vessel, triple vessel, is all came from this original CAS data. If a patient has left main and triple vessel disease, prognostically is more bad. And type A, B, C lesions, I think many of you are aware. Nowadays, it's becoming less and less important because even the worst type C lesions with the availability of good calcium modification techniques and other things, we handle all the things. But type A lesions, again, are important, but at the same time, you get it less common. But you should be careful. Sometimes, especially if I'm allowed to permit to say this, because especially in females, when you're doing lesions, then sometimes the type A type of lesions could go into dissections and get into spasms and things like that. So every lesion has to be handled carefully, respect it. Don't think that just type A lesion, you do it off in 10 minutes and come out. That place is I keep telling cath lab is a graphic equalizer. If you think too much of yourself, next day something happens. So please respect each lesion and try to do good to each of these lesions. And then don't think doing stenting in mild, moderate lesions is easy. You land in more complications when you're tackling that. I am not advocating to do it, but some people, if you think that straight away you do it, there only you land in more trouble. Tight lesions, generally human body, you can't do it more tight and worsen it. That's why you can do it all right. Then finally, when you say nowadays we write even the institutes, I'm sorry to say this, they scribble something and they don't give proper report. So what is to be commented is if a case is surgical, the number of vessels, branches, divisions are to be important, and the quality of distal vessel becomes important, and details of each of the stenosis becomes important, LV function becomes important. Angioplasty, then course and the type of lesion, then what is the morphology of the lesion, all that becomes important. So keep all this in mind and express the diagnosis properly and when you're giving the final report. And syntax score, if somebody has a habit of writing syntax score, it's good, you can do it. But syntax score is not the total sanctity of everything. It has its own limitations because sometimes it ignores totally smaller, thinner vessels, and sometimes dominance is not properly addressed. But it's okay. But if you have the habit of writing it, it's okay because even it's becoming less and less important because mild, moderate, even the mid-tier child, you are doing everything. So a word about graft angiography before I close is basically whatever catheters you're comfortable with, you can do it. But by and large, JR catheters helps in most of the things. If you have a specialized catheters to hook grafts, it is good. And then when you inject, actually contrast, if nothing fills, that means it's good. The grafts are patent. This is the dextrocardia, again, the principle of double inversion is what is applied. I think with this, I'll not, time is up. I'll stop here. Then probably as access sites and all we can discuss later. After Madam covers the talk on drug-eluting balloons, I would come up again to show some of the tips and tricks and some details and tell you about what are the basic material which should be kept in cath lab and what are the saviors in some of these procedures in cath lab. I would cover up once Madam talks about balloons. I think if you have any doubts, if you thought I was too basic or some things which are missed, feel free to discuss. If you want, we can have some discussion now or after the end of the other two talks. Thank you again for patient hearing. Anything else you have in mind, we can feel free to talk. Thank you. How many of you sitting here, honestly, because we also want to learn from all of you, how many of you sitting here thought this lecture was totally waste and you didn't learn even single point? Raise your hands, please. Then it becomes, we have to modify ourselves, that means. Eh? How many of you feel at least you have learned one new point in the lecture? Yeah. Oh, I'm happy. Huh? Thank you. So you don't do that for the sake of impressing me, because what I'm saying is each of you are sparing your valuable two days time. Lupin is facilitating, that is different, but each of our time is important. I always want to give value to time what you sent. That's why whatever I thought is important for youngsters, I thought I would cover. But some of the things which I highlighted also, don't mistake me. All the real world scenarios. Especially with radials, some shots are taken, patients are sent for the intervention, things like that. Please avoid it. At least when you are taking a patient for angiogram. The axis thing, I will also cover up how to give up or do a proper angiogram without causing pain to the patients, because patient is important. Finally, they're not objects. And I see patients, there's no prestige in doing only radial. So patient is saying, crying with pain, and people are going on trying. That's also not good. So you have to other important thing in angiogram is to perform the procedure, painless procedure, because our cardiology, by and large, we don't want to give pains like surgeons, if I'm allowed to tell. So we need to do a good job and at the same time get the complete information before the patient is taken out on the lab. So that's why some of the things which I thought are important, I'd cover up. And then regarding the sites and some of the materials, I would cover up. I would probably shave some time, if Lupin permits me, from the Inclisiran talk and use it to show some of the absolutely essential material which are to be kept in cath lab, because after you pass out again, you need to maintain your own inventory. I'll show that. With this, I'll stop and I request Madam to take the next talk. Thank you.
Thank you so much, sir. Next, I would invite Dr. Chabi Satpathy. Can we have the CV, please? Yeah. So Dr. Satpathy is the professor and HOD for the cardiology of MKCG Medical College. She has been the CM awardee for the lifetime achievement and also the governor awardee with Rajya Puraskar. She has various research articles as well as case reports. Ma'am would be taking the topic of cath lab toolkit for PCI, guide catheters, wires, balloons, and stents. Over to you.
That pointer. You can take out that pointer also. Okay. So a very good afternoon to all the faculties, the students, and of course the supporting staffs too. So I'm dealing only with the drug-eluting balloons and PCI. This has been a little changed. I'll be talking only on drug-eluting balloons and PCI. So these balloons has been considered the fourth revolution in interventional cardiology. The first being a balloon dilatation, the second is the bare metal stents, the third is the drug eluting, and the fourth is the drug-coated balloons and BRS. Now, why at all drug balloons? Now, we have seen on following up the patients of stents, they used to accumulate mace over years. Annually, the mace being 2 to 3% goes on increasing beyond 5 years, which is not seen with drug balloons. With drug balloons, the mace of initial 2 to 3% annual that flattens off, plateaus, and it doesn't increase like the drug-eluting stents, so the interest arose. Now, what exactly the specialty? These are semi-compliant balloons made up of polyurethane and nylon with a matrix coating of lipophilic drug along with a hydrophilic excipient or spacer. This excipient transfers the drug to the vessel wall upon dilatation of the balloon so as to reduce the quick loss of the drug from the balloon surface into the circulation. These drug balloons, they are not having a class effect. They vary from balloons to balloons. And drug transfer is possible at a concentration 100-fold higher than possible with systemic administration of the drugs because locally delivered. However, 20% of the drug coated goes from the balloon surface to the vessel wall and 80% flows down the circulation. However, this much proves sufficient for the therapeutic effect of the target lesion. So we have various methods of coating the balloons. It could be spraying onto the balloons. It could be dipping the balloons into the solution of the drug, could be micropipetting, could be nanoparticle coating over the balloon, or could be drug imprinting. So we are now having innovative technologies gradually to improve the efficacy of the drug balloons. Now, what are the advantages versus that of plain balloons? They need a shorter duration of DAPT compared to the drug-eluting stents, so preferred in high bleeding risk patients. These anti-proliferative drugs are delivered without leaving any permanent metallic prosthesis inside the vessel, neither any polymer inside to carry the drug, so no allergic or hypersensitivity reaction, so no accelerated atherosclerosis. Once you put a stent inside with a foreign body, the fluid dynamics is changed and there occurs turbulence inside the vessel. So with the drug balloon, we do not modify the fluid dynamics, so no chronic inflammation. They do not occupy any precious space inside the vessel. So small vessels, we prefer a drug balloon rather than posting another stent into the small space. And we enable performance of bypass in the concerned segment in any time in future, unlike a stent in the segment. The vasomotion of the concerned segment remains intact, and there occurs a luminal gain of the concerned segment with a DCB. Unlike a stent when implanted, there's no chance of gaining the lumen area. There's no concern for underexpansion, malapposition, or strut fracture, which is specific for the stents. There's no stent thrombosis or instant restenosis. We are leaving nothing inside the vessel like your bioresorbable scaffolds. And important is the delivery of the drugs is too uniform and homogeneous compared to the stents. If you are putting a stent, the drugs are only on the struts, and we deliver drugs non-homogeneously into the vessel wall versus that of drug-coated balloon where the drug is there coated uniformly across the balloon, unlike the struts. Now we have two types of drug-coated balloons, paclitaxel and sirolimus. What is the pros and cons? Why we have a robust evidence on paclitaxel balloons? Can the sirolimus replace them? Now, paclitaxel balloons are highly lipophilic drug-coated balloons and smaller molecules. They irreversibly bind to the vessel surface. So they are absorbed quickly. They persist on the tissues for a longer time, for weeks together, for a single application of a balloon. And these are robust evidence-having balloons. However, they too have their own disadvantage. They are cytotoxic drugs. So more inflammatory, there occurs a delay in the healing, and there's also a mortality concern which is now disappearing. And these are crystalline coated balloons. The safety is relatively less with a narrow therapeutic range. And the drug we deliver is only there in the subintimal space. However, when we come to the sirolimus balloon, the advantage they are cytostatic, so less of inflammation and faster endothelialization without a concern of mortality anytime in the history. Now, amorphous coated balloons, some 10,000 times more safer with a wider therapeutic range. And the drug we deliver is throughout the arterial layers, unlike the paclitaxel, which usually stays in the subintimal. However, we do not have more evidence like the paclitaxel. They are recently developing with innovative techniques. They are moderately lipophilic drugs and larger molecules, so they reversibly bind, absorb slowly, and the concentration falls off quickly. So with these newer innovative methods, now we are having balloons which are equivalent to the paclitaxel. What is the optimization technique? The drug balloons we select has to be at a ratio of 1:1 to the reference diameter. The length of the balloon that we select has to be minimum 4 to 6 millimeter more than the balloon you are using for pre-dilatation and the preparation of the lesion to cover on either side. The balloons once enter into the vessel should reach the target within 2 minutes. And the time from onset to full dilatation of a drug-eluting balloon should not exceed 25 seconds at the site. This device is not meant to open the lesion, just to deliver the drug. So at nominal pressure you apply, and you should maintain the full inflation minimum for 1 minute. In intolerant patients, at the least for 30 seconds can be acceptable, not below that. And the inflation of the drug balloon should be slow here compared to the conventional balloons so as to avoid any dissection. Now, before applying this drug balloons, the lesion has to be optimally prepared. We should know whether the result achieved is acceptable or not. So what's the definition of acceptable result? There should not be a flow limiting dissection at the site. There could be dissection, but it should not be flow limiting. And the residual stenosis should be less than 30% at the site. If we are not very much sure about this, can go for FFR to see that it is beyond 0.75. If it is acceptable, go for a drug balloon. If it is not acceptable, you can try with the drug-eluting stents or at best with a vascular scaffold. Now, what are the latest evidence? Now, these evidences are for only last 3 years I have collected in a tabular form. For instant restenosis from the SCAR registry, so 9,000 odd patients followed for 5 years, the DCB is all the same as DS, except that the target lesion revascularization is better for DS, but otherwise all the endpoints are same. When we go to large vessels, now we see they are all safe as the DS. However, we do not have a robust trial to compare head-to-head DS versus DCB in a large vessel. However, the TLR is all the same. Now coming to ACS, can we give a DCB? Now meta-analysis of 2,000 patients in 24 showed, yes, in ACS also, DCB is all the same as the DS considering the miss. And the sub-analysis in STMI patients also the same miss for both, except that you should not have a large burden of thrombus at the area. In bifurcation lesions, so when you are considering the large vessels, all the same. Now coming to bifurcation lesions, DCB are found to be much better compared to the uncoated balloons. So when you are dilating the side branch, prefer a DCB versus that of an uncoated balloon. And with Hers et al. Study showed that when you are applying a DCB to the main branch, yes, you can apply to the main branch, but the major advantage, if you're applying a DCB to the main branch, the area of the side branch ostium gradually increases over 9 months to 76% of the baseline. In the small vessel diameter, it's always better to give a DCB versus that of DS. The mass is significantly reduced. In CTOs, you can try with a DCB-based approach after opening, the proximal being a stent and distal DCBs. Multi-vessel disease, DCB-based approach depending on the caliber. And in high-risk patients, including diabetes, the mortality is also significantly reduced with the DCB compared to the DES. These are all from last 3 meta-analysis, up to 8,000 patients followed for 1 to 5 years. So this is a patient, 65 years old, male patient, obese, smoker, hypertensive, and dyslipidemic. He had 3 times PCI in the past, with 3 layers of stent in the LAD and 1 layer in the diagonal. So again had chest pain for 2 months, NIHA class 3. There was little ST depression in the anterolateral leads, no hypokinesia of the area, and the ejection fraction was maintained. Of the patient had class 3 angina for last 2 months. So this we found the patient is again having instant restenosis of the stent deployed to LAD along with some stenosis of the stent deployed to diagonal. So 3 metals layers are there in the LAD and 1 metallic layer on the diagonals. So he was interested what to do next. It's always better to go for bypass surgery, but if you don't go for bypass surgery, the only option left for us, a drug balloon has never been given to you. We can try with that. So we give a drug balloon to the side branch, diagonal, after pre-dilating lesion with INC balloon. And then after modification of the main lesion in the LAD with a scoring balloon, we give a drug balloon of 3.2514 in the LAD. And this is the final picture following drug balloon to side branch and drug balloon to the main branch. They're still in the diagonal ostium, there's some stenosis of 50 to 60%. Should we meddle with it or we leave it? So what is the literature saying? From Indian Heart Journal 2022, if there's a pinching of the side branch ostium after application of a DCB to the main branch, there's no need to pursue the side branch ostium because it may increase with positive remodeling with a DCB. And if you are trying to give balloons to both side branch and main branch, it's always advisable to give a drug balloon to the side branch followed by to that of the main branch in case there's an indication to give a balloon to the side branch. And the DCB consensus guideline says if there's no flow limitation down the vessels in either of the lesion, either main side branch or main branch, if the flow is not compromised, there's no role of kissing balloon inflation. So we left the patient and patient is better for last 1 year. Now coming to the next patient, this is a patient 40 years old male smoker with chest pain for 1 day with some ST elevation in V1 and loss of R in the anteroseptal leads with ejection fraction which is borderline with hypokinetic LAD territory. So we did the ECG, we did the angio and we marked the lesion in the LAD. LAD lesion were very significant, but starting from the ostium, we do not have a landing zone there. There's also disease of the second diagonal ostium. So after preparing the diagonal with a balloon, we gave a drug balloon to the side branch. Then we gave a stent after preparation of the main branch with a DEB of 336, which crosses from left main to LAD. So stent, crossover for LM to LAD, and drug balloon to the side branch. And this is the final lesion, the final picture of the patient, and patient hasn't returned till now. Now coming to small vessel disease, a patient of 53 male diabetic with chest pain for 3 months with NIHA class 2, though the engine was little raised, the ECG was absolutely normal. So this patient, we did the angio, we have seen only a small discrete lesion in the distal LAD. There's no further any significant proximally. So after preparing the lesion, we gave a drug balloon without any stent in the distal LAD, the diameter being around 2 or less than that. And the final picture is like this. No stent, the patient returned. Now, what is the role of the stent length and diameter cutoff for future cardiac events? How much caliber is safe? How much length is safe for us? Now, coming to this 2019, studies are all pooled, and they showed that if you are taking the target vessel failure, target vessel revascularization, the incidence of MI and stent thrombosis, the purple color says about the overall, what is the length you require and you should not go, what's the caliber you require, it should not go. So whenever the length is exceeding 40, there's more of miss. And when the caliber is coming below 30, there is more of miss. So we are very safe when the stent length is up to 40 and the caliber is above 30. That is from this study. So this patient who is 60 years, a diabetic male with chest pain for 14 years, ST elevated in inferior leads with 2 more than 3, with AVR showing significant depression. There's some hypokinesia of the L6 territory and the ejection fraction was borderline. So this patient, we did angio and found the patient is having a stump in the LCX. After little balloon dilatation, we could see that it is in the OM, there's a discrete lesion, and the lesion in the proximal LCX is a long lesion. So after preparing the OM with a balloon and putting our DEB in the OM 2.2512, preparation of the proximal LCX with a stent length of 2.75 into 36. So the proximal LCX stent was around 36. So we're not interested to go beyond 50. We gave a drug balloon to the distal OM, and the final picture is this. So this patient hasn't returned till now. Now coming to, if the drug balloon is causing less of bleeding because of less of duration of DAPT, can we do with a single antiplatelet agent instead of a dual antiplatelet agent? So this study of 2025 with a prospective Eastbourne registry has showed that the total number of patients around 2,000, some 1,800 in the DAPT group versus 100 in the SAPT group. They have shown that TLR is all the same. Even also in these patients of DEB, we are giving a single antiplatelet from the beginning. The TLR is not high, rather the bleeding is less. Now, whether the sirolimus coated balloon will replace the paclitaxel, which is having a robust evidence till date. Now, initially when the stents came into market, the sirolimus eluting stents were much better when we consider the MACE and the target lesion revascularization compared to the paclitaxel eluting stents. The paclitaxel eluting stents that disappeared from the market. It's all flooded with limus eluting stents. So then they came with an innovative method of coating the balloons with sirolimus, and they came that the drug eluting curve is all the same like sirolimus eluting stents. And now we are having all balloons coated with sirolimus. So this is a meta-analysis of 2024, where the paclitaxel coated balloons are doing the same as that of the sirolimus coated balloon, or they are still superior. So after searching all the studies available up to 2024, some 2,000 patients were available that had compared PCB versus that of SCB and followed for 1 year. They showed among patients undergoing DCB only PCI, the risk of TLF is all the same, whether you are giving a PCB or you are giving sirolimus coated balloons. However, little minimum luminal diameter were larger for PCB, but events, rest all events are all the same, whether you're giving a paclitaxel coated or a sirolimus coated. Now here at MKCG, we just started from the time when we started with the drug balloon. We have started for last 2 years with the drug balloon. From that date, we just found out how many stents we are given and how many balloons we have given. Now, within that period of around 2 years, we have given 491 stents and given total of 173 balloons. And these drug-coated balloons are almost equally distributed. Some 60% are sirolimus coated and 40% are paclitaxel coated. And how many patients have returned back? Of course, we are not in touch with the telephonic conversation, but out of the patients, 1 patient in stent group have come back to us with in-stent stenosis at the edge of the stent in RCA. So it was sirolimus eluting. We gave an eluting. However, out of the total balloon PCI we had done with the drug coated, none have returned over the last 2 years. So what's the take-home message? Till now, recommendation is limited to in-stent restenosis and, so to say, small vessel disease. It's being tried with good outcome in large vessels de novo, in bifurcation lesions, in high bleeding risk patients and patients with high risk and diffuse multivessel disease. Particularly in Asia Pacific region, it is expected to play a pivotal role because we are having more of small vessel disease, multivessel disease, and diffuse disease. But challenges still persist. Whether we can give a DCB in unstable angina, can we dilate without giving scaffolding? And whether we can give it in a tortuous vessels or in calcified lesions where the drug cannot be delivered uniform. New generation BRS may complement the DCB for a full metal-free PCI in future. Proximal BRS, distal DCB. At present, DCB-based approach with or without a DES in the proximal bigger branch may suffice in the clinical situation. So it would be better to conclude that a lot of stent should not be used when a little will do for your patient. Thank you.
I think, thank you for excellent talk on DCB, madam. I think you are a very passionate user of the DCB. I think that's how it shows in volumes of DCBs which are used. But I feel, this is my personal impression, it is unfair to compare DCBs with the DES because regulating stents as platform, the how they work is all different. And then where you can always use a regulating stent, you can use a regulating stent. Where you feel there's too much metal is going to happen, where you cannot use a regulating stent, like difficult to stent scenarios, is where I think you can be comfortable using a DCB. That's a personal. Personally, I follow that approach, and when you can do the job without many metal, that's good. But always stent have a different mechanism of scaffolding action. It prevents dissections. Many of the times, though Antonio Colombo recommends a lot of dissections even left with DCBs, as youngsters, they're worried. I requested Antonio to put a position statement on this because many of the times he recommends leaving dissections. Any youngster passing out does a proximal disease, a dissection, he leaves it, the patient gets into trouble, then his career is finished. So that's where I think there are challenges in using DCB, but I think the role of DCB is very evolving. But as of now, I think definite indications where is, as Madam presented, where already have a 2 layers of stent, where you don't want to put a third layer, instant restenosis, you have no choice but for using a DCB. And then thin, long, diffuse vessels where you cannot stent it, again, that's a role. Third important thing which is coming up is a bifurcation lesions where you stent the main vessel and the branch could be treated with the DCB. That has become, the bifurcation therapy has become very simple. Nowadays our approach, but for left main it is different. But again, if your LED diagonals and OEMs nowadays put the stent in the main vessel, then do DCB. The madam showed one case examples like that. And third, other important thing what we need to say, as already highlighted, sake of everybody, I'm repeating, you use it to deliver the drug, that's all. It is not a replacement for balloon. Bed preparation is optimal and you need to do whatever you want to prepare the bed and then deliver the drug. Another important place where bed preparation followed by drug is coming up is isolated LCX osteal disease. Previously, it was always a challenge. We conquered left main also, but osteal LCX disease is a big problem. Whenever you did any sort of thing, patients were coming back with LCX osteal restenosis. This is where I think we started preparing the bed well, be it Wolverine bullying, cartoon bullying, or orbital atherectomy, whatever you want. You prepare the bed of LCX osteum and then take an optimal big-sized balloon, regulating balloon, release the drug and coming out. We are just collecting data. We have experience about 10, 12 patients where entire procedure is becoming simple. That is another area where I think LCX osteal disease where we started using this. These are some of my thoughts on regulating balloon. But anything else, anybody has any doubts, madam will be happy to clear anything on regulating balloon. Any questions or comments? How many of you are exposed to regulating balloons? Nowadays, it's become very common. So many companies are coming with drug-eluting balloons. I think there's about 10% market which companies see that there could be a role, especially in young diabetic patients, diffuse disease, where you're not able to stent, and all those things are fine. But the problem comes when you face with the dissection, how to deal with it. General approach, what is mentioned for sake of youngsters, I'm permitted to tell, madam. Basically, the proximal vessels, where you feel a lot of area is compromised, flow is very like not a TIMI3 flow, that's where we tend to seal it up with a stent. If you don't have it, very distal diffuse vessel, distal dissection, even if it's longer, the flow is okay, thin vessel, that's where we tend to leave it. And where you feel, even if that is some problem, patient will tolerate, that's where I think we are leaving. But each of us have our own experiences, good and bad, regarding DCB use. Any of you want to share anything of your experiences on regulating balloon? And they're slightly more bulkier than the regular balloon. Be mindful of it. They won't just track like a regular good non-compliant balloons. They are little more of non-compliant NC, little difficult than NC balloons. So take that and repair the lesion well before you take this balloon. That's my thoughts. Any of you face some problems with the usage of regulating balloon? Good, bad, or ugly, whatever you want to mention, please feel to discuss about one or two comments we want from regulating balloons, because many of you are exposed to this regulating balloon. Madam has covered it very well. Any comments or questions from anybody?
Good
Can you
afternoon,
get
sir.
my other
Yeah.
talk here?
Srinivas,
Yeah. Subject.
Srinivas, most of the things you have already covered for our students. One important thing is that, madam, the drug-eluted balloon or drug-coated balloons are already recommended for the small vessels or the diffuse arteries, or where we cannot stent the arteries. But the role of DCB is not yet established for the main vessel or the larger vessel. So that needs to be, very important aspect. We need to deal this thing.
The large vessel, only place where you are using a bigger sized balloon is LCX ostium, where again stents are not able to do good job. So wherever you find it difficult to place stents, or wherever you find the results are not optimal with stents, that's where I think DCB is being tried. That's by and large.
All right. I fully agree with Dr. Sir and Dr. Srinivas. This is still now useful only for the small vessels, for instant restenosis with multiple layers of stents. And in patients who are having a bifurcation lesion, we find very useful rather than giving a 2 stents into a dedicated bifurcation. We just open the ostium of the side branch and give a stent to them. These three are the useful conditions in fine. The rest of the condition we are not giving till now. This is what the literature is saying up to 2025. So till now, every fourth is a drug-coated balloon for us. Every 3 stents, we give the fourth as a balloon. 25% of the all PCI are a drug balloon now. Thank you.
Oh, that means quite aggressive usage of DEB, madam. In our place, I think we use about 10%, and then probably.
Hello, sir.
Please.
Hello, sir.
Ma'am, what bailout procedure you follow?
After dissection of the
Yeah, bailout, you have to prepare with a stent. You have to be prepared
So
with a
what-
stent
what
for
will-
a bailout stenting. Yes, right.
What will be
Unless
the criteria for the bailout stenting?
if the patient is not having a TIMI3 flow down that artery once you dilate, and the T4, 5 grade of dissection over there, and still you are not able to open, and the stenosis is still after preparation with a balloon, normal balloon is 50% is not opening up, you cannot give a drug balloon there. So if you have a target lesion which is acceptable, then only a drug balloon. You don't open the balloon unless you are very sure a lesion is well prepared.
Ma'am, if patient had disease in 2.25, let die of 2.25 mm vessel disease dissection disease in 2.25 mm, and during after DEB patient get a dissection, then what should be done? If it is very small, where we choose to do a DEB, and after DEB he'll get that dissection and TIMI3 flow is not achieved, then what we can do further?
What is the caliber of your vessel?
2.25, let 2.25.
Yeah, up to 2.25 stents are still available. Stents are too available, but below 2, you have nothing to do. You're just dilating and coming back. Now, if the vessel is too large,
Yes.
supplying a greater area,
Yeah, ma'am.
the good caliber, you have to be very mindful whether the balloon is doing a good thing or have to go a stent. Up to 2.25 can try with a stent. If there's a dissection, if you are not prepared with a balloon, then you can try with a stent. No problem. You can say 2.25 stents are available. Right. Thank you.
Thank you so much, ma'am. Please give a loud round of applause. I would request Mr. Indrajit Bhaumik to please hand over the memento to Dr. Satpathy. Can we have the memento, please? Over to Dr. Srinivas sir for reducing risk among ASCVD patient focused on newer LDL cholesterol lowering therapies.
No, actually, we wanted to cover some of the other cath lab material too. So I'll briefly take 10 minutes to cover that, and I'll cover up the time of from my lipids talk. I think all of us know this great man, Werner Fassmann. I thought you should pay respects to this, and probably Grundzig also for doing angio. This is the first angiograms came here. The cross section of catheter, guide catheter is again important, slightly built differently. We need to all understand this. And then this concepts of French size is again important for youngsters. How many of you are aware of radial sheaths, which is actually 6 French? You can take the 7 French catheter inside. Have you heard of that? Slender sheets, huh? That is a term. All of you become comfortable with usage it, but many of you, if you're in the habit of reusing it, that's very flimsy. It doesn't come longer. So, but if you're doing a radial procedure, 7 French catheter, that's a great method to do it. So keep this concept of inner ID versus outer ID. So if you make this thinner, then probably the inside lumen becomes more, is it not? So once it is done, you think, why we didn't do all these years? That's how the research comes. The outer French is 6 only, but the inner thickness is small, very thin. That's how inside it can take a 7 French catheter, 6 and 7. So colors are coded again, are different. And then this is a concept we need to understand. That's how this helps in doing a complex PCA even through radials. Side holes, again, generally a side hole catheters are given up because it creates a lot of contrast and gives a safe feeling. Even if it is damping, still you don't get the pressure traps. That's why it is less and less used. But suppose you have osteal disease where you have no choice, sometimes you can use. Some of these common catheters, you all know about Judkins catheter, saving catheter. Judkins is the person. And this a word about this. Suppose you are taking a catheter, if a catheter is not reaching this place, it's coming only till here. That means what? You have to take a little bigger size catheter. So that is our conceptually you need to understand that how to increase it to JL 4 or 5 versus taking a shorter catheter. If the catheter is going too deep here, that's what happens with the optitar catheter when you're doing through radial. Oftentimes you need to ask the patient to take deep breath because the right coronary is little low. That catheter is prepared with a bigger length so that you put the right. So that's why when you're engaging on the left, you need to ask the patient to take deep breath because this becomes shorter. So these are the conceptual things. Suppose the catheter is going too deep down below, that means you have to take a shorter length catheter. If it's too going above, you have to take a bigger length catheter. That's a concept of JL. I think many of you know about it. And then finally, you are not able to hook it. Welcome, Pramod. Finally, you are not able to hook it. What is the savior catheter for you? You are not able to engage left with the routine Judkins. What method you follow in your labs? Yeah. Many of you sometimes in the radial field, you're taking JR 4 French catheters and trying to hook with a shorter loop. But by and large, what we follow is some people have the habit of taking amplitzers, but amplitzers are difficult to handle catheter-produced dissections. So what we take is 5 French XBU catheter. That is a very user-friendly catheter. The tip is more longer. It goes and selectively hooks the left. Many of the times it is savior. That's why some of the must catheters, I would say, to keep is extra backup XB3 5 French catheter. So this is a concept, too long, I said, too short. That's how you need to understand. Depending upon the diameter of the aorta, you check depending upon which 3, 4, 5 French. Some of the things, this is what I was mentioning. 3.5 5 French catheter, guide catheter helps to hook big savior in many difficult anatomies. High takeoff, not able to hook. There's radial spasm. All these times it helps. And it's a very soft tip. Even if it goes a little deeper, it is quite excusable. I'm not recommending it, but it's helpful. Amplitzed catheter, various loops is beyond a scope. The time doesn't permit us to discuss all these details. But again, safe to handle. How to get the catheter out? You push it so that the catheter comes out without producing dissection. Same thing with right. Withdrawal of Amplitzed catheter, again, is a technique which you can have some discussion. The extra support catheters are very useful, especially to do calcific lesions, and that's how the angioplasty we started JL catheters given up and extra backup guides are common. Then multipurpose catheters sometimes come. Why it is also important to learn is till you pass, these things are asked in exams. And then even in the Viva voice, they'll ask you to pick up and probably do it. From the right, some new advancement has come in this 3D RC catheter, where you want a better support, probably you can do it. If the angulation is a little high up, then you can take a hockey stick catheter to do it. I'm trying to cover everything very fast. Excuse me for that. These venous grafts are hooked with those, but many of the times it's not available. Same JR catheter helps. This is a standard safety techniques. I always keep telling about it. Please check the pressure. Please aspirate. See that there is no air, and then flush it frequently so as to avoid the clotting finding. And observe for damping. Again, never inject with a damped catheter. This is again second or third time I'm mentioning, because I've seen worst complications happening. Then dampening pressure, whether it is happening with the deep seating of catheters or because of lesion there, we need to observe it. And then probably how to undo it, untorque it, this I've covered in my earlier talk. The stabilization of guide catheter is again a technique where patient catheter is going in, coming out frequently. How do you do it? Use your buddy wire, use appropriate sized guide catheter to stabilize it. You have your own things. But again, you need to get the catheter stable so as to anchoring technique and other things which are described. So this guide catheter selection, various methods are available. Again, I don't want to dwell too much because of the sake of time. But again, all the things are described. The radial catheter, again, many of you know. Previously, we used to think that doing a radial angiogram was taking more time. How many of you agree with me that once you change to radial, the procedures have become very fast now? We can do 20 cases in a cath lab, where when we were fellows, at least in SGPJ, used to press hard, a lot of time used to get wasted for femoral, all that is gone. So, but initial times, it looks like it might take more time, but once you become comfortable, anything happens is always good for the patients. Patient go, and then many of the times I see, once I finish the next angiogram, patient will have the file and coming, is ready to go. He's saying, what happened just now I did, that patient is saying, I'm fine, I want to go, doctor. So that sort of thing is all became possible with radial. I'm not advocating it. So, but it's a great thing that radial angiography has happened. Then some of the other things I wanted to just mention to you regarding the height, that is another thing. Grafts, it's okay. Choice of catheters, catheters are preferred, especially when dealing with CTOs, calcified lesions, tortuous arteries, and then guide catheters. This is better support catheters. Always when you're doing a 2-stent technique, preferable to take 7 if you're doing radial, 16-7 technique, and probably everything new catheters are preferable. If you want, then still 6 French you are using, definitely you need to take a new 6 French guide, because it becomes very difficult for an G6 French if you're handling, especially through radial or doing a bifurcation technique. Be careful with guide tips. When you're withdrawing, then it gets to get sucked in. So that's again, we need to be careful, otherwise it produces dissections at that point. So get the guide out before you're sucking the balloon back, and then always take the help of 5 French catheter to keep it available. It is a great savior. A word about wires, because it was not covered. I thought I would just briefly take 2-3 minutes to talk about balloons and wires. And then wires, again, whichever is a regular workhorse wire in your lab, please be comfortable, use it. There's no problem. But you be aware of it, which is the softer wire, which is the stiffer versions of wire, that's it. But which is a common wire which is used in our lab? Any of you can tell in your labs which is the commonest wire, workhorse wire in your lab? Sorry? Run through. All-Star, anybody uses? BMW? So run-through has become the commonest wire, huh? That's good. We also use that run-through wire because it's it has characteristics which are mixed for everything. Slightly expensive, but some of the wires, some of the labs use All-Star and others also. BMW wire, just pre-shaped wire is slightly helpful when you're wanting to get into branches, when you're not able to take up with a run-through probably. But other wires which are also user-friendly, especially in tortuous vessels, you need to have a whisper wire. And then it tracks through. Or when you're having a dealing with the CTOs, that's different. Faint tricycle, if you feel, fielder XT wire, which has a 0.09 inches, is again a great savior. So always, and if it's tough lesions, tortuosities, where you have to have better wide support, apart from buddy wire technique, you need to have a Grand Slam wire or a Iron Man wire that gives more strength. So if you have to have an inventory of minimum labs, one of its workhorse wire is good enough. Then second wire for a slippery nature is whisper wire. And then which are tough lesions, you have better support, you have Grand Slam or Iron Man wire. And then if you are dealing in next level, you're going to CTOs. Again, don't want to go into all the Gaia series, other things. Many of you would be better aware. So minimum these 3-4 wires should be kept available. Then balloons and appropriate size balloons is important. What is the commonest workhorse balloon which is used in your labs? Okay. Which is the toughest lesion where they are not lesion is not tracking? What is your favorite balloon of choice? Because it should be it's vice versa, no? We should also learn something from you. Okay. Which one? Mini Trek. Then anybody else? Anybody has used Terimo's Rail balloon? I feel Tarimo now it has before to only 1.25. Now we have 1.065. That's I feel whenever it's difficult, tough, I use that. If that's not going, then you have other things. But you have more tougher balloons to expand the lesions. But I think for trackability, I feel that is the best. And then probably if you have more tougher lesions where you're not expanding, not opening, then this is acrostack type of balloons are to be used. And the quantum NC balloons again to be used. Keep a word of caution is regarding the sizing of the balloons. Keep the size in control. When you want to open OPN balloon, word of caution, don't exceed the size. Because size, all these, some of you are taking pictures, I can give all the slides, it will be uploaded in fact site, you can get access free. I don't believe in keeping the knowledge close. Any of you will get to the slides, don't worry, Lupin will help you to get it. If you want to take pictures, welcome, but concentrate on what we are talking. In the process of taking pictures, you may not concentrate. OPN balloon, keep the size under control because again, the size exceeds, you could land in perforations, things like that. This concept, I think many of you are aware of Murray's law and the bifurcations, it becomes important. The proximal vessel, it's not coming there. The proximal vessel, again, it's important that the concept of 2/3 is okay, but you need to have some portion of stent length where you're covering with the balloon, that portion needs to be kept. The stent should be coming to that place. That is again, this concept of how to do prot is important. This balloon should not exceed. What is happening? This is not coming there. Anyway, this balloon should not. This balloon should not come beyond this point. I am not able to point it. That's where I think it's like. Stent, I think each of you are now comfortable. That itself becomes a big topic for discussion. But open cell design is what is preferred when you have a branch there. One word is about the expansion limits of the stent. This is very important for all of you have this display in your lab because what is the maximum expansion limit, especially in the era of crossover stents where you proximally dilate with a bigger balloon. Keep this in mind. If you take a 2.5 and try to expand it to 4, stent anatomy gets distorted. Not supposed to do it. Each of it is written in the stent packet also what is the maximum expansion limit. Keep that in mind and probably practice that to prevent the anatomical structure of the stents. So those are the things I thought I would briefly share with you regarding balloons, guides, wires, and stents. And sorry for running it faster because again, time is up. Then I wanted to share with youngsters this 1 or 2 minutes philosophical thoughts. The 5 A's is available, affable, able, approachable, accountable. These are things which are important to our patients. Okay. And one more thing is, unless you are available, you can't build up your practice. It's not like I feel unless you are available, you won't think. And you should be also affectionate. Happiness and progress in life is very important. It is not just the money what you're doing it. It's a mixture of all these things. And have some good mentors to discuss. And then probably each of these patients practice it better. And along with income, you should be doing good work so as to be happy. So that's how please keep patients' interest on top and priority. Patients are not commodities, please. Then avoid mortality in the initial part of your career because it becomes very important. Unless you did about 50 to 100 angioplasties, don't go for too much complicated cases because it is better to gradually build up your career and have a mentor, whomever you're comfortable with in your training, have ideas taken. Always group practice helps. Even today, the complex PCIs have always kept two operators, again, senior operators to be doing better because we can always do it better. So have some relation with something. Avoid embarrassment in the first 100 cases in the cath lab. Work-life balance is again very important. Easy to say, but each of you should evolve your own methods to keep work-life balance. Many other times my wife keeps telling me primary angioplasty left her in cinema theater. We went to do a primary with cars. They're not available again. There's a lot of cooperation from better halves are also important. Each of you evolve your techniques. My best way to do work-life balance, I feel, is to follow group practice. That's how I strongly believe we should all follow, form groups and deliver goods to this patient. And love your work and enjoy your work so that you'll be happy. Thank you again for a patient here. Now, after a good discussion, I hope you all enjoyed that. And we need to do some justice to Lupin also, because they made all of you comfortable, spent so much money. And then, but again, prevention to intervention, intervention to prevention is very important concept. So it is not that. Mm. It is important after you did a good procedure. Nowadays, it's a good antiplatelet therapy, and again, controlling the lipids well is important. Actually, I thought I will speak after the Ivabra attack, but the other doctor is just coming. So I'll share, because I've taken up some time, I'll be brief on this. But I would like to share some of my thoughts on this new modality of therapy, which is coming for lipid lowering. How many of you are aware of Eugene Braunwald's statement that how to live without getting heart attacks or coronary artery disease for 100 years? Did you hear this? No? Eugene Braunwald said this, not Srinivas Kumar. Yeah? I did recent TCT meeting. Along with that, I told about various things which are happening in the program. I mentioned this. Press, media, everybody was gaga about this. Rest all the interventions, nothing is written. They only wrote about this new injection which can make you live for 100 years. There's definitely some truth in it. I always wanted to mention, I don't know whether the slide is there, otherwise I'll show you from one of my slides. So how to make reducing the risk of atherosclerotic disease in these patients and focusing on newer LDL cholesterol lowering therapies. As you understand, in India, we do have a higher disease. And can I get that pointer? Then disease comes a decade earlier. And the disease sometimes is more diffuse in nature, and it happens in less than 50 years of patients. And an average LDL cholesterols in general are less than US counterparts. But that itself is atherogenic in our Indian population. So if you see this, many of them, you know that lipid control is important. But if you see the real world scenarios, so many of the times you fail to achieve. The achieve target goals, which are decreased now in this, the goals of going on decreasing. Can I get that pointer? Is decreasing. We all agree that high is bad. High is bad. Average is okay, not good. Lower is better. That we agreed. But even lower is even better. Lowest is the best. That's what is the data which came after the 4 years trial and the PCSK9 era, where to bring it down to less than 40. Probably when you're born, your lipid LDL is less than 40. That's where we are aiming at. And the latest guidelines all recommend that LDL cholesterol in extreme high risk should be less than 55. Indian Lipid Guidelines Association said less than 50. So that's all good, but it's difficult to achieve. No, we are not able to achieve it. What we had before was moderate intensity statin, high intensity statin. I think you're aware high intensity statin is where LDL reduction happens by 50%. Moderate intensity is 30%. When you add ST-MIP to it, it's going down to 65%. But now with with the availability of PCSK9 inhibitors, and also inclisiran, probably you can decrease the levels to 85%. Take it from me, I have seen single-digit LDL cholesterols with the advent of inclisiran, 9, 12 LDL cholesterols. But surprised, now it started decreasing the dose of statin because any therapy has to be statin plus. So that some of the newer things which are coming up for patient good again, bempedoic acid, which is free from the side effects of statin, mechanism of action a step earlier. Then this is where I think Lupin wanted me to concentrate a little on stretching on this inclisiran molecule. Because the sevelicumab, all that good, but subcutaneous every 2 weeks is again a boring thing. Inclisiran, once in 6 months shot, given significant reduction happens. What is the specialty of this? The mechanism of action is only through liver, no muscle action at all. So no muscle side effects at all. So then inclisiran specifically works in the liver, and a lot of trial data which has come up, Orient group of trials, and many of them are completed, showing that it is very effective. What it does, see this, apart from the regular therapy, statin, high dose, STMI, whatever you're giving, apart from it, they added this, further 52% reduction of LDL cholesterol happened. Great. Then when this is seen, we always wanted events to decrease. They have the further things when they try to see some small group of patients, LDL reduction happened, events also decreased. But data is more coming, efficacy, reduction of events is happening. Across the world, even in Asia, it is found to be beneficial. Then inclisiran is the side effects wise very minimal side effects. Even in patients who have renal insufficiency or liver insufficiency, still it is found to be safer. Then you see this, it's also working against LP small a, lipoprotein small a, which statins were not very good to do that. But if you see this, one more newer molecule, palicaseran, is likely to come, which is further likely to decrease lipoprotein small a, but it is again. One more good thing I have noticed with this inclisiran usage is HDLs are not coming down too much. LDL comes down, total cholesterol comes down. In fact, little increase in HDL is noted. That's a welcome thing. So you see the data which is coming in the Victorian program. So Victorian secondary prevention and the primary prevention. Primary prevention is started. The data event things are not at. Why it's moving automatically? Timed. Anyway, myocardial infarctions are also decreased. Basically, this inclisiran showed 26% reduction in MACE, and then MI strokes are also significantly decreasing. We want the more long-term data. It is coming. So early LDL cholesterol targeting without even using statins. That's what the study started in the Victorian Initiate. You might use SDMI, but without using statin also they started, which I don't think is right. Any therapy has to be statin plus. In the Victorian Initiate study, there's randomization, how it is going, then what it showed, even directly using that, there's 60% reduction of LDL cholesterol. That's how I think it is a significant reduction with inclisiran first therapy compared to usual care therapy happened. And till 330 days, it is found to be beneficial. And then acute coronary syndrome also, now we don't want to waste time. If a patient is not achieving the goals, then we want to, within 4 weeks, and probably we want to initiate PCSK9 inhibitors for rapid action, following it up later with inclisiran. This has come into guidelines also, because if you wait too longer, patients could suffer recurrent events. Then this Victorian mono study is being tried even in less risky patients, and it's found to be useful there also. I think one US FDA one I wanted to project. This is one very important for us to follow it closely. That's how such CME programs become very important. US FDA has approved as latest as July 31st. How many of you are aware of this already? That means you are quite keeping yourself appraised. US FDA has approved inclisiran injection even for this first time usage, even for primary prevention. Many of you sitting who have familial hyperlipidemia patterns, many of the doctors also sitting here would have LDL cholesterols of 200, total cholesterols of 300. We were trying to take only statins, not getting controlled. Now you have a very effective solution for decreasing your risk. Be mindful of it. And I wanted to show that slide, I think is not there. If you are controlling your cholesterol, LDL cholesterol, not going to the target level where you suffer heart attack totally, then you flatten that curve. It is not touching that level where you're getting into heart attack till 100 years of age. I'll show you one of the snippets, I think. Can you open that snippet? Excuse me. I'll show that one slide before I close. Go down. Yeah. Go up. Up. This is what which I didn't come. That's enough. I'll close with this. This is what is basically mentioned. If somebody has familial hyperlipidemia pattern, very high lipids exposure right from early childhood, he gets into heart attack. This is a threshold where you're getting into heart attack, ACVD level. At 30 years of age itself is getting into trouble. This is the average Indian which is getting into trouble, maybe a decade earlier. This is the Western data. If you're hitting that target where you're getting into heart attacks, by this age. In India, it happens a decade earlier. But suppose with inclisiran type of therapy, where you can control your cholesterols, line C, where you don't go into the target level to get into heart attacks itself, till 100 years of age, you can live free from getting a heart attacks. Please be mindful of it. If somebody who can afford it wants to take it, I think it can be taken, but I feel still it should be start in place. With this, I stop. The other doctor has come. Okay. Evaporating talk, I was told that we'll have it after the coffee break. Any other questions or comments or anything you want to ask on any of the things discussed? Feel free to, otherwise we'll break for a coffee. Any comments, questions? How many of you started in your hospitals using these newer molecules like PCSK9 or inclisiran? Oh, good. But many of the hands are not coming up. Lupin needs to act a lot, I think. Yeah. So, but personally, I was part of that trial of Novartis before this is launched. We had some experience there, found very useful. Later, this is launched. The only problem is the cost of it. The cost is too much, but if the cost is not a factor, if somebody wants to take it, as efficacy-wise, is too good. And safety-wise also, I think even in, I was on the board for Novartis. They took me to one doctor who has used in 700 patients in Dubai, Abu Dhabi, all the things, everybody is covered with this insurance. The government provides. The 700 patients were treated with inclisiran. They found it to be quite useful. Then that's how we all started taking it more. And I'm a very strong believer of aggressive reduction of lipids, which helps, which was, doctors are again poor patients. Many of us who don't like to take tablets daily. In that setting also, you can take the help of this molecule, take once in 6 months injection and fill it, shut it and forget it types for 6 months. And then in Indian scenario, probably each of the drug we give it a little longer. So probably once in a year also could be working with small dose of statin. We need to have the data. PCSK9, we are not giving every 2 weeks. We're giving once in a month. Like that, probably if it works once in a year, I think company now they give a scheme where 1+1, one thing is given, other thing, they should be talking about it. I should be thanking Lupin for anybody taking that molecule. They give antiplatelet, statin, other things, everything free, I believe. So that's quite appreciable and thankful to Lupin for this. And with this good news, we'll break for coffee. We'll assemble back in 15 minutes.
Yes.
Thank you.
Thank you so much, sir. So we'll have the coffee break now for 15 minutes and then we'll assemble back.
Charging and also. QR. Sandhu. QR.
PPT, right? There is one PPT and PDF. No. Outside.
This one?
You were right. That was PPT only, na?
Yes, sir.
Normally I keep both the PDF.
problem the backup
कधी ना
open होत नाही
आणि पूर्वी खूप व्हायचं ना की PowerPoint 1990 and suddenly color theme change व्हायची.
ते formatting पण बदलून ना
So then letters would go out of letters would become white on white.
I'll just take the
एकच
backup.
करतो. पण कधी काय असं
हाँ मैं एक मिनट बैकअप ले लेता हूँ बस.
comfortable झाली.
Yeah, it was comfortable. You got to get up.
डॉक्टर राजीव कर्णिक.
Tomorrow I have this no, busy day on also because of this ESC also I'm going to. Oh, I have some working day. I have to get up, start from here at 3:15. 4:15, I think I'll reach there. 5:15 boarding time. So thank you so much.
ते
हा.
करून support.
And this thing, sorry. The major point.
Welcome back, everyone. I would request everyone to please take your seats. We'll be starting our next session. So for the next session, we have Dr. Rajiv Karnik. Can I have his CV slide, please? So Dr. Rajiv Karnik is Director, Heart Failure Clinic and Interventional Cardiologist at Fortis Hospital, Mulund. He has a unique distinction of topping all the University of Mumbai for and securing 6 gold medals. He has been awarded the Commonwealth Scholarship in UK. He has also been invited at Mayo Clinic, USA, Fellowship of European Society of Cardiology as well as FSCI. He is a premium professional member of AHA, member of CSI, API, and various prestigious bodies across India, as well as the prestigious body of ACC. And he has also been bestowed the Rashtriya Ratna Award 2002. So Dr. Karnik is going to take us through the significance of heart rate management in the evolving era of GDMT in heart failure. Over to you, sir.
लेजर पॉइंटर भी बनाया था ना जरा can you print for me? Yeah, I think this is. Good afternoon, dear friends. First of all, let me thank Lupin for providing this opportunity in this fabulous city of Hyderabad. It's a great pleasure to be here. Now, what we are going to, I'm going to cover in the next 20-25 minutes is heart rate management with ivabradine, not with beta blocker, with ivabradine in heart failure with reduced ejection fraction. Dear friends, you know this heart failure is a deadly disease. In CHARMS HF, you will find that 9 out of 10, 90% were symptomatic. In CHARM registry, 1/3 people required hospitalization, and each hospitalization brings the person nearer to the death. As you can see here on the right-hand side in the US military group of 51,000 people, the mean survival, just with one hospitalization, the person lives, his average life survival is about 2.5 years. 2.6 years, and with every next hospitalization, it's becoming lesser and lesser. Just to summarize this previous slide, heart failure is extremely prevalent as on today, because that is what I had heard in Cleveland Clinic from the stalwarts, that the money spinner for Cleveland Clinic for their new building was, like in 1960s, it was bypass surgery. In 1990s, it became plasties and stents subsequently. But after medicated stent and arterial grafting, everything became dwindled. All these money spinners went away, and they had only heart failure management, and AFib ablation was the only money spinner for them. And so it is deadly, it is costly. And especially in India, it is even worse. As you can see here, between the global scenario versus Indian scenario, the mean age of presentation is 73 in Western population versus 53 in Indian population. Mortality, 3.8 in Western in-hospital mortality versus 30% in India. So it is extremely, I think, fatal or malignant, especially in Indian scenario. We spend a tremendous amount of, I mean, there is not we, I mean, the patients spend share tremendous amount of fear in acute coronary syndrome. The moment the Gray score is more than 140 or troponin is positive, everybody rushes for angiography, angioplasty, and then with multiple devices inside. But the worst case scenario in SCS with Gray score more than 140, and if you give the extreme high risk, yeah, as you can see here on the left-hand side, this is the SCS group. And then this is Stephen Green's slide. And then he has said that much above that begins the lowest risk case of heart failure. And then the mortality is that higher. But the good part in heart failure is there are good therapies right now, and then with which you can see the conventional and comprehensive treatment, the survival rates are significantly different, with gain in years of life to 6 and 8 years between the two. In fact, till 1986, we hardly had anything for heart failure management, apart from digoxin, diuretics, so on and so forth. But 1986 onwards, we had a plethora of different drugs. The first in 1987 consensus, the North Scandinavian enalapril trial came, then SOLVD and SAVD in 1987, 91, 92. The ACE inhibitors became the first pillar in the heart failure management. Then in the last decade of this previous millennium, 96, 99, and then going into the comparison of Copernicus with carvedilol, the beta blockers became the second pillar for heart failure management with very good amount. And the background therapy, if you see the ACE inhibitor 95%, ACE ARB 95% in all these beta blocker trials. So with background therapy of previous pillar, then we were seeing this great result. Then the third pillar came, and then that was aldosterone antagonist. The spironolactone RALS trial came by Bertram Pitt in INIGM 1999, which showed a huge reduction, about 30% relative risk reduction in severe heart failure. And about 12 years later, this Faiz-Zanart's emphasis HF came with mild heart failure, and that also showed 24% relative risk reduction. And then there again, you will see the two previous pillars were already existing. ACE inhibitor 94, beta blocker were less in the previous this thing in 90s, 95, because by that time, beta blockers had not become this thing important part of the management. But in Faiz-Zanart's this thing trial, you can see that 87% were in on beta blockers. And the real game changer came in 2014. And then that was LCZ as that at that time as it was called as LCZ 696 or our ARNI as on Weimar Asmarda or whatever you call it. So this LCZ came and which was shown with comparison with enalapril, which showed additional 20% reduction in the death and various endpoint, all the endpoints we are seeing. And then 5 years later, the dapagliflozin came and empagliflozin immediately after that. And then that also showed that with all the previous pillars are existing in the blue bar and the green bar is with this SGLT2 and that showed additional again 20-25% relative risk reduction. So that made these 4 pillars extremely important and in the management of heart failure with what we call as fantastic 4. And as you can see here that as the number of pillars are going on, adding the mortality is reducing. And there are different meta-analysis done. And this is, I think, by Jasper Tromp from Singapore, but even Greg Fenero and various other people have also done this kind of meta-analysis. And as the number of pillars go on getting added, then there is incremental better and better benefit in terms of mortality. But having said this, we have such great treatment for heart failure. I mean, have we conquered the illness and are we getting the benefit? No, because there are a lot of limitations to the existing pillars. As you can see here, the creatinine rise, the blood pressure going down, and this postural hypotension, there are so many things which make our treatment difficult. For example, the moment, I mean, if you see this hypotension or rise in creatinine or potassium rise, what is the initial response? And then this was taken from the multiple physicians as an analysis. So the first thing is remove this drug which is producing creatinine rise or hyperkalemia, or reduce the dose. And then obviously that doesn't give the full benefit. And as you can see here in CHAMP HF registry from United States, the target dose of all the 4 pillars and in the full recommended dose which was used in the trials was present only in 1% cases. Extremely difficult to achieve all the 4 and in full force. And that leads to our next chapter, that apart from this fantastic 4, what else we can do to curb this unmet need of increased fatality, mortality, or hospitalization, etc., with other drugs. And this optimization of the existing treatment is yes, but then there are, as we saw, there are limitations with potassium, creatinine, blood pressure, postural hypertension, symptoms, so on and so forth. So new options have to be looked for. And then it was realized that all these trials with beta blocker, there was a very linear regression or reduction in the death rate, mortality rate. And then as you can see here, the rate, no reduction, this is a 0 point. And then there is an increase in the heart rate and reduction in the heart rate. There is a very linear relationship with fairly good R value of the slope, this achieving this. And not only in the post MI that what we saw in the previous this thing, but this is from the normal people who did not have coronary artery disease, which paper came in NAGM 2005, and all cause mortality and non-sudden and sudden myocardial infarction, death, etc. You will see that there is increasing, so there is a graded incremental risk of heart rate from 60, 60 to 65 to 70, 75, 75 plus and 80 plus. That makes one prong of calling something as a risk factor. When you call something as a risk factor, there has to be graded incremental risk and robust relationship. That has to be there to begin with. And then that was in epidemiological study, like what I showed you in the previous slide. And so also in the coronary artery disease patients. So this was coronary artery surgery study from Europe and America, and registry patients where people who had not undergone surgery, who were on medical treatment with 15-year follow-up. There also you will see exactly similar kind of graded incremental risk. And this is the other part, that if you reduce the rate, there is incremental benefit. Is it because of the effect of beta blockers on catecholamines and myocardium and then so on and so forth? No, there is something else to do with the pulse rate also, because pulse rate or the heart rate, which produces a continuous pulsatile force, a shearing force on the vessels all throughout the body, and especially more so in the coronaries, carotid and renal arteries. And then there, depending upon this, the steady laminar flow will have this antithrombotic and migratory properties. So typically what we call is endothelium is non-sticky and non-leaky. It doesn't make whatever macrophages and platelets, they do not adhere. So it's non-sticky and non-leaky. So it doesn't go into the subendothelial region to produce inflammation, plaque, and so on and so forth. As opposed to that, this flow reversal with eddy currents, especially at bifurcation points in carotid, internal, external carotid, or coronary artery bifurcations, and so with turning points where there is turbulence and shear force. This is what one can see, the prothrombotic and pro-migration and this various effects. Will not go into the details of molecular biology, pathobiology, how it produces, but nevertheless, I mean, if somebody is interested, I can provide this paper to the person. So basically, all those experiments in vitro initially, then animal experiments, and then in human beings confirmed that yes, by reducing heart rate, we are getting benefited. And then apart from beta blocker, what else we have in our armamentarium? And then that focused the attention to one is non-dihydropyridine calcium blocker like verapamil, diltiazem, but they were contraindicated in heart failure because they worsened the failure. So the second option was ivabradine. Digoxin was the third option, but then digoxin in DISH trial and other trial did not succeed. So ivabradine came into picture, and then that typically prevents this funny current. And that, as you can see here, the depolarization gets gradually delayed, and then the heart rate goes down. And then very classically, it works only on the SA node, only on the pacemaker. It doesn't work anywhere else. So unlike our beta blocker or calcium block, non-dihydropyridine calcium blocker, which work on AV node, produce AV block, PR prolongation. So it is purely the sinus node reduction. And then the proof of the pudding of this concept and to see whether in heart failure, this beta blocker and or ivabradine is working or not. So that was studied in this great trial called as SHIFT trial, which came in 2010, the Swedberg et al., which was published in 2010. So there was a very consistent reduction in the heart rate with ivabradine, which was given in the SHIFT trial of more than 6,000 people, 6,500 people with two randomized parallel arms, 7.5 milligram BD, majority of the 70% people, 30% were on 5 milligram BD. There was a very consistent reduction in the heart heart rate, and that resulted into 18% relative risk reduction of primary composite endpoint of CV death and worsening heart failure hospitalization with a good p-value of less than 0.0001. So extremely good p-value for composite endpoint, and especially this was driven more by heart failure hospitalization and heart failure death. So as you can see here, the 18% became 26% with again the same p-value of 0.001. And then for death from heart failure, again 26%, p-value is slightly less emphatic, 0.0, but then still less than 0.01. So in short, the primary endpoint was effectively reduced, which was not so in beautiful trial earlier, which was done in people with coronary artery disease with ejection fraction less than 40%. But then this was uniformly in primary endpoint was nicely reduced. And not only the relative risk reduction, but if you see even the absolute risk reduction between the two arms was 5%, which makes the number needed to treat 25 or 24, even 20, you can say that 5%. But in this calculation came as 26 people you treat and one death and or heart failure death or hospitalization you can prevent. Not only these hard endpoints, but soft endpoints like NYHA class, that also you can see the improvement was more in this thing, evaporating group, and deterioration, worsening was less in the evaporating group. So, and at various endpoints were also studied. So everywhere you'll see the hazard ratio was reduced to the tune of about 12% to 26%. And in all the different subgroups, it was uniform. Only one thing I just want to highlight is when the baseline heart rate was more than 77, the benefit was there, but then the confidence limit was east-west crossing the midline in this forest plot graph, suggesting that p-value is will be less for this subgroup. Like in beautiful trial, they started with people having this thing heart rate more than 60, but they saw the benefit only for 70 plus. So similarly here they started with in shift trial, they started with people having heart rate more than 70, but the greatest benefit was in 77 plus. So I think when we are selecting the patient, we should see that when the heart rate is less than 77, this forest plot graph is way to the left side of the midline, and the side effects are not much. So this is, the entire spectrum of coronary artery disease and cardiovascular disease, starting from atherosclerosis to myocardial infarction to comorbidity, concomitant comorbidities and heart failure. Different trials came. But the real one which we are talking today in today's topic is SHIFT, because that was the most successful. Beautiful, as I said, the primary endpoint had not reduced, but secondary endpoint had reduced. Another trial was Signify, and then that was also a huge trial again, which came in this thing, NAGM 2014 with 51 countries and then almost 20,000 people. But then if you see here, the Kaplan-Meier curves are identical between placebo and evaporating, because this was again basically for coronary artery disease patients. So it was not so successful. So there was another editorial, does it signify the benefit of evaporating, or does it ignify the existing controversies of should we or should we not use? But then if you summarize all these evaporating based trials, in CAD, there are these black ones indicate that they were not beneficial or controversial. But on the right hand side with systolic heart failure, you'll see that they are red, and then red is beneficial. Not only the hard endpoints and this, but then subsequently even other things also were studied. Like for example, this is a Korean study which came in Heart Failure Congress 2023, and they were actually this is a very busy slide. I just magnified this. So they studied this LV reverse remodeling as 10% improvement in the LVVF, and then finally becoming more than 40%. And then as you can see here, the people who were on evaporatin and heart rate was less than 70, the odds ratio was almost 3.8 to 4. As opposed to that, beta blocker and then evaporatin or heart rate not going to less than 70, then the odds ratio was much less. So that is the importance. This was another paper in the same age, this Prague Heart Failure Congress, and we should be very proud. In fact, Lupin people are here; they will be proud. In fact, this Kolabkar, Vivek Kolabkar had opportunity to present this paper in this thing Prague, and then this was the national meetings, 19 meetings of ad board meetings of more than 500, nearly 500 key opinion leaders were taken, and then majority of the cardiologists from India, they concurred on few things. And then that was like heart rate reduction in heart failure is important. Then adding ivabradine is important. And in fact, there was some talk about this ivabradine and carvedilol combination, because I think Lupin was thinking once upon a time, I don't know whether they're thinking today or not, then having this combination of ivabradine and carvedilol, because Carviva HF37 trial was the trial in which there were 3 parallel arms, and then carvedilol 25 milligram BD or carvedilol 12.5 BD plus ivabradine 5 BD, and the third arm was only ivabradine 7.5 milligram BD. That was Carviva HF37, and then that showed significant benefit with this combination. So that's why Lupin was thinking of this fixed drug combination of ivabradine with carvedilol 12.5 and then 2.5. So people can get the full dose. So in short, this carvedilol has benefit not only in terms of heart endpoints, but mechanistic benefits of LVEF, remodeling, quality of life, and it has become an important pillar, as you can see here. And then it has come in the guideline as class 2A ivabradine, especially if the person is in a sinus rhythm, heart rate is still more than 70 despite the recommended dose of beta blocker. So first, of course, beta blocker, and then go for this. Maybe half a minute if I can exceed, then yeah, just last 4 or 5 slides maybe. So this was all-cause mortality and CV death, heart failure, hospitalization. As you can see here, the heart rate is an important factor which reduces death rate in this, gives the beneficial result. And then that's why this particular phenotypic classification of heart failure became very important in consideration while giving different treatment. This is a very old quote of Jean Baptiste, that doctors pour drugs about which they know little, they cure diseases about they know less, and patients into the patient about whom they know nothing. So that's why this Rosano in 2021 had very nice phenotypic classification. In fact, from India also we have very good phenotypic classification. I think Dr. Srinivas will be he knows about that. So and then accordingly, you first classify where your patient lies and then decide what you have to give. Only the last part is the downside, that it does produce little increase in the if atrial fibrillation, phosphines and other things, visual disturbances are very less common. Bradycardia is in fact desirable, but this atrial fibrillation is there. This in Freeman Hospital, they had done a meta-analysis. In fact, this is a hospital where I was there in 86, 87, along with John Burke, and he was a second author in this particular group. And that is about 15%. That is the downside. So when you will use heart failure patient with ejection fraction less than 50% in sinus rhythm and heart rate is persistently more than 70 despite beta blockers first in the tolerated dose. But if the patient is in atrial fibrillation, the sinus node doesn't have any action. If there is already hypotension, low blood heart rate, then it will not work. Pregnancy, it's not useful. And in peripartum or cardiomyopathy, if the patient happens to go through the second pregnancy, don't give it. Liver disease, don't give it, because metabolism is through the liver. And 5 milligram BD is the starting dose. Western literature always mentions 7.5 BD. In India, we do go to 7.5 BD in few patients, but majority of the patients are on 5 BD only. So this is the last slide. So ivabradine acts as an add-on to beta blocker. When the beta blockers are either we are not being able to give in full dose, or even after full dose, the heart rate is still more than 70, or as a substitute if the person has asthma or AV block or something, and where we cannot give it. But the downside is AV block, and then in say 15% in the meta-analysis, one can have atrial fibrillation. Thank you very much, dear friends, for a very patient hearing.
Thank you so much, sir. Any questions or any comments from our audience? If you have any questions. Okay. So thank you so much, sir, for this wonderful presentation. I would request Mr. Pradeep Dubey to please felicitate Dr. Karnik. Moving on to the next session, which is advances in OPCI. We are going to start first with approach to calcified lesions, selection of IVL, OA, or RA. For that, we have with us a distinguished faculty, Dr. Pramod. Can I have the intro slides, please? Yeah. So Dr. Pramod is a senior consultant and chief of cardiology, structural heart and advanced coronary intervention at Medicover Hospital. He is a awardee of Dr. S.R. Rao Research Association of Physicians of India. He is a guest faculty at CRT 2004, Washington, D.C. He has been the chairman, scientific committee for Basics and Beyond 2022. And he has also authored multiple book chapters, publications, abstract, and research papers. Over to you, sir.
I think he has gone to get a connector for my laptop. Otherwise, I would. Oh, it came. All right, good. Thank you very much. Thank you, Lupin, and my dear friend Srinivas for giving me this opportunity to interact. Unfortunately, I think this is the first session in this PCI. So we are starting with something very difficult. So always there are two approaches. One is to advance yourself from basics to beyond. But here we are going from beyond and maybe we'll come down to basics. So the topic I'm going to speak is one of the difficult things actually, calcific coronary artery disease. So Srinivas and other senior people, we used to struggle to treat the calcified lesions. In those days, we didn't have enough hardware to take down the stents or take down the balloons. But now I think it has become very easy. But only thing is you have to be diligent and you have to know exactly when to use what kind of device. So that makes the success very good. And Srinivas mentioned in his talks about something about the income and all those things. So I think if you care for the outcomes of the patients, your income will be better. I think you understood. So I'm talking about this calcified lesions. As you know, calcium gets deposited in the vasculature. Usually it's a process of aging. And with increasing aging population in our country, nowadays we are seeing more and more calcific disease. Now we treat patients who are 90 plus, also coming in acute situations and also with stable angina and heart failure, etc., where they require stents to be implanted to revascularize them because they're not very suitable for surgical interventions. So in such situations, definitely we need to tackle these calcified lesions, and there are some good tools now. And as you know, coronary calcification is associated with other comorbidities, and people who have hypertension, diabetes, which are the traditional risk factors, especially CKD is one of the most common association in people who have calcific coronary disease. So we have to be very careful because treating a calcified disease takes long time and we need a lot of contrast injections. You have to be very careful. So there, some imaging modalities will be helpful because you can't push a lot of contrast into them to successfully tide over the calcified lesion. And as you know, calcific coronary disease is associated with low procedural success and increased risk of early and late complications. So when you're putting a stent into a calcified lesion, if it is not expanded properly, immediately it can come with a stent thrombosis, or in later part, it can come back as a restenosis. So both ways, early and late complications are known to be there. And difficulty in delivering the stent is often there. You cannot take the stent down because calcium is not like a smooth wall. It is like what we see in the caves, like stalactites, all those things. So it will project into the lumen and you have to make it smooth. Then you can take the stent down. And often on angiogram, you cannot see those projections. So that becomes one of the important limitations to take the stent down. Of course, now we have a boon, that is guide extension catheters. So if you take the guide extension down, you are making a smooth entry for the stent, and success is more when we use the guide extension catheters. And stent under expansion and malapposition, these two are also very important problems. Under expansion means you are not prepared the bed properly and you are trying to put a stent, so it cannot oppose to the vessel wall. So this is another important thing. It can come back as a restenosis. Malapposition is more forgiving. Malapposition means there is some gap in some parts of the stent struts. It is more forgiving. It's usually not associated with major problems, but stent under expansion is a major problem. Subsequently, to rectify the defect also, yourself or your other colleague, or if he goes to another hospital, they will struggle to go through because their wire will be going between the wall and the unexpanded stent most of the times. It is very difficult. We have to be very careful. And lastly, damage to the stents. As you know, there are a lot of data on the drug-eluting stents. Previously, there was polymers on the drug-eluting stents, and the calcium will erode the polymers. And when the polymer is eroded, the drug that is impregnated on the polymer also will go away. And at that spot, you will not have the drug, which basically you are using to prevent restenosis. So those cases, there may be a focal restenosis at that spot where the stent got damaged. And lastly, dislodgement is also a problem. Many times we are surprised. We try to take the stent down, multiple attempts. Then you are frustrated. You say, okay, let me come out. And then you come out, the balloon only comes. The stent is stuck in the vessel, sometimes in odd places like a left main. Then it is very difficult. So in those cases also, you have to be very cool and manage the case. You cannot just pull out everything, including the wire, and then it will be more messy. So you have to be very careful and vigilant to look what is happening. This is another important thing about the calcific coronary. So I think most of the problems are highlighted here. And as you know, assessment of coronary calcification starts usually with the CT coronary. Nowadays, we do a lot of CT coronary angiograms because we are seeing young population with myocardial infarctions. We see people suddenly falling dead in the gyms, in the playgrounds, at home, offices, etc. 23 years, 24 years also. So the disease burden in India is very peculiar and alarming to all of us. And we have heard about the inclisiran and lipid lowering. That is one of the important things as a preventive measure. We have to always get the lipids tested, and at least in my opinion, people who are above 18, we have to look at the lipids. And fluoroscopy, of course, in the angiogram, when we do, we look at the calcium and we identify how much is the calcium, but it's not a very highly sensitive way to detect the amount of calcium. It's only 40% sensitivity as compared to imaging modalities, which I have mentioned, OCT and IVUS, which have a high sensitivity to look at the calcium to the tune of 90% almost. So these two imaging modalities are very important when we want to do a PCI on a calcific lesion. And here there are some angiographic criteria and also some rules are there for the IVUS and OCT. Mostly you have to know the difference between IVUS and OCT. When you do these tests, you can assess different things. Firstly, what is the arc of calcification? Is it all 360 degrees or 270 or how much it is? So if it is 360-degree calcium, your balloons are not going to help there. You will only rupture those balloons. Probably you will also rupture the coronary if you use a bigger balloon. So in those cases, never attempt to take a simple balloon. You need to do definitely some debulking is required. And among debulking also, you have to choose. We'll go forward how to treat those lesions. And second is, what is the thickness of the calcium? So we can measure the thickness. Out of the two things, IVUS cannot measure the thickness because it cannot pass across the calcium. It will be reflected back. So you can't see. Whereas with the OCT, you can see what is the thickness of the calcium. So there is a scoring point for OCT. And based on that, there are different scores also. So more than 5 millimeter thickness, if there is a calcification, that is an adverse factor. And second thing is, what is the length of the calcium? You can also measure that in both, of course. If it is more than 5 centimeter long, 5 millimeter long, then that is another important limitation to look at the expansion. Second thing is negative remodeling. So these are some criteria. Based on that, we have some scores developed that will tell you whether it is an adverse or a favorable factor for PCI. This is called rule of 5. Now it is changed to rule of 3. So we may not really go into those details because, as I mentioned, when you do a OCT or IVUS, you look at what is the arc of calcium, then what is the thickness, what is the length, whether there is any negative remodeling of the vessel. If you know these things, then you know that it's not a favorable thing to go ahead if it is too high. And then approach can be decided by these imaging modalities. So advantage of doing the imaging modality is you will decide what kind of strategy you are going to do. So if the calcium is not 360 degrees, it is say, for example, only 90, and it is fibrofatty in the remaining areas, then you can break the calcium simply by a non-compliant balloon, or you can go with a stent. Just prepare the bed and go with a stent, it will expand. Whereas if it is a 360, then you have to cut it. And we will go further how to go about it. And there are different methods to modify the calcium. As I said, currently we are very fortunate. There is a lot of material that is available. For example, if you want to do calcium modification, we have balloon-based strategies, which include scoring balloons, like a cutting balloon, where there are 3 blades, stainless steel blades are there called tomes, and they will cut the calcium in different places. And there is another called aperta, which doesn't use a metal, but it is also cuts into it. And then we have also other scoring balloons where there is a nitinol wire which is wound on the balloon. It will also do a cutting. It's called differential cutting. And sometimes we also resort to a poor man's cutting balloon. What you do is you pass a wire side by side and then inflate the balloon. So this is called force focused angioplasty, which we were doing in the beginning days when we didn't have these cutting balloon, etc. And then we have an open balloon. Open means it is open. That is, it is going to open any lesion. It has much more force. Normally, when we use the NC balloons, we go to 16 or 20 or something like that. But with the open balloon, you can go up to very high pressures, like 30, 35, though the maximum top is 55. But you don't go to 55 because you are going to cause injury to the vessel. So you can go up to say 30 or so, and you can break the calcium in some cases. And we have the other devices which I'm going to talk: rotablator, intravascular lithotripsy, and orbital atherectomy. These 3 have become very common tools in our day-to-day practice. So these are some of those things which I mentioned: cutting balloon, then angiosculpt, aperta balloon, etc. They're useful for non-dilatable lesions, calcified lesions, and also some cases of instant restenosis. Opium balloon I have mentioned. Intravascular lithotripsy, we are going to see some cases. We'll talk a little bit about it. So here you are using lithotripsy. As you know, it is used to break the renal stones previously, but now it is used in the cath lab. So in the balloon is there. Inside there will be small electrode kind of things. They will emit the energy and they will break the calcium. So what it does is it creates some cracks in the calcium. After the cracks are done, you take out this balloon, put a regular non-compliant balloon, expand it. Then you are going to have a vessel that is expanded. Otherwise, if it is not broken, it is not going to allow the balloon to expand. The balloon will rupture. If you put a stent, stent will expand, but it will be constrained. What I have said is that under expansion will happen. So you can use this balloon to break it. It's very simple. It's like any other balloon. You take it down, and then there is a button, you push it. It gives 10 pulses. So you can see those 10 pulses, and you can sometimes it paces also. So you can see those waves coming there. After 10, you deflate the balloon, then pull back, do one more. Like that you can do. There are 80 to 120 pulses you can deliver. So depending on the vessel length, amount of calcium, which by experience you will gather, you can use the pulses and always keep 10 pulses as a backup, because sometimes post stenting also there is an indication to use. It may be useful there. So this is the IVL I have mentioned about it. That is the cable and connector where you press it, and then you have a light which shows green color. That means it is giving the pulses. So here is the example of calcified left main bifurcation which was done. You can see this is the OCT image. You can see it is 360, almost completely restricted, and it is extending. It's a true bifurcation. True bifurcation is where you have Medina classification. Probably you will be knowing 1, 1, 1. That means the terminal part of the bifurcation of the left main, ostium of the LAD, ostium of the LCX, all are involved. So these kind of cases are difficult to do without IVL. So in the next, I will show you how it appears. So as I mentioned here, you can see the calcium. I think I cannot show you there. The calcium thickness you can see, it is looking like an island. That is how the OCT helps you to identify. And in some areas, it is too tight. If you see the minimal lumen area is only 1.4 millimeter square. Is there any other pointer? Okay. Yeah. Here. So this is one calcified island. You can see so many things like this. This is also a calcium. So calcium will produce this kind of low attenuation signals. And here it is all around. And probably this is a nodule also. So here I use this shockwave balloon 3.5 into 12. You put it here at different places and then inflate it. In left main, you have to be a little bit careful because if the patient is not able to tolerate, you cannot deliver all the pulses there. I will rush a little bit. Then I did also the circumflex. You can see it's too tight here. So sometimes you can use a normal balloon and then put the IVL also if you are unable to take your IVL balloon inside. It's very tight here. And this is the post OCT run from LAD to LMCA. You can see some of those cracks. These are all visible here. Angiographically, you cannot see, but on OCT, you know that it opened. And you can also see here in the longitudinal that it is opened very well. Up to here, you can see this is the catheter. So that means our procedure was successful, and you can also measure what is the area, lumen area gain, etc. You can measure. This is also one of the important tools in the studies when you want to comparatively study whether orbital atherectomy is good or rota is good or IVL is good. So here you can see the post-PCI analysis. Area has come very well, 9 here, 12 and 12 there. And final result, you can see 2 stents are deployed, one into the left main to LAD and the other one to the circumflex. So there are different techniques. We don't want to go into that because that is not the purview, and you can see the best result here. Now, next important thing is rotablator. This is an old tool. Actually, it has a diamond chips that are coated onto a hemispherical short burr. Here, these are the diamond chips that are there, and it rotates at a very high speed, drills into the coronary artery. So it requires a little bit of learning curve. Previously, there was a rota where you have to use all 4 limbs, but now there is advancement, Rota Pro Plus, where a single operator can do using only the hands because the buttons have shifted to the device. So here this burr rotates at a speed of 140 or 160,000 rotations per minute, and it polishes the vessel from inside. This is one case, 73-year-old unstable angina, normal LV function. And here you can see how it is done. So how to identify the calcium on angiogram is before injecting, if you are able to see the vessel contour, that means it is calcified. And you can see here, a lot of calcium will be there and their tight lesions will be there. Sometimes calcium will be only epicardial. The lumen area is good. There you don't have to do anything. But if it is encroaching onto the lumen and producing narrowing, there you have to intervene. This is the RCA. Yeah, right coronary. Before injection, you can see, and in the mid part, there is a very tight lesion. This is a bend here. This is one of the important things. Usually, when you have this kind of bends, we don't advocate to use a rotablator because there may not be a control on the rota. It may perforate or differentially cut the other side. And this red line is very important because you have to watch the distal wire. It may go further and cause perforation. That is very important. So rota floppy we have used. And here you can see exchange technique we use. So usually you go with a microcatheter, pass the lesion, then you exchange that with the rota wire because the rota wire is not 14,000, it is 9,000. It is much narrower diameter wire. And there are 2 kinds of rota wires. One is floppy, the other one is extra stiff. Depending on the curvature or lesion, you can see here, you can see the calcium. So next is the rota. This is the burr that is going and polishing. You can see here, there is the tightest part and there is also a bend. You have to be very careful here. So if you just drive it at a high speed beyond this, you may get stuck. That is called burr stall or burr stuck. So that is one of the important problems. And if your rotor is stuck here, you cannot take it out. It's very difficult. There are some techniques, passing another balloon and trying to make a way for the burr to disengage and then pull it out. Of course, in the Rotor Pro, you can cut it at the shaft and remove. These are all different things when you land in problems, but always better to avoid the problems in cath lab. So go simple. This is called a half rotor. You're not going beyond, you're just going a pecking motion and creating a space in that bend where there is a difficulty. You can see it is just buckling also. So one of the difficult things. And one important thing you must notice is here, there is a temporary pacemaker. So subsequently, I will tell you what is the use of that in these cases. So here you go and then you exchange with a regular wire. Once you polished it, you go back with a micro catheter, then exchange to a regular wire. And then your routine thing is with the balloons, and subsequently you go with a stent. You can also do IVAS to check what happened. IVAS showed good result here. And again, the telescope, which I was telling you, the guide extension catheter, this will give you a lot of support. If you are unable to deliver anything, you can put this catheter. This is actually the guide and this is the guide extension. You take it as much down as possible. And then here is the bend which gave me a lot of trouble. I went beyond, and then you can see your guide extension is also following. This is a inch warming technique. You inflate the balloon a little bit and then take it on the balloon while you are deflating. So you can take the guide extensions as deep as possible, and they are very soft tipped and they are safe. There are many available, but I like this telescope. And subsequently, stent is delivered, one more stent, optimization, 2 stents are done. So this is the post PCI IVAS run. You can see whether a stent is opposed well, any malopposition is there or under expansion or edge dissection is there. Those things you can identify. So this is the case. This is the final result. You see, comparatively how nice it looks. So this is a femoral approach. These procedures are complicated. They require a lot of time, and patient also through radial may not be comfortable. So I do from femoral. Always after doing a femoral, you have to do an injection that I made as a routine practice, because you have to hit it exactly above the bifurcation and below this inferior epigastric artery. If you are above this inferior epigastric, you are likely to produce a retroperitoneal hematoma. And if you are below at the bifurcation, there may be compromise of SFA, or you may produce a pseudoaneurysm. So by fluoroscopy you can do, or by ultrasound guided. Femoral, all of you have to be good nowadays, because a lot of structural procedures are done through the femoral with large bore access. So that is about the rotablator. Now another tool is orbital atherectomy. While rotablator does only forward, you cannot bring it back because the polishing is there only on the front. But now the advancement is coming. The diamond polishing is also there on the other hemisphere. So not only you can go forward, you can come back also. So because of that, we may be eliminating the risk of burr stalling or stuck burr with the rotor. So that is new advancement, but that is not yet come in India. It is going to come. So orbital atherectomy is one size, whereas rotablator different burr sizes are there, like 1.25, 1.5, 1.75, 2, etc. Depending on the size of the vessel, you have to choose. But here there is only one size, and it orbits. It spins like this. And even large vessels, it can go. And here it's similar to rotor. You have to advance this burr slowly, 1 millimeter per second, whereas rotor can go faster. If I have a long segment of calcification, I would prefer a rotor than a this one, OA, because it takes a long time, 1 millimeter you have to go. But it spins well, you can come back also. There is no risk of stalling of this or that kind of problem in this. So here is one example of a 70-year-old man with effort angina. You can see again very highly calcified lesion in a bend here. This bend is too much difficult. So I thought rotor may cause problem, and it is heavily calcified. So you can see here again, temporary pacemaker is there. And Versaton, same, you have to take a normal wire, cross the lesion, then put a microcatheter, exchange. For this also, there is a separate wire called Viper wire that you have to use because that gives support. And OA is done slowly. Gradually, you go in 1 millimeter, go forward, come backward. Takes time to reach all the way to the spot. But anyway, it is done here. This is post OA. You can see some cuts are made, and then you can see that it did not expand much. If you see, IVL gives you immediate result, ROTA also gives, but here still there is some constraint portion there. And after that, you again predilate to make it smoother. And subsequently, you take your stents. Here mid RCA 2.7533 and proximal 3 into 33. 2 stents deployed here. And again, post dilation also you have to do to make it better. Now you can see the vessel is opened very well. So now this slide is very important. I think you can take pictures. A lot of mobiles are there. This is not there anywhere. I made it today. So here I have mentioned ROTA is rotational, as the name suggests. IVL gives ultrasonic pulses to brake. Orbital atherectomy is orbiting. It goes like this, whereas ROTA is a high-speed drilling. And for balloon crossable lesions, you can use rotablator. Sorry, here balloon crossable lesion, you can use IVL. There is some change there. For balloon crossable lesions, uncrossable lesions. So just there is a change. If you are unable to cross with the balloon, and then you can use the rotablator or orbital atherectomy. If it is crossable, then use the IVL. Because IVL is a little bulky, the balloon has to go. And next is sizing. Sizing is for rotablator, you have to use balloon artery ratio 1:0.6 and IVL 1:1 you have to take. Suppose if the vessel is 3.5, you take 3.5 only. And for OA, it is only one size. That is 1.25 for everything. And deep calcium modification is possible with IVL. Because when you use ROTA or OA, you are only shaving the parts that are projecting into the lumen. But IVL can go deeper. Those sonic waves can go deeper and break the calcium there. And fractures are less and short with the ROTA and more extensive and linear with greater volume for the IVL. Acute lumen gain, as I mentioned, is greater with the rotablator, comparatively lesser for both of these, IVL and OA. Wire bias means when you are driving it in those tortuous cases which I showed, it will differentially cut only on the other side because it is going high speed. If the vessel is tortuous like this, it will differentially cut only on one side. And sometimes that may cause a rupture or perforation at that site. So that is there both for the ROTA and OA. Because IVL is a balloon, it expands circumferentially. This kind of wire bias is not there. And dissections and perforations are very rare with the IVL. So probably the perforations are zero, though recently I came across with one case where there was a perforation reported. But for the other things, there is a low risk. And side branch, you cannot put. Suppose if you are doing the first case which I showed, LAD and LCX, you cannot put a wire in the circumflex because you are only drilling the LAD and LM. So you have to do that, then come back and do the circumflex again. So sometimes if the patient has a migration or a plaque shift into the LCX, hemodynamically he may become unstable. So you have to rush the procedure in that situation. And need for TPA is there for ROTA and for OA, and for IVL you don't need. A risk of no flow is not there with IVL, but it is there highest with the rotablator because it is pulverizing and producing showers of calcified debris downstream. So you have to be prepared to give vasodilators intracoronary and then manage, though we give some fluid to run through a bag, saline and NTG heparin is run. And with the orbital also there is some incidence. And for treatment of ISR, IVL is now indicated. Even for multi-layer ISR also you can use IVL now. For the other things are not indicated, though rotablator is still some people used to do, but now IVL has got an indication. And ease of use and learning, IVL is the easiest. And for the rotablator and orbital atherectomy, you need some learning curve. I think again, some changes are there. So I think that is my last slide. I tried to summarize the details. Thank you very much for your patient hearing.
Thank you, Pramod. In spite of your busy schedule, you came here, and any of you, he has to leave because of work pressure. Any of you have any doubts or things, you can discuss Pramod because he may not be available for after the two talks. We'll have again discussion at the end of 2 talks, but anybody wants to ask anything, feel free to discuss. Thank you, Pramod. And
Pardon? Yeah, balloon uncrossable lesions. What I do is actually when I encounter a highly calcified lesion, I try to take a small balloon, like a 1.5 or so, try to go on a normal wire after crossing. If you are unable to cross the lesion, that is an indication that you are not going to go with the balloons. Then either you have to go with a rotablator or orbital atherectomy. So that is very simple. And second rule we used to have in Washington was if you are unable to take your IVUS catheter down, that again is an indicator that there is a lot of calcification and you cannot do the case with simple things. Okay. Yeah.
Timer laser on and calcium.
Yeah.
पे sir क्या?
Yeah, I didn't cover because the topic was not assigned to me. I thought even time also may be constrained. Laser also can be used, but nowadays the utility of laser is not much because we have better and simpler tools now, and it is not cost effective for most of the centers. But recently there were a lot of regulations also. Recently only it is approved, and we have now started using laser also.
Thank you so much, sir. Please give a loud round of applause. I would request Dr. Srinivas Kumar to please felicitate Dr. Pramod Kumar.
Okay. Can you show this once? Let them take the picture.
We'll do it, sir. Thank you so much, sir.
Again.
Yeah, we have. So if anyone wants to take a pic, you can take a pic of this slide.
I made some corrections.
Thank you. Moving on to the next session. The next session is on IVUS versus OCT, which one to prefer when. For that, we have Dr. Javed Ali Khan. Can we have this CV slide, please? So Dr. Javed Ali Khan is a consultant cardiologist at Care Hospital, Raipur. He is a senior consultant cardiologist at Indraprastha Hospital, Apollo. He has expertise in coronary interventions and structural heart disease. Multiple national and international publications he has authored, and also some chapters and articles. Over to you, sir.
Good afternoon, friends. Thank you very much, Lupin. Thank you very much, Srinivas, for inviting me for this very important meeting. And I'm happy that I'm addressing the budding cardiologists of the country. I mean, more than 100 people are here who are going to take the responsibility of cardiology on their shoulders. Friends, it's very important, the very important topic for today. And before starting my talk, I just want to know how many of you are scrubbed for IVUS or OCT in your cath lab. How many of you? Oh, many people. Great. So friends, you would be knowing that OCT and IVUS are the two newer modality of imaging we are dealing with. And why this new technology has come, because of there are various reasons. There are certain background points like before that, I think from 1980 to 2015 or 2017, 2018, we have been doing all kind of the intervention with only with angiography, plain simple angiography. And after that, we realized that the results are not so good, and that is why there was some need for looking deep into the details of the lesion, and that is why the imaging came into the picture. The cath lab angiography has got many loopholes, many shortcomings, and a couple of them is a poor resolution. Many times it is not clearly seen. The angiographic pictures are not seen. You cannot make decision out of that. Secondly, it is completely on the angle dependency. Sometimes the angle is like that. Suppose the lesion is based on the bend, or at some place where you cannot decide. In some view it is looking like 50%. Some view it is looking like 70%. Initially we decided that we'll take the average of those 2 or 3 views and then decide about this one. So the people realized that this is not accurate and we should look for something else. Vascular overlap. Sometime in the angiography you are looking the vessel one over the other, and you cannot make out the decision whether the disease is significant or not, whether there is a calcium or not. Then foreshortening is there. In some view it is looking less, in some view it is looking longer. So there are many shortcomings for that, and that is why we decided, and the people decided to look the lesion more into the detail. Further, the CAG is 2-dimensional. It is basically a luminogram. We inject the dye into the vessel and see the lumen, and we cannot have the tissue characteristic, what kind of lesion it is, where the calcium is there or not. Sometime in the CT angiography or the regular angiography, you will see some calcification, whether this is adventitious, whether this is intimal, whether it is medial, you don't have any idea. And in the modern cardiology, you need to know each and everything, because we are doing more complex cases, more critical cases, more calcified lesion, etc. So we need to know the tissue characterization, which is very important. And based on that, the Pramod has already told that we need to have the imaging facility. And because of the imaging facility, you decide what kind of treatment a particular person needs, whether he needs a cutting balloon, whether he needs IVL, whether he needs a rota, and depending upon the length of the lesion, the depth of the calcification, etc. That is why the newer technologies came into the picture. And there are various benefits of the newer technology or newer imaging modality. You know what happens? We put the catheter inside the coronary artery and imagine and see this one. There are 2 ways for this one. Either by doing the ultrasound, which is we are doing in the regular cases in the radiology department, the same ultrasound can be done inside the coronary artery. This is one. Or secondly, taking the picture from the coronary artery directly inside the coronary artery and see what happens. So these are the 2 major modalities we have, and there are various benefits of the newer modality. The information which is necessary for preparation of the lesion, as my earlier colleague has told, Pramod has told you, the lesion preparation is very, very important. Unless you prepare the lesion very properly and deploy the stent, then the stent is going to block. That is very important. The lesion preparation is very important, and preparing a lesion, you must know the tissue characterization, the length of the calcification, the depth of the calcification, the thickness of the calcification. So information necessity for the lesion preparation can be taken or can be derived only by the imaging modality. The directing appropriate stent sizing, what size on, you will understand later on. The size of the coronary artery which we are seeing in the angiogram, regular angiogram, generally it comes out to be slightly bigger. When you do the OCT or IVUS, we find the artery which we are thinking at 3 millimeter, it is 3.5, not 3. So we are deploying the stent undersized. So undersizing the stent at the site of the lesion is the cause of subsequent complication, either thrombosis or reocclusion, etc. So selecting the optimal stent length is very important. And before that, we used to put the wire and then, take the picture of the wire, and size can be measured because of that. But in case you will do the OCT or imaging of any kind, ultrasound, IVUS, etc., you'll get to know the basic thing is you need to put the stent from the normal to normal segment. That is the basic philosophy, and you cannot leave anything beyond. So sizing is very important. The lumen diameter is very important, and that can be derived only by the imaging technology. Stent expansion is very important. The things which are visible only by the angiography is not sufficient. Sometimes you get to know that the stent is underexpanded in the middle segment, or the part of the stent is not. This is basically the segment where you'll get the restenosis or reocclusion or stent thrombosis. So proper stent deployment, proper stent expansion, etc. can be, this information can be get only by the imaging modality. So friends, we have got couple of imaging technology we have. I mean, mostly we are using the OCT, the optical coherence tomography, which is many pictures Dr. Pramod has shown now, and the IVUS. You know, the IVUS has come first. When I was doing my DM, that time we had the IVUS, but that was a very basic IVUS, and that did not get any popularity. But later on, the people have come out with the higher resolution IVUS technology. And OCT is a newer modality which has come, and angioscopy, where you can see from by the scope inside the coronary artery, and near infrared spectroscopy, which is also a coming up modality. This intravascular ultrasound sonography is an equipment basically provided by the Boston Scientific or Volcano. These are the two major companies which are manufacturing the IVUS. The basic difference is, in one, we have got a one element which rotates at the speed of 1800 RPM and take the pictures, and then this pictures are processed and the result comes in. And the eagle-eye catheter, which is manufactured by the Volcano, they have got multiple elements, etc. These are the technical problems, But the two major IVUS company which are manufacturing the IVUS, and we are using these things, these are the two. One is Boston Scientific, another one is Volcano. There are some minor differences, technical differences. The OCT basically was the Abbott, this one. And the OCT is an optical analog of the IVUS, where we take the picture from inside the coronary artery, because the coronary arteries are filled with the blood. So before taking the picture, we need to replace the blood from there. And replacing the blood requires one thing, which is contrast material, which we are using. So we have to inject the contrast material forcefully into the coronary artery, replacing the blood, and this camera takes the picture, and it's a very high resolution picture which can be taken by this thing. And one important thing you must remember, the difference between the OCT and IVUS is, once you increase the penetrating power, or you increase the megahertz of the element, then the imaging quality improves, but the penetration power reduced. That is what the basic principle of the echocardiography. In the pediatric age group, while we are doing the echocardiography, we have the 7.5 or something, 10 megahertz kind of this thing. And for the obese people or the ultrasound, 2.5 to 3.5. Similar concept is there. So once we increase the megahertz, then the picture quality is better, but the penetration is there. The OCT behaves like that. It has got a very good picture quality, but the penetration power of this thing is less. So the light, the near infrared light can show you something inside the coronary artery very nicely, but it has got a limited penetrating power, so it cannot go deeply beyond the coronary arteries, or the distal structures are not clearly seen. That is the basic philosophy for this thing. The IVUS and OCT advantages and disadvantages, you can read this one. This is very, very important. The advantage of the IVUS, it is the first thing, first modality of imaging the coronary artery which has come. So abundance of literature is available. I mean, for many, many years it has been used and it has proven its efficacy. The pre-intervention imaging is possible. You know what happened? While we are doing the intervention or planning the intervention, we put the imaging catheter inside the coronary artery. It should be able to cross the lesion, and then you pull it back and take the pictures and decide about your strategy, what is to be done, what is the length, what is the size, what is diameter, etc., etc. But this is possible more with the IVUS rather than OCT. So, I mean, the pre-intervention, the IVUS catheter is possible to take the picture, but OCT is also sometimes possible, but the crossability of the IVUS catheter is better than the OCT catheter. The penetration of the adventitia allows, I mean, as I told you, the intravascular ultrasound has got a bigger capacity of penetration. So even up to adventitia, you can see very clearly, very clearly. So that is what advantage of this one. Extensive research and publications are there for the intravascular ultrasound. And for the CTO, suppose somebody is planning, it can give the better guidance to the operator. But there are certain disadvantages of the intravascular ultrasound, or not disadvantage. I can say it is some limitations are there. The imaging can be difficult to interpret. You know, most of us are trained for the echocardiography, but not for the ultrasonography of the abdomen or chest or something like that. So basically, this is ultrasound. So interpretation sometimes takes a longer time. We need to expertise ourselves for this one. So the learning curve is longer. Once you start seeing the images of the intravascular ultrasound, you will understand where is the calcium, what is the size of the calcium, what is the adventitia, what is the depth of the calcium, but etc. etc. So detailed architecture of the arteries can be seen and interpret with difficulty with the IVUS. This is one. The tissue characterization is not good, not up to the mark. I say it is not up to the mark, as we can see in the OCT. The tissue characterization is slightly poor. The thrombus dissection is difficult, you know, by the intravascular ultrasound. Low resolution of the longitudinal view. Suppose you want to see the artery in the longitudinal view, it is the resolution is not up to the mark. Now we come to the OCT. What are the advantages of the OCT? First of all, I mean, the learning curve is very short. This is very important. The images are so brilliantly shown to you. I mean, you can interpret. Once you will see, you will never forget this one. So this is one. Resolution is perfect, more than 10 times of the IVUS catheter. Better tissue characterization. You can have the better feel of the tissue. I mean, you can interpret where is the media, where is the where is the intima, where is the external elastic lamina, etc., etc. Tissue characterization is excellent with this one. The images are clear and easier to interpret. So the learning curve is very short. In couple of weeks or couple of cases, you will understand what is happening. You know, and the limitation of this one, the additional contrast. As I told you, once you start doing the OCT, you need to push the contrast material into the coronary artery just to displace the blood. So extra contrast material is used. And you can understand, you are all cardiologists now. I mean, you can understand you are doing the contemplating the coronary artery angioplasty, etc., and the creatinine is 2, 2.1, 2.3 or 3. Then you don't try to push more contrast, you know. So whatever contrast is directly related with the nephrotoxicity. In case more contrast, then more chances of the nephrotoxicity. So this is limitation. You need to have more contrast with the OCT. The flushing is necessary to clear the lumen times and again. Times and again, you need to clear pre-dilatation. As I told you in the intravascular ultrasound, most of the time you are able to cross the lesion and have the feel before the angioplasty. But in OCT, sometimes it is difficult to cross the lesion because of this profile, etc. Compared to the IVUS, because this is the new modality, the less literature is available in the at the moment. But I hope more number of people are using. Many studies are being done, and will have many publication on the OCT also. This is the property advantages and disadvantages of IVUS and OCT. You can read this one. This is very important. I mean, in case the megahertz of IVUS is less, then I mean it can you can see it is deep into the artery. That is very important. In case the megahertz of this one IVUS catheter by latest generation IVUS catheter have got the 50 to 60 megahertz, then you can have the better visibility, resolution, etc. But the tissue character this thing is limited. The OCT frequencies is the same. Distance between the maximum pullback length, you know, how long you can see the artery is almost same for every catheter, 100 to 150 millimeter, etc. The blood tissue in moderate back is scattered in the IVUS, which is 40 to 50 megahertz. In 50 to 60 megahertz, the strong back scatters are there because, you know, the blood volume scatters are there. So it is difficult. And OCT you require to push the blood out. And lipid plaque agent and cross-section calcium. These are the two major things, I mean, in case the plaque is highly filled with the lipid molecules, then OCT sometimes not able to pick up the structures beyond the lipid plaque. And suppose the calcium is there, the sometime the IVUS cannot pick up beyond the calcium. So these are the two major differentiating points, the lipid filled plaque and the calcium, and the IVUS and OCT behaves in a different direction in this thing. Now look at the differences in the lumen and the stent measurement between the OCT and IVUS. You can see these are the pictures of the same patient, same coronary artery, as you can see. As long as the coronaries are normal, there is no major problem, and IVUS and OCT can give you the same kind of picture. And the measurement, in case you'll take, there is no significant difference between the measurement between the IVUS and OCT. The normal coronary artery you can make out easily, the intima, media, internal elastic lamina, etc., with both with IVUS and OCT. The calcium detection, I mean, this is what Dr. Pramod was telling, and most of the time he was showing the OCT. Why? You understand why? Because the calcium detection is mainly the field or domain of the OCT. Reason is, as I told you, the ultrasound cannot pass through the calcium plaque or calcium region. In that situation, you get to know only the arc of the calcium, how big the calcium arc is there. Up to 360, the whole artery is calcified. Up to 180 or 90 or etc. Depending upon that, you decide. But you cannot know the depth of the calcium by the IVUS. This is what the problem is. The IVUS cannot penetrate into the calcium segment, and the depth of the calcium, which is very important, in case the calcium plate is more than 5 millimeter thick, etc., 0.5 millimeter thick, then it is a thick plate and it's very difficult to break, and the IVL, etc., can break this one. So all those things are important. The total characteristic of the calcium is important. Arc of the calcium is important. In OCT, you can have the OCT light has got some penetrating power, and they can penetrate deep into the calcium, and they can show the picture, a less attenuation picture beyond the calcium. So you can get to know even when the calcium is there. So with the calcium, the OCT is better always over the IVUS. OCT is better than IVUS. But in case the lipid rich plaque is there, in that situation, the situation is reversed. As I told you, the the plaque is lipid rich, the fat is there, then it absorbs the light, and you cannot see beyond the lipid rich plaque. So that is what the problem. In that situation, you can see this one, the first right coronary artery you can see, and OCT and IVUS images. This in the OCT, you cannot see anything beyond the lumen. This is all lipid rich plaque, But I was in the same patient, you can see everything, even beyond the plaque. So these are the very important differentiating point. But when there is the calcium, the OCT is always better, because the OCT can penetrate to some extent into the calcium and give rise to some idea of the depth of the calcium and thickness of the calcium. Sizing by the IVUS and OCT, I mean, most of the time, we take the external elastic media lamina to a EEL to EL, and depending upon that, we decide the size of the stent, what size of the stent is required. Whenever there is the EEL is not available, then we go to the distal artery as a marker, reference image, or the proximal segment, and take the EEL and decide about the size of the size of the stent. The main this thing is when we take the EL as a corresponding this one, then we reduce downsize the stent by 0.5, and in case nothing is visible by OCT, like only lumen is visible, EL is not visible, we take the lumen area and upsize by 0.5. So these are the things. Stent sizing by IVUS, these are some representative images. This was published in 2017, and we can get to know the EL to EL marker and the reference images, proximal and distal to this one. Stent sizing by OCT is same. Either you take the proximal reference and the distal reference and decide about this one. In case EL is visible, then downsize by 0.5. In case EL was not visible, then lumen plus 0.5. Stent sizing by OCT. Look, stent size, stent edge dissection. These are some complications which we get to know only by the by the imaging technique, and especially something which are picked up by the IVUS, something which are picked up by OCT. But these are some images, which can be picked up by the OCT, like dissection. Suppose you have deployed the stent and you want to know, this is one complication of the stent deployment. In case your pressure is high and the stent is not placed in the normal segment, it is in a disease segment. In that situation, the edge dissection chances are there. So edge dissection can be clearly seen by the OCT. The lower image for this one, the IVUS is not very clear for dissection. First image A and A plus. And the second, you can see the malposition of the stent. You have deployed the stent and you want to see whether the stent is properly opposed or not. In that situation, suppose you will do the IVUS, it is seen, but it is more clearly seen by the OCT. So these are the few differences. So, and suppose sometime what happens, you have already deployed the stent and the tissue protrusion is there. So that can be seen only by the OCT more clearly than by the IVUS. As I told you, OCT, because it has got a very remarkable resolution power, more clearly you can see the near images, close to the intima, close to the media, etc. Stent fracture and neoatherosclerosis. Stent fracture, you can see in the first top, this one, there are two layers of the stent fracture, two layers of the stent, which are corresponding to the stent fracture. There are C images, rupture of the plaque into the neointimal things into the plaque. And all those things are very clearly visible by the OCT, not by the IVUS. So near problem, inside the problem of the artery, close to the intima or media, can be seen better by the OCT rather than by the IVUS. Clinical evidences, IVUS versus OCT, what the literature says. The literature says that most of the things are possible with OCT and IVUS, and they all favoring that one of the imaging this modality has to be used. The OCT guided PCI to improve the outcome. Various studies, various trials have shown, the IVUS has come first. So the OCT come later, and most of the trial have been come and shown the OCT is at least non-inferior to the IVUS. That is what is messages with all those things. OCT versus IVUS versus angiography, they have shown very clearly in case you are doing the angioplasty alone, with regular angiography without using the modality of imaging, then chances of complication, morbidity, mortality, etc., everything is high. Immediate post PTCA, thrombosis, stent thrombosis, restenosis, everything is high. These are certain papers of optical coherence tomography versus intravascular ultrasound recently published, and they all shown the OCT is non-inferior to the IVUS. That is what the message is, the bottom line is. The OCT versus intravascular ultrasound angiography to guide percutaneous coronary intervention says the same. The message is same. They have tested both the modality and they found, because the IVUS was the gold standard, and they found the OCT is not inferior at least to that. So one real-time meta-analysis, very important, 20 randomized trial, more than 12,000 patients they have included, and IVUS and OCT was conducted, and they found the result was compared to the angiography guided PCI, the results were more satisfactory with image guided interventions, etc. And target lesion failure was more than 30% reduction in case of the image guided PTCA. The image guided PTCA also reduced the stent thrombosis more than 50%. Stent thrombosis is one of the dreaded complications, you can understand. Suppose you have given the stent and after 10 days or 3 days or 5 days, the patient comes back to you with the subacute stent thrombosis. Most of the time, you are not able to save him. because they know the thrombosis is so dreaded. So nobody wants the patient should land up into this thing, and that thing you can reduce or at least optimize by using the using the imaging technique. All-cause mortality is also 25% less. These are the some flow chart when the from 2018 the ESC initially recommended as a class 2A recommendation. European Society of Cardiology has recommended the imaging from class 2A in 2018, and over a period of time, now this is the time that 2024 the ESC has given the clearance as a class 1A indication in all kind of complex coronary intervention. In case you are complex, mean either you are doing the long segment, you are doing the calcified vessel, you are doing the bifurcation, etc. All complex intervention, the class 1 indication, either IVUS or OCT, and most of the studies have shown the IVUS is okay, and the OCT is not non-inferior to that. But they are because one investigation is not meant for everything, like ECG. By ECG you get to know something, by echo you get to know something, by ECG you get to know only electrical activity, but in case you want to see the function of the heart, you need to do the echo. Similarly, one technique is not suitable for everything. Something are good, something are limitation, and this is the final slide, friend. Imaging modalities you can see. In case of the acute coronary syndrome, you want to do the imaging, it is always better the OCT. In case INOCA and MINOCA, you want to do something, some imaging is required, then OCT is preferred. The stable coronary artery disease, the IVUS is preferred. The left main, in case you are contemplating, it is always better to do the IVUS, because the problem with the OCT is sometimes it is not visible, the ostium of the left main coronary artery, which you can miss. So in case you are contemplating the left main coronary artery, it is always better to do IVUS. Bifurcation lesion, both are same. Ostial lesion, it is always better, the IVUS. The CTO lesion, the IVUS is better. The ISR, in case you are contemplating any kind of intervention, the OCT is better. Calcified lesion, of course, the OCT is always better. Stent characterization, rupture plaque, thrombus, etc. This is OCT. Neoatherosclerosis, in case you are thinking it is OCT. Stent apposition, you want to make sure it is OCT better than IVUS. Stent apposition, stent edge dissection, both can pick up, but OCT can pick up better, and so on and so forth. So let me conclude, my friends. Imaging is a class 1 indication in all complex lesion. This is one. This is very important. This is ESC guideline now. IVUS and OCT both are good imaging modality and should be used complementary to each other. In certain cases, the OCT gives you the better idea. In some cases, the IVUS gives you the better idea. For all ostial left main, and this is what is important. This is all ostial left main bifurcation lesion. IVUS has got some edge over the OCT. For calcified lesion, edge dissection, recognition of thrombus, malopposition, of ease of interpretation of the images, OCT appears slightly superior to that. In all clinical outcome, results are same for both the technique. Thank you very much.
Thank you, Dr. Javed Sant, for the extensive coverage. I think we are sorry for going reverse because Pramod had to leave. We started with the difficult topic in between, and the basics topic now will be covered. I assure you that we'll have good discussion. Any doubts we have will clear after the other talk also. I think ideally you would have done basics first, and mid, the second and third should be the toughest, but we went reverse. I think as SAR started, you all realized that which one is better is not the issue. Each of it has its own advantages and disadvantages. Which one to prefer when was the topic. I think we'll cover a little more clinical scenarios, and the morphology is already is covered. I think each of you, I think I'm happy that 90% of the hands raised, even in India, out of labs out which are available, about 1,500 or so cath labs available in the country, about 50% of them have imaging modalities now. I think 500 plus labs of IVUS and 250 plus labs of OCT, and 150 plus labs have both IVUS and OCT. And that's a good thing. I think more complications being done, complex PCIs being done is a good value addition. Thank you, sir. I think we'll have a discussion from all the things after the finishing of the next talk, because that is also related. And they can invite.
Thank you so much, sir. So I would request, sir, if you can just wait on the stage, and I would request Mr. Rahul Chakravarti to please felicitate Dr. Javed Ali, sir. Next, we have a session on imaging and physiology, basics for the beginner, by Dr. Tanuj Bhatia. Can we have the CV slides, please? Yeah. So Dr. Tanuj Bhatia is head Department of Cardiology at SGRR Medical College, Dehradun. He has been awarded as the most promising interventional cardiologist in UK in 2016. He has been also awarded the Champions of Change Award in 2019 by ex-President of India, Sri Pranab Mukherjee. He has been awarded as the Champions of Change Award 2020 again by a Governor of Goa. Also Achievers Award second edition in 2023. He is also India's best doctor as per the 6th edition of 2024, and he has been a principal investigator in various randomized controlled trials like Artemis, Anthos, and Acclaim. Over to you, sir.
Thank you very much for the opportunity, and I would try to avoid overlap of the discussion with the talks earlier. And as sir said, we should have started with the basics, and we are going from difficult to easy in this reverse manner. But sometimes that's better, because you get trained to the difficult, then the easier becomes much more easier. So conventionally, what we have been seeing in the angiogram actually is just 5% of the entire arterial circulation that we witness. We don't witness the microcirculation, and the coronary artery needs much more attention than what is just seen on the angiogram. Traditionally, significant coronary stenosis is defined as 70% luminal diameter narrowing in an epicardial vessel, except for left main, in which the cutoff is 50%. Courage actually challenged this definition and said it's much more than that. We'll discuss that in the details of the trial. But as exemplified by the speakers earlier, in the projection, it's just a 2D luminogram that we are witnessing, and we need to understand the entire anatomy in the 3D, which is particularly not easy, even if we see two views at 90 degrees. And eyeballing can have limitations in lesions between 50 to 90%, and this reflex, which has been known as termed as oculostenotic reflex, has been appreciated more in this era of imaging. The spectrum of coronary syndromes, we know we have chronic coronary syndromes, we have acute coronary syndromes, and we have punctuated episodes of acute coronary syndromes over and above chronic coronary syndromes, which occur unexpectedly. At least 50% of the ACS has been happening in patients those who do not have history of prior angina. So which modality to use when? As it was discussed, IVUS versus OCT. It's also a debate between imaging and physiology. It was one of the views that we use physiological assessment for chronic stable angina and imaging or OCT assessment for ACS. But this seems to be a pretty reductive approach, because CAD is usually not a focal disease. We are still trying to understand more so in the imaging era about the progression and regression of plaques. And PCI, we don't have one size fits all for all the approaches. The first discussion that I would be doing would be about the use of physiology, which is extremely important in angiographically indeterminate lesions. Then we'll cover something about the vulnerability concept, and also understand the limitations of imaging and FFR, how we may misuse them for over-treating or under-treating our patients. First, the assessment of an intermediate coronary lesion. Usually angiogram is quite insufficient and we need some adjunctive tool. The thing that comes to our mind is the physiology. I think so most of you might be using, just like imaging, how many of you have been using FFR in your lab routinely? A raise of hands. So as we can see, the comparison between physiology and imaging, physiology is much underused in current era. The raise of hands was peculiarly less than imaging. So the first thing that comes to our mind is FFR, fractional flow reserve, that is done in the hyperemic situation. Besides that, we have certain wave-free ratios like IFR and RFR. RFR is resting full wave, full cycle length flow ratio. Also, we can use other adjunctive tools to treat our lesion or the patient by using anatomical plus minus physiological assessment, that is by CTFFR or QFR, and definitely other things guided by imaging. Starting with FFR, the most studied, it has a wealth of long-term data. So FFR is defined as PD by PA, that is the pressure distal to the stenosis divided by pressure proximal to the stenosis. It provides functional information and takes into account the size of the perfusion territory, the viability of the supplied myocardium, presence or absence of microvascular disease, and collateral circulation as well. I think so this figure needs a lot of appreciation that routine measurement of FFR has shown to reduce the MACE rates by 28%. This is a huge figure. The p-values were dramatically significant, and of importance is that FFR received a class 1 recommendation much before than imaging did. In absence of a true gold standard, FFR is the strongest contender and it is the best parameter for defining ischemia for a particular lesion. And as I said, it has got a long-term data as well. So as we discussed, FFR actually FFR is defined as maximum flow in presence of that particular stenosis divided by the normal maximum flow. So it has been simplified as PD by PA, but it is basically Q in the presence of stenosis, that is the flow in presence of stenosis divided by flow in presence of normal, in absence of stenosis in that normal vessel. Why I'm discussing it? Because it will make you understand when we should not use FFR. So it is QS by QN, which is pressure distal minus pressure in the right atrium, PV, upon PA minus PV, pressure proximal to the stenosis minus pressure in the right atrium. V is the venous part of it, the venous side of it, divided by R myo, divided by R myo. So what is important is that because PV is dramatically less than the proximal driving pressures. Maybe if the driving pressures is 120 and PV is just 4, so it's 120 minus 4 and it's 80 minus 4. So we ignore that PV. So PV gets ignored and henceforth R myo gets cancelled and henceforth the simplified value is PD by PA. But of importance is that we should not be using this when we have patient in a congestive heart failure. That signifies that the patient has elevated venous pressures as well. Second thing, FFR actually accounts for the perfusion area as well. So for the same amount of stenosis of 60% with a MLA of 4 millimeters square, equally perfusing either a large perfusion area versus a small perfusion area, the large perfusion area FFR comes to be positive as compared to a small perfusion area FFR that comes to be negative. If there is a scar tissue distally, then even then in that situation, the FFR may come out to be negative. And if that distal vessel is also giving collateral, even a 50% stenosis may have a positive FFR. So the unique features include that a normal value of 1 is an absolute truth for every single patient and every single artery. It is not influenced by changing hemodynamic conditions. It accounts for collaterals as well. So it actually guides your clinical acumen more than imaging in certain subsets that we'll discuss. FFR plays an extremely important role. I like to say this at this point of time itself that putting in a stent is not our purpose. Treating the patient is our purpose. So immediately seeing a stenosis and putting a stent because of that oculostenotic reflex is not the way to go. Assessing the functional significance or the anatomical significance is more important. Like this is extremely important in serial stenosis or a diffuse disease. So in serial stenosis, there is another term which is known as FFR pullback gradient. So if we have a positive FFR and we have serial lesions, we actually, like in this patient, you can appreciate that the left anterior descending artery has 4 stenoses, 1, 2, 3, 4, starting from distal to proximal. Which one to treat, which one not to treat, or put in a stent all across the length and making this patient a potential subset for our future intervention for ISR is not the right way to go. The pullback revealed that the significant step up, as you can see on the right side of the figure, these are the step ups. So you can see the step ups are more at the first and the fourth lesion. So you can treat the first and the fourth lesion and get away with the medical therapy for the second and third lesion. Similarly, in diffuse disease, I think so. This is one of the OSCE as well. If you see a gradual elevation of that in that FFR pullback gradient, and you are not able to see peculiar step-up points, these patients are best left medically rather than treating them with a stent. The beauty of FFR is that it is highly reproducible. What we really need to practically do while we are doing an FFR is to achieve true maximal hyperemia. So this word is extremely important and it is done by a very simple agent, adenosine. It is exogenously administered either by the intracoronary route or by intravenous route. The doses for the right coronary artery are approximately 100 micrograms. For left coronary artery, 200 micrograms. The side effect is just a transient AV block. The dose calculations for the intracoronary I've just mentioned. Intracoronary has got peculiar advantages for single lesions, for assessment of multivessel disease, for patients without asthma. However, a long pullback is required for diffuse and serial stenosis in which it is not a recommended way. For those cases where intracoronary cannot be given, like osteal lesions, long pullback is required, or the guide catheter without side holes is required, we can go for intravenous adenosine. The dose for intravenous adenosine is 140 microgram per kg per minute of an infusion. Approximately it takes about 3 minutes. It can provoke bronchoconstriction, but if you counsel your patient well that this is a very transient side effect and it would go after a few seconds, the patient doesn't react so much. What precautions you need to use while recording the FFR, that you should not deep wedge your guide catheter because it may cause damping of the aortic waveform and give a false FFR value. You should avoid using side holes because again, it may cause a drift in one of the readings. And even you should be cautious about that fluctuating PD by PA line because it may be because of suboptimal maximal hyperemia. The data comes from various studies, starting from FAME study as early as in 2006. It showed a significant reduction with angio plus FFR guided PCI with 13.2% patients having MACE at 1 year as compared to angio only group, which had 18% MACE at 1 year. Subsequently came the DEFER study that said it is quite reasonable to defer PCI in patients or lesions with having negative FFR. Similarly, FAME2 result. Another interesting fact is that a lot of our patients, those who actually have triple vessel disease, and we are actually contemplating either CABG or multivessel PCI, if we do a FFR guided revascularization, approximately 14% of patients actually become less of the triple vessel disease from a functional point of view. So you might be doing a FFR guided revascularization to a triple vessel disease, and you may actually land up doing just a double vessel angioplasty, and one of the lesions might not be significant as well. The Ripcord study showed that FFR changed our angiographic treatment plan in 26% of the patients. And as I discussed, there are certain non-hyperemic pressure ratios which we use peculiarly in patients, those who are not tolerating adenosine or those who are not eligible for adenosine. And these non-hyperemic indices like RFR or IFR are especially important in tandem lesions, diffuse lesions, acute coronary syndromes where FFR has less predictive value. However, we should not be using non-hyperemic indices in a left main coronary artery, systolic dysfunction, and post-PCI assessment or side branch interrogation. We always believe that eventually, as our technique improves, the anatomy and physiology should match. If the diameter stenosis is more than 50%, we do expect a positive FFR. If the diameter stenosis is less than 50%, we expect a negative FFR. So these are the patients where both the modalities tend to guide us towards treating or deferring the lesion. However, there might be discordance between these two outcomes. If we have a angiographically significant disease and the FFR comes negative, this is a false positive guidance of the angiogram, and this is known as mismatch. Then there is another term known as reverse mismatch, in which we undertreat the patient because the diameter stenosis is looking less than 50%, but the FFR is positive. And mind it, this is the truth, and we need to realize and accept this fact if we want to treat the patient. This visual functional mismatch may be seen in approximately 40% of our patients, more so in the left main bifurcation category when we are assessing the side branch, less so in the non-left main bifurcation category. I'll exemplify with the example. So this is a left main to a LED stent done for an acute coronary syndrome in a postmenopausal woman. We had a huge LCX as a side branch at a stake. There is a proximal left circumflex disease, but the ostia did not look much involved. But subsequent to stenting, there was ostial pinching of the left circumflex. So this is the OCT pullback taken, and this OCT pullback showed a 3D bifurcation view of that ostium that showed a pretty well roomy ostia looking angiographically to be diseased. And you can see in the 3D view even a double carina made by a crossing strut. So we just passed on the wire towards the left circumflex, documented that with this MLA of 2.53 millimeter square, our FFR was negative. It came out to be 0.26. So this is again another kind of a disclosure, and it has been recommended that if you are doing left main to LED crossover stenting, and if the LCX ostium has a MLA of 3.7 millimeter square and a plaque burden of less than 56% stenosis, there is a negative predictive value of 100% that you will have a LCX compromise. So this is one of the ways how you can guide your treatment, like in this case of this visual functional mismatch, where both these modalities kind of helped us. But yes, as with every modality, FFR does has its limitation. There are situations when we really need to know the anatomy and morphology of the lesions. And certain lesions, just like ACS and serial lesions, actually fly egg dissection, suboptimal expansion of the stent. They all fly beneath the FFR radar. And here comes the important when we really wish to dive into the artery, see the morphology. And as it was discussed, I would just discuss the basics. The details have been discussed, but we would like to see the morphology. Again, I'll go from FFR to combination of FFR and imaging, and then imaging alone. So this is a 54-year-old male post angioplasty to one lesion. We saw this patient in the COVID era in 2020. He was diabetic, presented to us with unstable angina. So we see two tandem lesions. One is osteoproximal LED and another is mid LED. Again, we need to be sure which lesion is hemodynamically more important. We take a FFR to start with. It is 0.72. We fix the distal lesion first on the basis of OCT, which had a larger luminal stenosis. And after fixing that stenosis, we get a negative FFR. But more proximally, what we could see was an eccentric plaque. So as sir said in the previous talk, that OCT is an image you immediately pick up beautifully. So you see an eccentric plaque proximally. you can see very bright punctate spots with background shadowing, and OCT has a resolution at par to histology. These are nothing but type 2 macrophages. So this is another beauty of OCT to tell about the inflammatory burden of that lesion. So we did this presentation in EuroPCR as one of those images. So these are M2 macrophages. Another important thing to understand about atherosclerosis is the reason of the progression of a plaque is often healing of a plaque itself. So healing of a plaque needs to be understood, especially if our patient is having recurrent symptoms. Talking about the tug of war between FFR and OCT, yes, we have one study known as the Forza study in which FFR guided PCI was compared to OCT guided PCI. And it was seen that at 13-month follow-up, patients with FFR had more MACE as compared to OCT, however, definitely with lesser number of stents. So shifting my talk towards basics of intracoronary imaging, both IVUS and OCT have had their own journey. Both journeys started in 1991, but IVUS gained earlier acceptance into the recommendation as early as 2006. But we have to be proudly accepting that in ACS, both imaging modalities got a class 1 recommendation in 2021 and in CCS in 2024. Coming especially to ACS, the role of intracoronary imaging cannot be less exemplified. Definitely, if you have a clear culprit, you can go ahead and do your PCI. But you all know that there are ambiguous angiograms. There are angiograms in which you are not able to point a finger towards which is the culprit lesion. And you can confirm that plaque event for a type 1 MI by intracoronary imaging. And here we discuss the vulnerability concept. This case actually opened my eyes also. Please see this case very carefully. 52-year-old male, a history of chest pain for 3 days. Angiogram showed a beautiful left-sided coronary artery, and the RCA had mid-severe disease. So did a conventional PCI to RCA, went home back. And after a few hours, not few hours, maybe around 12 hours, the resident called up and said the patient has chest pain and there is ST elevation in anterior leads. I'm showing it as a surprise because we have to accept this fact that ACS occurs in non-obstructive vessels as well, those who have vulnerable plaques that are missed by a routine angiogram. And it was a surprise that the LED was occluded. So we did thromboaspiration, did a imaging run by IVUS, and we could appreciate just a 30% plaque. So what you can appreciate a small calcific plate at around 10 o'clock. This is the conventional way of describing a cut section of an image, both in OCT and IVUS. And at around 5 o'clock, you can appreciate a necrotic core and a residual thrombus. That led to a development of this acute coronary syndrome event. So talking about vulnerable plaques as I go, it's very easy to define on OCT with a thin cap fibroatheroma thickness of less than 65 microns. But the definition of IVUS is much less disseminated in the Cardiological Society. By the modality of IVUS, fibroatheroma is defined by presence of more than 10% confluent necrotic core. That means if you see a fibroatheroma and it has a necrotic core of just more than 10%, it classifies to be a fibroatheroma. And if this necrotic core is abutting the lumen by just 30 degrees, this may be classified as an equivalent to TCFA. Talking about evidence, we have data from ADAPT-DES and IVUS XPL studies that in around 8,000 and 1,600 patients respectively that showed IVUS shows dramatic outcome benefits, and you change your procedure 74% of the time if you use IVUS. Just 26% of the time you do the same thing, but otherwise you change your procedure. Cost effectiveness is pretty good if we see over the long term. IVUS is a mature technology, although there is a learning tool to it. None of you seem to be happy seeing those gray images, but we'll try to figure out a way how we can do it better with it. Basically, it's just a particle displacement animation. I'll try to make you skip these slides, but just that it maps to a grayscale. Talking about basics, how to identify, I think so. If we start annotating our images in our early career, it really helps. Make a lumen picture. All the plaques are intimomedial. Try to identify the adventitia. EEM is our purpose. I've not written this, but I would like this to be one of the take home points. External elastic lamina pointing out and understanding it, it's extremely important. So this is the cross-sectional image, and this is the L image, the longitudinal image. We have two types of IVUS catheter, the mechanical transducers, the phased array transducer. Both of them come with their own shortcomings, but both of them work almost similarly. I'll show you the figures subsequently. Again, annotating the images. How IVUS typically guides our procedure. In the pre-intervention, it helps us assess the area stenosis, plaque burden, MLA, plaque composition. So if we match to the grayscale, the calcific plaque has a appearance, echolucency similar to the adventitia. And a fatty plaque is extremely dark. And between them is the fibrocalcific and the fibrous plaque. So starting with a soft fatty plaque, it's not as bright as adventitia, it's hypoechoic. It may have a necrotic zone, intramural hemorrhage, or a thrombus as a DD. The fibrous plaque may have attenuation. As discussed in the earlier talk, the calcified plaque may cause reverberations, especially if it is thin. But more importantly, it causes acoustic shadowing beneath that. Shadowing is also a feature of attenuation, and it may happen deep or superficially. And superficial attenuation may be a harbinger of a subsequent thin cap fibroatheroma that may rupture subsequently. Then the plaques may be concentric or it may be eccentric. And then there is another phenomena known as Glagov's phenomena, that is known as positive remodeling of a vessel, that allows maintenance of the lumen area as the disease or the plaque progresses. You can appreciate the heterogeneous nature of the plaque, the equilucency of the core distally, and more proximally, it's a thicker cap. So it may be an equivalent. We just discussed about this Glagov phenomena known as positive remodeling. And another phenomena is negative remodeling, which is seen in chronic CTOs as well. All this helps us devise our interventional device and the aggression with which we will be using our interventional device. Post-stenting, the MSA criteria is extremely important. What I really like about this music criteria is that it's actually takes an average reference lumen area of more than 90%, or 100% of the reference segment if the MSA is less than 9 millimeters square, and more than 80% and 90% respectively if the MSA is more than 9 millimeters square. Apposition, as discussed earlier, it's more difficult to see with IVUS, but if you annotate your images, it's pretty easy. I'll just rush through these slides, just have a look at these slides, feel confused, but the moment you annotate, you try to actually understand. So that's what I want to say, that try annotating your images by your own self. It's very easy. Point a finger on it and say, this is fibrotic plaque, this is possibly lipidic core, this is possibly calcium. And once you start doing it, you'll be able to understand this grayscale images much more easily. Dissections discussed. Definitely, if we compare this with OCT, OCT is pretty much easy. Seeing a vulnerable plaque with a thin cap fibroatheroma is pretty easy with a thickness of less than 65 microns. Macrophages we've already discussed. Seeing thrombus is pretty easy. Definitely high resolution imaging is easier. So it's time for YOLO, as they say. You only look once. You just look once and you say, okay, this is what it is. Rather than in IVUS, you spend more time. It uses light, not sound. This is again a similar B mode and L mode. We have beautiful various views. One is a tissue plus lumen mode, a lumen mode, a stent only mode, and even a fly through mode. And there is a beautiful MLD max algorithm given by by the OCT guys, and which has been improvised. I'll
talk about that towards the end of my talk. Again, it changes 86% of our approaches in various lesions, lesser time spent. And this is, as I just said, it's the YOLO approach. You only look once. You just look once. This is the fly-through 3D image. You are able to see the side branch. You are able to see the ostia. You can see the side branch wiring going through that ostia. A case example of a patient with inferior wall MI, we aspirate the thrombus, take a post-thrombectomy OCT run, and you see actually what the plaque pathology is. Plaque pathology is not only limited only at the site of occlusion, even more proximally, you have plaque ruptures that needs to be covered. So it can really guide our intervention, reduce our MACE over the long term as well. So this is a simplified OCT algorithm for plaque identification. The first question you have to ask yourself is, can I see the intima, media, and adventitia all across? If the answer is yes, it's either a normal artery if there is no plaque, and if there is a plaque, it's a fibrotic plaque. And if there is an irregularity, whether it's in the lumen or in the wall, if it's in the lumen and it has got low penetration, it's a red thrombus. At high penetration, it's a white thrombus. If it's in the wall, if it has low penetration, it has murky irregular borders, it's a lipid plaque. And if it has got a very sharp delineated borders, it's a calcific plaque. It is as simple as that. You just learn the learning curve is pretty fast. You just have to put a finger on the big three, the all other comes subsequently. It may also even guide your lesion preparation, direct stenting for a lipidic plaque, atherectomy with the rule of 5 or rule of 3, maybe it has been discussed earlier, for severe calcific plaque. Limitations, we should talk about the limitations when we are treating. So don't overtreat. Seeing the plaque doesn't mean treating it. If we see a spontaneous coronary artery dissection on an OCT, best leave it on medical management and see if on a subsequent angiogram, if it is not a flow limiting. Like in this case, you can see a beautiful intramural hematoma between the two layers. It can be managed medically. This has already been discussed. Limitations of FFR. We don't use FFR well in the post-PCI strategy. So there is a strategy known as PIOS, physiology guided incremental optimization strategy. So it's as I just said, FFR before PCI and OCT after PCI, it's a very reductive approach. MLD max is also a reductive approach, and we are moving towards MPLD max P from MLD max. So it is morphology, physiology, length, diameter to strategize our procedure, and medial dissection, apposition, expansion, and again physiology to guide our post-PCI outcomes. In conclusion, FFR and OCT represent the yin and yang of coronary intervention. They are perfectly complementary, and we'll get away with those mismatches if we image and do physiological assessment together. And Forza and combined OCT actually open doors to this understanding. So let's not compare apples and oranges. Let's eat them both. And the future may have more in store. There is something called as nurse IVUS that gives you a chemogram or the lipid plaque, about the information about the lipid plaque. And we are, besides anatomy, that is OCT, besides FFR, that is functional evaluation, we also have biomechanical variables that may guide our technique, that is endothelial shear stress. And I'll conclude this talk that FFR represents truth and OCT or IVUS represents clarity, and they are beautifully complementary. Thank you very much.
Very good talk. Thank you, Tanush, for covering all that in detail. I think it reverse would have been better if you told all the basics very well, though we exceeded little time. But I think all the points, can you get that? Points are covered very well. And just to supplement further, after each talk, I will show some snippets which are more clinically relevant, with some examples of cases and things like that. I would add up. But how many of you now feel, if you're given a choice, which one you'd prefer after all the three talks? IVUS, who wants IVUS? Raise your hands. Yeah. Who wants OCT? Oh, good. I bet people are also sitting here and they would be happy. Then OCT actually looks more rosy, more lucrative, and the pictures are quite attractive. And then more clarity, I would agree that it is learning curve is less. But life is always a mixture bag of both. Learning curve is less. Images once you get are good, but they're difficult to acquire. Once you get IVAS, how many ever times you want to pass in, take it in, out, how many ever times you want to do it, you can do it without causing any inconvenience, neither to operator nor to the patients, right? So that's a easiness of using of IVAS. Can you get this slides there? And then as I've told, I think more of you must be having exposed to IVAS, or how many are exposed to OCT, how many to IVAS? How many to IVAS in your labs? Okay. OCT? I think both are equally coming. As I've already, many of the things are already covered. I didn't want to go into details again, tell the same. But anything, diagnostic lesion severity assessment is again coming up as very important thing, because many of the times we tend to actually stent unnecessary lesions. And don't think that using imaging always makes you do more. Sometimes it's the other way around also, we came to know. Because areas, unless the osteal left main, we know the standard criteria is less than 5.9, we want to treat, and if you want to remember roughly at least 6. But osteal LAD is, unless you're going down to less than 3 or osteal LCX to that, then FFRs are coming negative. So imaging also, if your area is coming more, then I get you can actually leave it. So that is another indication where usage of imaging could simplify things. You have a middle LAD lesion, you have osteal LAD lesion. If osteal was important, you could do crossover and becomes very complex. Sometimes osteal LAD lesion becomes a diagonal, the area is more, you leave it and just do a middle LAD stenting. So that way it can sometimes simplify also. All other things like precision PCI, stent optimization, complication assessment with edge dissection, all that is very well covered. I won't go into details again to bother you more. But what I wanted to also tell you people is, in daily practice, which one to use when, not which one is better. 80% of the times, most of them are interchangeable, but which one to use when is what you need to know. Actually sick patients with LV dysfunction, serum creatinines being high, then probably always prefer only IVAS. In sick patients with LV dysfunction, if you put on contrast, patient will worsen on table, we are going to LVF. Please keep this in mind. And then stable patients, normal renal function, then probably you want to get attractive pictures. OCT is good, right? Stable AMI, stable hemodynamics, it's okay. But sometimes ACS scenarios, now you get more and more indication for OCT, by where you want to check for plaque erosion versus dissection, or the underlying plaque or only erosion. If it's only erosion, we tend to leave it with suction. But if it's again dissection with the underlying plaque, we tend to stent it. That's why more data is coming up. Anatomical lesions, I think, is already covered very well by earlier speakers. But instant restenosis is one, I think OCT clearly scores over IVAS. And CTOs also is not covered because not coming up yet. But catheters with a crystal at the end, now that is coming up, CTOs, but sometimes it helps in cap penetration and things like that. Precision PCI learning curve is a little more for IVAS, and crystal clear pictures, OCT. What do you think is the most probable? Now it has become class 1, but why is it not picking up still, you feel? What is the most important, difficult problem with imaging, you feel? Anybody can tell? What is the most problem? The problem is, once you get good images, interpretation is okay, but sometimes the where you need it most, the catheters don't go. The calcified lesions, sometimes there is tracking of the catheter gets spread out, all that problems in real world practice. That is not covered, just to highlight the importance of imaging, but you should know that. When there's a calcified lesion, where you're likely to get the most is the catheter doesn't go. We need to take balloon, we need to prepare the bed a little for it to go, and then you do it. So, but what I research as an end user we want is, we don't want both IVAS and OCT coming onto one catheter. That is already coming into picture. And where you have interpretation of both, but the catheter is slightly more bulky. But we want more catheters which are easily user-friendly, which can go to image. So that's what, as a clinician, we want more and more to happen. Then many times the stent under expansion is mentioned in this imaging. They are defined as two ways, as this absolute areas you remember. If any area is less than 4.5, please don't accept it, because area wise, you measure the areas. If it is more than 5.5, it is good. Then relative stent expansion, this is again told 80% of the average area, but more than 90%, is what we want, but is difficult to achieve sometimes. This other thing I wanted you to understand the concept, stent under expansion. This is again covered well. And this is seen under expansions, but mala positions is again told well. This is again a slide which is not there in many of the things. You can mention it. Ideally, which stent you use, how much is the area you need to get, how do you decide whether it is optimal, ideal, or under expanded is with this. There's no great science in this. Initially, I thought how they got these areas. It is just pi r square formula. If it is 2.5, we do pi r square. What is the area which you get? We come to this. If it is 3 pi r square, again, what is the area you get? It is that. So half the diameter, then pi r square. If you get it optimal, more than that, that is ideal area. Sometimes under expansion, these values. So please remember this figure of 4.5, less than 4.5 square millimeter. Please don't accept it. You have to act on it to do something. And one more thing I wanted to mention in the imaging thing is just to keep understanding and write a report, like how you write an angiogram report. If you make an imaging report, that helps you to rethink what you have done for. What is the indication for which you have done imaging? Number one. Number two, what is the equipment which you used? What type of catheter, whether you pre-treated with nitroglycerin, things like that. Then the third thing is, what are the findings which you got pre, and what is the action which you did and post, and finally highlight that area of what you got. That is the most important thing, outcomes measured. If you get absolutely good values, you get a good results and follow-up. I think you need to inculcate that habit of writing the reports for imaging too. So we also try to do it. Our fellows also sometimes do, sometimes not. So this is importance. No more fancy things like my eyes can see everything and I don't need imaging. All that is gone. It's all bullshit now. It is proven beyond doubt and has become a class 1 indication. So all this, the dreaded complications like stent thrombosis, mortality, all significantly decreased by imaging. And poor man's imaging, that's what is you said is the stent, what do you call the stent whiz or stent boost, whatever you call the different companies, clear boost. See that so much of under expansion. Nowadays, bed preparation is very important. Even the balloons don't go sometimes, but stents go. Take it from me. And that's why bed preparation is very important here, inadvertently prepared before. Later, such a long stent is put, but again, still see the stent is under expanded. So you don't need great imaging also. In that case, you can do it, but sometimes imaging catheter won't go there. So you need to optimally dilate it, then keep it, and finally the OPN at 40 atmospheres is open. So this sort of thing also helps, like poor man's IVUS, I could call. This is what I mentioned about stent expansion limit. Please keep this in your lab, all of you, because once the stent, how much the area which you should not cross, we should keep. I think those are things like some of the things like the interesting images like stent hematomas, how it is easily seen, also not shown. I thought I would just mention. This CKD's concept, again, ISR treatment concepts will cover up at the end. I think with this, I'll stop. Many of you have any questions, please feel free to discuss. I want some discussion to happen on this important imaging modality. Otherwise, we'll go to the ASCII. I think all of you are eager to know because you need to become comfortable with the presentation patterns of ASCII. And then also, you can close this. Madam will speak first. We requested Dr. Pragati, who's just fresh from that, to she will present. I'll add up something in the end. But before we go on to those ASCII sessions, which are highlight of this year, which were not done before, any questions or comments on imaging, please? How many of you in your lab started writing the areas post-tenting after image? Please follow this. It's very important to write absolute areas. If you are good, then probably the most important single positive predictor outcome is getting a good absolute area, stent area. So even if stent is little underexpanded, little malopposed, I'm not suggesting it should be, but if areas are good, that's where we need to leave it, because we also need to know when not to aggressively do further, because it might lead to rupture, things like that. So if you get a reasonably good area, especially in presence of calcium nodules, you don't get a circular area. That is again a problem, but still the areas overall are good, then you tend to leave it. So if time permits, I'll show some snippets on calcium nodules too. With this, I'll stop and request, we'll go on to ASCII. You want to do it?
Yeah.
Okay, thank you. Any question? Because I thought many of you had some doubts, wanted to ask questions after the first talk. Some questions are coming from there. feel free to ask. Balloon uncrossable lesion approach, you are asking. Actually, when there's no balloon is going, there's nothing else you can do but for rotablation. Then nowadays, you have orbital atherectomy, that also sometimes more next best after rotational atherectomy. Then orbital atherectomy is good for proximal lesions, bigger vessels and more diameters. The advantage of it is only one catheter can do for both 80 and 120 vibrations. So that is your more cost effective. And rotablation, you should become comfortable. Please, just because you saw it here, don't start using it, because unless you are comfortable with, otherwise the burr stuck phenomena is more common with rotablation. If you want a beginner, you want to learn, orbital atherectomy is more user friendly. Practice on that because it cuts both antegrade and retrograde. That's why the problems of getting stuck is less. But don't go by always what is told that ruptures are not common, hematomas are not common. If you are not very careful, still it could happen with that. The beauty of orbital atherectomy over rotational atherectomy is the Viper wire, which is there with orbital atherectomy, is more user-friendly wire. You can directly use it without exchanging with a regular workhorse wire with microcatheter also. But if you can do it, with the luxury of it, you do it. So that is the advantage of orbital atherectomy or rotational atherectomy. Once you do it and take some pathway, again, you have to use NC balloons and make appropriate areas. After preparation also, after making IVL or rotational atherectomy or orbital atherectomy, you have to take appropriate sized NC balloons and prepare the bed well again. Just because you did, don't take the stent directly, because you need to again get areas, good areas before you take the stent. Then you take the stent. If you can image it afterwards, show the dissections, areas expanded, it is good. Then take the stent. So don't directly take the stent after the rotational atherectomy or orbital atherectomy. You need to again take NC balloon, crack it, and appropriate 1:1 sized NC balloons. And for the opium balloon, again, I mentioned, size should be kept under control. Pressure, you should go up. You can go up. Those are some of the things I thought I would just tell you. Again, stress on calcium bed preparation and usage of these various devices. If any of you have any doubts, questions, comments, or bad experiences, can anybody tell one bad experience, what you faced and how you tackled complication session is coming up. We'll tell more. But some peculiar complication you had when you used the imaging catheter? Anybody? Just because I'm asking, at least somebody can get up. I'll tell you so many. Okay, it's not to hide, because we have to learn from others' mistakes. The most commonest you get is a spasm. We don't give nitroglycerin, the lumens areas will come down. Next commonest, I would say, it won't go, catheter won't go. Third commonest is, if you are not careful, the wires may come out of the catheter. If you are pushing it too much, then both will get entangled and both you have to get it out. So those various things, the complications of imaging also is a complication we can discuss further. I think I don't want to dreadfully trouble you too much with the complications of imaging, but you need to understand it comes with a package. But if you do it well, there are a lot of advantages and become a class 1 indication. With this, I'll stop and we'll proceed to further. Thank you.
Thank you so much. Please give a loud round of applause. I would, before we start on to the next session, I would invite Dr. Tanuj Bhatia on the stage for felicitation. And he would be felicitated by Mr. Anirban Chatterjee. Please.
कौन सा PPT है? What's our answer? Which one? One. This one, right? This one, right?
Thank you so much. The next session is on a review of OSCI set visuals, where it would be an interactive discussion, and it would be taken by Dr. Pragati. Can we have the CV slide, please? So Dr. Pragati is a consultant interventional cardiologist at AIG Hospital, Hyderabad. She is also the academic coordinator for cardiovascular sciences, Hyderabad. She is a member of Academy of Cardiac Imaging Society, Telangana chapter, and also she is interested in advanced cardiac imaging. Over to you, Dr. Pragati.
Good evening, everyone. And firstly, I would like to thank you all for this opportunity. So we will have a little brain tapping session. So I want this to be an interactive session. Please, I hope mics are issued. Mics are issued. So every question, I need volunteers. We'll start with what is FCCC? You're attending this course. So what is FCCC?
Actually, it is a mnemonic which we started before, and then it changed to Upgradio. It's FACS Cardiovascular Research Foundation Cardiology Clinics. Then we continued because then Lupin, once it took over that, then it became Upgradio. I think PG is highlighting that they wanted that, so that's why we kept both. Thank you for all of you to join, and hope you're all enjoying it and like it further. And then what is ASCII, you know? Yeah? Sorry? Yeah, sometimes some people call it a OCSE also. Clinical can come before and structure evaluation can come later. I think let us hear more about it from her. Thank
The
you.
first answer is given by the course director. Thank you, sir. So we'll just run through the cases, few clinical cases. I would just brief and I want an active interaction. So here is a 65-year gentleman. He's known diabetic, hypertensive, known CAD, underwent revascularization multiple times. With recent acute coronary syndrome, unstable angina, he underwent complex angioplasty because he had an instant restenosis in his LAD stent. And after that, following the procedure, 2 weeks later, he started to develop severe high-grade fevers that persisted for a very long time. So he gradually went into sepsis, shock. He was partially treated outside for quite some time, a month over. He was tubed. He went on renal replacement therapy. Gradually, he was extubated and he was shifted to us for further management. So we evaluated him further, which showed so we have taken a multimodality approach because his Tudiko showed mild collection of pericardial fluid, so which was slightly curious, and we went with a multi-modality imaging approach. So this is his angiogram. Again, this is his CT. If you can see the asterisks there. So, what is your diagnosis? What is this condition called as, and what is the management going to be? Sorry? Septic aneurysm? Partly correct. It's called as mycotic aneurysm. Why is it called as mycotic aneurysm? It is not the fungal infection, but the growth, outpouch is like that simulates. So it is coined as mycotic aneurysm. So this is an acute infection. Can be because of bacterial, fungal, or any kind of viral infection. So it can be seen in conditions with extreme immune suppression, patients with leukemia, HIV, SLE, or chronic indwelling catheters, or patients undergoing renal replacement therapies, or a procedural device contamination, or infected access sites, or hematomas, and pseudoaneurysms, delayed bleeding and prolonged arterial sheaths, and multiple interventions in a short period. So very complex to treat and very poor prognosis. So we need to have an eye for it. So we need to know that there is a condition like this exists, because we lost a patient. This patient we lost despite we sending him for surgery also, because post-op also they don't actually do well. So there are multiple causes for the genesis. First will be the embolic blockade of the normal arterial wall, or direct sepsis, or immunological mediated complexes. So he underwent an aneurysmectomy, the pus was evacuated, and the stent was retrieved, the artery was ligated, and a graft was given. The surgery went fantastic, but we lost the patient. Yes. So what do you see here? What is the procedure being done? No, what is the procedure being done? The first one, the first video. One at a time. Can somebody hold the mic and speak up? What is the first video and what is the second one? Let's say, what is the device? Okay. Here's the device, one correct answer. Next. What does the echo show? That's the air. That's the air. But this is a 45-year male. He was kind of obese, so he was constantly retching and he was continuously coughing during the procedure. So this is what has happened. During the procedure, we see there's a lot of air in the right-sided chambers, and you see a free-floating air. Luckily, this happened post-device deployment. It was a large device sitting there, and post-device deployment also, during the retrieval of the sheath, he did a kind of Valsalva-like thing. He retched, and this is what has happened. There was brief hemodynamic instability, but we identified the condition immediately and we could rescue the patient. So most of the times it is conservative. However, if the patient if the patient needs, we may have to give mechanical ventilatory support and conservative management till the patient recovers. So this patient developed a massive pulmonary and systemic air embolism, and it is a rare but fatal complication during ASD closure. More so in larger devices. So the management will include immediate head low. First thing, immediate identification of the complication. Next, immediate head low position and ventilation with 100% oxygen, CPR if required. And early identification, we can rescue more than 98% of the patients. Next, name the plaque modifying balloons. I think this must be easy for you. First one. Scoring balloon. So what are the characteristics of scoring balloon? Yes. What is the second one? The first one, you have nitinol wiring, laser cut nitinol wired around the balloon. Okay. So yeah, it is a scoring balloon. The second one. What is the third one and fourth one?
IVL and flaring balloon. Flaring balloon. Flaring balloon.
Sorry?
Flaring balloon.
Spiral balloon.
Flaring. Ostial flaring balloon is the.
The last one. Yes, correct. The last one is ostial flaring balloon. The second one is the chocolate balloon. It's a chocolate balloon. It has a constraining structure all around it. That's a nitinol constrictor. And it's a kind of semi-compliant balloon. So all of them are plaque modifying balloons. So this is the cutting balloon. The third one is the cutting balloon. So it has 3 to 4 arteriotomes which produces controlled dissections and more so helpful in calcified vessels or fibrocalcific lesions for adequate lesion preparation. And this is the ostial flaring balloon. Unluckily, we don't have this yet into usage in our country. So it has 2 balloons, proximal one and distal one, proximal compliant and distal semi-compliant one. And if you see, there are 3 markers here. So you make sure you position the middle marker at the stent edge. And if you see the compliant balloon, the proximal balloon, it inflates the proximal stent edge and it makes sure it is approximated well. So the future coronary access becomes easy with this. Again, so what is the device that you see here? What is the device? Sorry? One at a time? No, what is the device? Mechanical? Bileaflet? Where is it sitting? What is the position? Oh, right, mitral, correct. So what is the position? What is the procedure being done there? What is the course of the wire? Stuck. That's a stuck prosthetic valve. One of the leaflet is stuck. So what are we doing here? Balloon dilation. So it's a slightly conservative approach in acute condition when the patient is actually destabilized. So this is what we did, and we could make the leaflet open partially, but eventually the patient needed a mitral valve replacement. What is the course of the wire here? What is the course of the wire? Mm-hmm. Mm-hmm. It's like PDA? Huh? It's like PBMB. PBMB. Where is the wire going? So most of the times, yeah. Yes? Yes, yes, it's going into the aorta. So here we have used a angioplasty wire only. And this is a 2.5 mm balloon. So usually undersize the balloon. You can go across the valve or by the side of the valve. So this patient gave us some time after this procedure. And after stabilization, we send him for a redo surgery because the valve tends to degenerate faster after this. So here, these are the complications that we see very frequently. So what is this complication that we see? Yes, dissection causing acute vessel closure. It's a dissection causing acute vessel closure following contrast injection. So where do you expect such complications? Where do you expect such complications? There is no stent here. Catheter induced. Catheter induced. Sometimes probably vessels that have vasculitis like picture or vessels with fibromuscular dysplasias, fragile vessels. This can happen. And this we see post-primary angioplasties most of the time. These are the clots there. Yeah. What's the complication here? An air embolism. So what is the management for air embolism? 100% oxygen. Vasodilators. And what if there is a large volume of air that is injected? Yeah. Yeah. Faint answers. I can't hear actually. I can't hear. I can't hear. So most of the times it is supportive therapy. Just in case if the patient undergoes, if the patient has hemodynamic instability, we have to act accordingly. So what is this? What is the hemodynamic tracing? What does the ECG show? What do you expect after this? The patient seized on table after this. Okay, so it's an arrhythmia. So patient had VFib after contrast injection. So what are the measures that can be taken to prevent this? Measures to be taken to prevent this. Aspiration. And decrease the catheter. Retrieve the catheter. Okay, if there is staining, retrieve the catheter. Don't give further contrast because it's a kind of ischemia that you're inducing because the contrast will replace the bloodstream there. Okay. So here, one case scenario, similar scenarios. So 75-year male, diabetic, hypertensive, known CKD, hypothyroid with occasional chest pain. He came to us with sudden loss of consciousness. And he had a TPI, which was given in an outside hospital. So this is his angiogram. It's the first one, see it carefully. And a similar patient, he had exertional angina. Post TMT, his angina worsened, and this is his angiogram. What do you see? Both the cases. SCAD? Yes, SCAD. What is the type? Is the first one like and second one like? What is the first one like? The classification is given by? The first one we couldn't do an intravascular imaging. The second one we could do. So what is the intracoronary imaging findings? What are these lesions? Yeah, this is intramural hematoma. If you see different areas, there is intramural hematoma. So you see there's good, this is well defined and crescentic shape, and there is intramural collection of blood. This is called intramural hematoma. So what are you going to do with these lesions? Medical, all of them. So what is the medical treatment going to be? Okay. What is the medical management? What is an aggressive therapy in such lesions? How do you classify them? Where do you medically manage these patients? Anticoagulation, will it help? May not be. It may worsen the IMH. But dual antiplatelet, yes, but yet there is no role of, there are no adequate studies on prasugrel anticoagular. And what more drugs can be given? Statins can be given. Beta blockers can be given. They decrease the wall stress, shear stress, and they decrease the extent of dissection and dissection progression, I mean. Next. Where do you stent? Okay. Okay. So you need to look at the patient profile, most important. So what is the patient profile like? Is the patient hemodynamically stable or unstable? Hemodynamic instability or persistent and severe angina. Third most important thing, grave anatomical features. What will be the grave anatomical features in SCAD? What are the grave or high-risk subset features? So left main dissection causing significant luminal compromise or complete vessel closure, causing hemodynamic compromise or refractory angina or persistent arrhythmias. And what is the revascularization modality going to be? Is it CABG or angioplasty? CABG? Okay. What if the dissection extend to the distal vessel? And as well, there is antegrade flow also. So there is like highly likely that the graft will get occluded. CABG is still plus or minus. We don't know its efficacy. How about angioplasty if we ever have to do? So first one is usage of a cutting balloon. Yes, correct. Next. What more can we do? So what happens? It decompresses, it just dissects the artery internally, it dissects the intima, and it causes the IMH, the hematoma to drain into the lumen. Yes, and it decreases the luminal compression. You can just do a cutting balloon and just leave it. So the balloon size has to be 1:1. And next, you can do limited angioplasty or sequential angioplasty. Limited angioplasty is if you can never be able to trace the proximal dissection flap, you can just seal it, okay, with limited angioplasty. Or sequential angioplasty, you can, if you're lucky enough, if you can see the entry and exit points, you can seal the proximal and the distal points, okay. What are the types going to be? Types, type 1, the first one that you saw is type 1. So extensive spiral dissections, significant luminal filling defects. And type 2A is going to be a long segment disease. You can have islands of normal areas also in that. And type 2B will be rat tailing. That is a long segment involving the distal most artery causing rat tailing. And type 3 will be focal narrowing. This is the most confusing SCAD that we ever see. That simulates the atherosclerotic plaque. Only intracoronary imaging can differentiate. Okay. And type 4 is acute vessel closure. Okay, this is a clinical profile. 39-year-old lady came with complaints of palpitations, known MVP. She's being managed medically with beta blockers and antiarrhythmics. Again, suddenly one day she comes with syncope and her Holter shows 6% VPC burden. So please look at the images. What do you find? Mad, great. So what are the features of MAD? What are the echocardiographic features of MAD? Mm. Mm-hmm. And what more you see here? Do you see the systolic curling? How will you define MAD? Is there any arrhythmic risk associated with MAD? Yes, there is very high risk of arrhythmias and sudden cardiac death in patients with mitral annular disjunction. Okay. That is because there will be extreme pull and fibrosis of the, there's a hypothesis called the Padua hypothesis, which explains the arrhythmia risk in MAD, people with MAD. I will skip the slides. So MRA is very important in diagnosing this. So what happens, there is systolic curling motion, abnormal mitral leaflet traction. So there is significant and continuous traction and stretch of the posterobasal and papillary muscles, and degenerated mitral valve altogether contribute to significant malignant ventricular arrhythmias. So how will you treat these patients? Will antiarrhythmics help? What is the mode of treatment? EP study is of doubtful role. Medical therapy. How are you going to treat antiarrhythmic agents? Doubtful role. Beta blockers and calcium channel blockers. Yes, they may help. And what more? Device therapy is still a class 2A indication as secondary prophylaxis. Next, radiofrequency ablation plus or minus. Yes, one patient, we gave an ICD, post ICD also, patient had malignant arrhythmias, unluckily. And after that, she underwent a surgery. So after surgery, she is doing well. 5 years post-op, she is doing well. So this is the management. Okay. So identify the devices and their clinical application, please. First one, second one, third one. Good. Third one is the easiest. It's like an umbrella, inverted umbrella. These are septal occluders, interatrial septal devices, are simply called as, used in refractory heart failure, only for symptomatic treatment in patients with severe pulmonary artery hypertension or RV dysfunction. Whenever the RV pressures go high, so the septal occluder is placed in the interatrial septum so that there can be to and fro of blood circulation depending on the pressures, ventricular pressures, at the expense of desaturation, systemic desaturation. And what is the third device? This is an IVC filter. This is an IVC filter. So what are the indications of IVC filter? Indications of IVC filter? Where do you use IVC filter?
Anticoagulation is
DVT.
contraindicated.
Anticoagulation is contraindicated, or despite being on adequate anticoagulation, patient is continuously having recurrent PTEs. Yes. And what are the relative indications or prophylactic indications? There is no level of evidence. However, chronically bedridden patients, malignancy patients, or somebody undergoing a morbid surgery, you can use it prophylactically. Okay, what is the procedure? Elaborate it. What are the indications? What is it? Can't hear. Enhanced external counterpulsation. Now people are saying no need of angioplasty, no need of CABG. CAD will just be treated like that with these cuffs. True? How many patients with significant coronary artery disease will we send for this procedure? I mean, this treatment. Okay, this is enhanced external counterpulsation for those patients with refractory angina and non-revascularizable arteries, or we have indications for that. So what we do, we give serial pneumatic compressions to calf, thighs, and buttocks. So these pneumatic compressions, they inflate and deflate at serial intervals. Okay, so these are ECG gated, ECG timed with ECG. So during the late diastole, they inflate. So what they do is, over a period of time, there will be diastolic augmentation. So over a period of time, there will be increased coronary blood flow. That's the hypothesis. Yes, maybe few patients have a symptomatic benefit with this. So I'm skipping all the slides in the want of time. That's how the cuffs are connected. So the indications being chronic CAD, non-revascularizable arteries, or somebody, we want to prepare them for revascularization with severe LV dysfunction and hibernating myocardium, and heart failure and cardiac X syndrome. Okay, simple, easy. What is this? What is the procedure, complication, and how are you going to manage this? We're running out of time. What do you see there? Two mesh-like things. So what is the device? I thought all of you would shout. This is very easy. What is that valve there? TAVI valve. What is the other valve there? That is also TAVI valve. It's an embolized device. The proximal one is an embolized device. Okay, this is a device embolization. So how can you expect a device embolization, or how can you anticipate? How can you prevent this? So you have multiple etiological factors considering the anatomy. Let's say horizontal aorta or severely calcified valve, or bulky valve, or most often common with undersized valves. Okay, or if it is interfering with the LV structures, like significant LV hypertrophy or pre-existing mitral prosthesis. And what are the technical factors? Most importantly, this can happen when there is pacing issues, pacing failure, or premature pacing termination, or abnormal deployment, position of deployment, or device-related factors, obviously manufacturer defects. So how are you going to anticipate it? How are you going to treat it? So the device can embolize into the LV cavity or into the ascending aorta. So this is more common with balloon expandable valves, not likely with self-expandable, because self-expandable valves, they have the option of being retrieved and repositioned. So most common with balloon expandable valves. So if you see a balloon expandable valve being embolized, you bring it down to descending aorta using a snare and deploy it in the descending aorta. Whereas if it happens with the self-expandable valve, you can do it in the ascending aorta. And so this can, the most easiest thing to avoid this is using an LV pacing wire, because pacing failure is more common with RV leads. So you can use the LV wire itself as a pacing wire. So that is much easier. But make sure the wire is in contact with the LV myocardium. And what is the device? What is the procedure in the course of the wire? What are you trying to do there? Because I remember my experience, anything they will ask in the exam, like, so this is called lampoons, laceration of AML to prevent LVOT, outflow tract obstruction. So this is a major step in valve-in-valve tower. So this is already a prosthetic, bioprosthetic mitral valve sitting there. So we are trying to snip the leaflet there using a this is one of the application of electrocautery. So electrocautery now we are using for in prosthetic valves here. We are using in even electrophysiology also. There is wider application now. So here the course of wire is, we are making an AV loop here, and this is called as a flying V. And this area is actually denuded, and this will literally cut the leaflet. so that it will prevent the LVOT obstruction. So there are high risk indicators which will predict the LVOT obstruction post valve-in-valve replacement at the level of mitral valve. So this will prevent that. So this is lampoons. So this is a VA rail. So making a flying V is the most important step. Complex to understand in just few slides, but just remember that and what is the procedure and how to choose the site. What do you see here? So this is at the level of interatrial septum. That is bilateral septostomy. We're doing a flossing. So what is the site of choice? Interatrial septal puncture in itself is a topic and it has a huge learning curve. So where do you actually puncture the septum? Choose the fossa ovalis, center point of fossa ovalis. You are going to puncture when you going for PBMV or left atrial appendage closure. Okay. Posterior inferior in TMBRs. Posterior superior, it is mitral clip. I think we are done with the procedures. Time up. We have a few more. Okay, what are the plaque modifying strategies here? What's the first one? Easy. This is very easy. IVL, correct. Second one is rota. This is going to be orbital atherectomy. And the fourth one? Fourth one is that's the progression of the catheter. That's the laser catheter. The fourth one is the laser catheter. The progression of the catheter is very, very slow. That is the key to a successful laser. The slower it is, the better the results are. So the fourth one is the laser. That's the progression of the catheter. So mechanically, rotablator and orbital atherectomy, they mechanically chip the calcium. But IVL and laser has science in itself. Okay, so they're based on the conversion of energy. So energy is neither created nor destroyed. It can only be converted to other forms. So that's the science they follow. I think that's all. We ran out of time. Thank you so much.
Thank you, Pragati. Actually, you made it more interesting. What I have noticed with the students also is they are very good at what is related to newer procedures, newer devices. But ASCII was originally created for having some link with clinics with the methods. But of late, there are a lot of things what Pragati has shown is also being asked. I would also touch upon 2, 3 some clinically relevant things. But I would say that everything won't be so difficult. Don't get worried. Half of them will be very easy in ASCII, where anybody could pass. 50% is easy. Then just to supplement what great cases what you have shown, I really appreciate your efforts. And she also is interested in imaging, I think. That's why she collected all the data with other things too. Just briefly, can you get the ASCII talk? What I would like to just supplement is basically, I think many of you are aware how the exams are being conducted now, the practical exams. Just to take you through, once you go at 8:30, ASCII. Once you go at 8:30, they will take attendance, call you inside, and then okay. And then this is exam schedule. I think many of you know it. Then initially you will have this virtual ASCII. That is a welcome thing, no? All of you are made to sit in one hall and then you get two things. It will be directly relayed from National Board or the exams. The DMs also locally also they will do it. Then you will go to clinical case exams. Then post lunch you will have Viva voice and then finally you will also be given the catheters. And in the end, then the Viva voice, they will ask questions. I'm skipping some of the things. We could clear case exams. I think clinical cases, long cases, short cases. Then ward rounds will be taken through to each of these wards, if you're ICUs or whatever, depending on the hospital in which you can't come. And then after this, you're not supposed to meet your other candidates and go. And then in the final Viva voice, you will be asked questions in these 4 small subheadings: coronary artery disease, congenital arrhythmias and devices, and recent landmark trials. I think many of you could score and fumble, but if you have come to this stage, that means you've already passed. So I would just like to mention that everything won't be so tough. I think Pragati made it very interesting and showed a lot of good cases and a lot of new interventions. But I think many of you, I think I can assure you 50% of the questions you'll just walk through because they'll be simple. Another 10% could be tricky. Out of the 20 ASCII questions, this was first started in 21, later modified in 22 to 100 marks. The 150 was thought to be too much. Then each of it actually is given of 4 minutes. And then once you do it, then you can't go back. Yeah, this is the answer sheet, what is given. You are supposed to put the number and write what is asked. So these sort of things she already told you. For sake of time, I would skip. But what I would like to mention is basically they would give you some clinical scenarios and then show you something related to that. Sometimes it could be procedure also, as what Pragati has shown very well. So this is how it is. So they will show you a presented with ECG complete heart block and echo showing what? So basically inferior posterior aneurysm, that is showing scar. So what will you do like that? It will be asked, and you have to ask right specifically. What is the good thing about it is each of it has a mark, and if you answer one of it right, you get more objectively. There's no subjective examiner discrimination here. That is the advantage of having it. Suppose this is given 1 mark, you answer it right, you will give 1 mark. This is all goes through Tata Consultancy Services have designed a very good answering system also for it. So I can assure you that it will be totally unbiased. So if you did it 1, 2 correct, you will get half marks. So similarly, like each of this is a 2-year-old child presented with cyanosis. They would like to test your skill clinical with some of these imaging pictures. So mostly intervention aspect, actually our Upgradio Pragati exactly covered it. Like we wanted to cover more of interventions, and that's how she covered it. I'm very thankful to her. But just to show some of these echo pictures, some of the newer clinical scenarios, how you tackle it, all that also they want to test in it. Like 2-year-old child means what is a cyanosis in newborn? Rather than directly asking only in the clinical cases, they would also put such scenarios and give exactly marks for each. And then if you answer this right, you'll get 2 marks. However, better you write, you don't keep on writing 10 causes for that for 1 mark. You have to also time your things well. 4 minutes, you're supposed to finish. So if you answer however better and leave this, you won't get any marks for that. Structured like that. So that's why it's important. Some of these clinical scenarios will be given, and emergency patient coming with pulse BP not recordable, this sort of ECG. That means you have seen such cases in your emergencies. And then they'll ask you diagnosis, what you do, and how do you treat. So this is more something related to clinical presentation and one of the investigations. I think these things she has shown enough. When I was correcting papers, I was surprised, Pragati, that all the residents nowadays answer these very correctly. Whereas the clinical scenarios, they fumble. So they would write everything here, what is written. So there's a TAVR valve, there's a mitral clip, there's devices, there's electric appendage, everything they will write. So that's what is mentioned. That sort of things again, as clinical ECG monitors. I think what you know, what is this? Yeah, HCM, right. So this is out of appearance on echo, and then what is the syndrome called, typical echo findings, diagnosis, all that. So you will do well. And what I want to assure you is, don't think all the things will be tough as what Pragati showed. She really collected very good spotters. I think out of 20, 4 or 5 would be like what she has shown, interesting and rarer things. But 10 will be to routine, where you will easily score marks. Another 4 or 5 could be, this is what, 40-year-old male presenting with such high BP. If you know clinical scenario, automatic load is section. So like that, pointers also will be given to you easily. But only thing is that particular point you should strike and probably answer those, and don't waste your time. Answer appropriately as to the point. She showed something similar to it. So any of you remember this? I think it's outdated now. I don't know whether you people remember. So some things like this also will be asked suddenly. The commissioner term type of device, it is now given up now. This is a 2-year-old child, again presenting with that scenarios. Again, you should know the clinical history. Sometimes pediatricians are also coming to cardiology. It becomes easy for some of them. So this sort of thing, again, most of them answered this. I was surprised when most of the students wrote it correct. The impeller device, when it is kept, and they answered like this, name the other devices for similar purpose. You should also know. The marks will be accordingly written like this. So spend little more time here, not waste time there. That's important not to go into that. Spotters and echo shows such torrential MR, then probably you'll know the diagnosis. And then I'm going quick because we are running behind the schedule. What is this? Some of you must be heard this. and then you will get into it. And I was also impressed. In between, they're asking this also. Who is she? Padmavati, very good. So we should know about, he's a great man who showed in the morning. He still makes rounds on every Saturday in Brigham Women's Hospital, takes his residents through at 98 years of age. That is his commitment, Eugene Braunwald. Then some of these things again will be asked. It's not moving. Yeah. So something like clinical scenario, 50-year-old woman, emergency, sudden chest pain, sweating, hypertensive, pressureless, and ECG. That means you have to correlate both and answer. This sort of scenarios are little more commonly is given. Everybody will know. Yeah, nowadays you people do emergency duties also. That sort of things will be easy to answer. And then if patient lady comes like this, Takasubo, like this sort of things, special things, most of the fellows know it. And then she already covered very well. Some of the things, all this, I also thought what she's covering, I didn't know. That's why I kept some of these things. This is again thrombosection catheter. With COVID times, this has become very popular. No, what is this device? Yeah, I think you know better. Anyway, some of these things are the details. This is again shown in the imaging very well. So what is this imaging, dissection, all that. Sometimes such sort of things will be also asked, but mostly clinically relevant going to the images. That's what is covered. Such sort of ischemia going into ischemic torsades, and the ECG's diagnosis again, typical of it, this sort of pulmonary embolism. I think the other complication session is likely to come. Dr. Trehan sir has already come. She will enjoy those both. I think I want all of you to be attentive for the last half an hour or so. I'll just quickly finish. That sort of thing, MI is coming again, getting into it. This is what? Yeah? So this is balloon-attal septostomy type of procedure. Then ECG is such ghastly ECG, culprit vessel. These are some of the things which are normally also asked. ECG, culprit vessel and all, we know, no? That sort of simple things also will be kept. Don't think. This sort of tracings are again kept. Nowadays, it is less and less common. It is becoming, at least in corporate hospitals. But this pressure tracings also, one or two questions will be there. And saturations also, I tried to get some, I couldn't get it. Saturation tracings also, one or two will be there, congenital scenarios, where there is a step up at a ventricle level like that. And PDA level, what is the treatment, what is the latest modality, something related to that. Saturation studies and pressure hemodynamics also will be studied. Though it is less and less common, but these withdrawal tracings, Caraballo sign, LV to aorta tracings, all that, how do you identify infundibular stenosis, where you get again inhibited pressure trace, all that will be asked. I think these are some of the things I just wanted to touch upon the clinical scenario with cases, but I really appreciate Pragati for showing all the interesting, good interventional cases, a good collection with some complications. With this, I'll stop. If you have any other thoughts and things, we can go on to the complication session because we're slightly behind the schedule. Is it okay? Anything you want to ask in this ASCII? Because it's introduced first time this year, I thought some of you could be beneficial. Why I got this idea is when I went as examiner for DNB into Mumbai, when candidate came, sir, what you showed in the last meeting, they asked, they were thanking me. So I said, at least it is better that more students should be benefited. That's how we introduced a little more elaborate 1 hour sessions on ASCII. Hope you all liked it. If any of you wanted anything different, you can give your feedback to Lupin people. We'll again try to modify and do something better in next years too. Thank you. I think with this, we'll go to the last most interesting session, which is very well attended in all the conferences is complications. That's why we kept it at the end. Dr. Vijay Trehan is also, sir, is the master of that, and he has good collection. And I would skip my talk because of the sake of that is general talk, broad guidelines, how to avoid complications and all that. More specific will be discussed by them. I think I request you to announce the next speaker and call upon. Dr. Vijay Trehan will be taking the last two presentations. Thank you.
Thank you so much, sir. And please give a loud round of applause. I would, before we move on to the next session, I would invite Dr. Pragati on the stage. And I would request Ms. Deepa Nambiar to please felicitate Dr. Pragati. Thank you so much. The third and the last session is on complications of PCI. So we are going to start with the first topic, which is periprocedural coronary dissection, perforation rupture, which would be taken by Dr. Prashant Mishra. Can we have the CV slides? So Dr. Prashant Mishra is a consultant interventional cardiologist and in charge at the Department of Cardiology, Dinanath Mangeshkar Hospital. He is also the fellow of European Society of Cardiology, as well as the SKY. And he has authored multiple original work, articles, case reports. He is an ex-honorary executive committee member of Cardiological Society of India, Pune, and a postgraduate guide for DNB cardiology and MSc medical technology students. Over to you, doctor.
I'll be brief because the superstar is coming. The last talk. It's tough to cover such a topic. I have 20 minutes, and in 20 minutes, both didactic as well as a little case presentation to make it interesting. Why are these topics important? We are doing more and more complex cases. You are probably going to see even more complex cases. PCI has become much safer also at the same time. The hardware is getting better and better, but mechanical complications persist. The two most feared ones are coronary perforations and coronary dissections. They are rare, but if you don't pick them up quickly and don't react quickly, they are likely to be catastrophic. And therefore, understanding why they happen, what are the risk factors, and what are the management strategies, these are going to help you escape these situations. Now, what is dissection? Simply, it's a rent in the intimal layer, resulting in formation of a false lumen. The most common cause, and this is increasingly being recognized, is spontaneous or SCAD. We had an OSCE there. But iatrogenic is the one which we'll be covering in more detail in the next 15 minutes. This results in compromised flow in the coronary arteries. There's formation of a thrombus. And then there could be propagation of the dissection to more critical parts of the coronary anatomy. A little word on the SCAD. This is not a procedural complication, but identifying it might protect you or save you from a complex PCI. SCAD, there are two main types, theories why SCAD happens. One is the inside-out theory, wherein there is a rent in the intima. There is formation of thrombus at the site where the media comes in contact with the lumen, and this results in obstruction of the coronary lumen. The outside-in hypothesis is where you get a rupture in the vasa vasorum, which are the blood vessels in the coronary artery itself. And this hematoma formation in the tunica media compresses the lumen from outside. Both are different and both need to be approached differently. Coronary angiography itself may not help identify these two. We may require imaging. So what are the factors which precipitate it? Multiple theories, intense exercise, emotional stress, hormones, but there are predisposing conditions such as pregnancy, connective tissue disorders, familial fibromuscular dysplasias, and hypertension. And we can have them, we had a slide here in OSCEs. They are classified today into 4 main types. The first one is easy to identify. There is just contrast staining in the coronary arteries. The type 2 is more common. The most common of the types, we get a long, diffuse, smooth narrowing. But this does not extend to the terminal part of the coronary artery. You have a clear cutoff proximal to the dissection and distal to the dissection. Type 2B is the one wherein this thing, tubular narrowing, extends till the end of the coronary artery. It's like the rat tail appearance. And this is the most common type that you will encounter. Type 3 is a little tricky because it is a focal narrowing, and this very often looks like an atherosclerotic disease, and therefore may often be treated like an atherosclerotic narrow. Type 4 looks like an embolus. You will find this very commonly. It's very difficult to pick it up because we usually treat it like a thromboembolism in the coronary arteries. How do we treat it? Now, 80% of them would seal automatically on their own on conservative management. All we require is antiplatelet therapy, statin and a beta blocker, and monitor them for 3 to 5 days, and then continue the medication therapies. But there are certain set of patients which are high risk. They could be clinically manifested in the form of patients who are getting ongoing angina or hemodynamic instability, or they could be angiographic factors wherein this dissection occurs in the left main or in the proximal epicardial coronary arteries. Here, one may have to embark upon a PCI, and this PCI has certain caveats to it. Rarely you may require a bypass surgery, And then long-term therapy would be in the form of an antiplatelet or beta blocker. Here is a summary of what we can do. More than 80% of SCAD would heal over time, only medical management. If you indeed have to go through a PCI, the PCI is a little tricky. You have two lumens there, a false lumen and a true lumen, and therefore wiring needs to be extremely careful. One may use imaging, and here I, for instance, would prefer using IVUS. OCT requires us to give very injections at a pretty pressurized level, and this may just extend the dissection further. If you choose to stent it, you would require to use a longer stent because you need to cover a longer distance. Focal stenting here tends to propagate the dissection further down. Rarely, if you can pick up an intramural hematoma, you would prefer using a cutting balloon because this tends to migrate. You stent it, it goes further. You end up stenting another one, another. So I've seen 4 stents being done for a particular patient. Also, there is a caveat here. Recurrent SCADs usually occur at a different site in a different vessel. So fixing one SCAD is not necessarily going to protect you from the next SCAD. And late acquired stent malapposition is also a reality because this is not a coronary atherosclerotic disease. The hematoma or the thrombus resolves and you get hanging struts be left behind. And therefore, this is a lifelong issue that you would have subsequently. Rarely you require CABG, particularly with a SCAD that involves a left main or a proximal coronary artery. You would get excellent immediate results and clinical outcomes, but long term, again, once the SCAD resolves, you are going to get competitive flow both from the native arteries as well as from the coronary bypass grafts, and these bypass grafts are likely to fail. But our interest is more in the iatrogenic dissections. This has been classified by the NHLBI into 6 types. Type A is the one which we usually see. It's just a radiolucent area within the coronary lumen. Type B is when you see a parallel tract in the lumen, and this is separated by a radiolucent area. Type C is when the contrast can be seen outside the contours of the coronary artery. This is very similar also to the type 1 of perforation. Type D are the spiral dissections. Type E is when the dissection causes luminal compromise and persistent filling defect in spite of you doing everything. And type F is when you get total occlusion of the coronary artery. Immediate diagnosis. The faster you react, the better the outcome. You would get this staining and haziness and abrupt edges. Mind you, here the edges are abrupt. Usually if you have a thrombus which looks very similar, thrombus has a hazy or wavy appearance at its edges. Dissections tend to have sharp edges. You may choose to use IVUS or OCT imaging to clarify further, but sometimes, IVUS doesn't give you crystal clear images. OCT gives you beautiful images. But the problem here is the pressurized contrast injections, which may exacerbate the dissections. How do you treat them? The mild dissections usually heal on their own. All you need to ensure is that there is flow and hemodynamic instability. Severe dissections, first thing do first. Inflate the balloon that you have there and then think. You may require to stent it, either the entry point or both the entry and exit points. And we need to avoid propagation with gentle wiring and cautious contrast use. I'll have one case here. This is a 74-year-old, again complex PCI, hypertensive hypothyroid patient, bypass done, presenting with unstable angina, lab normal, ECG normal, echo fairly good. A coronary CT angiogram was done first, which showed patent Lima graft to LAD, a patent Rima graft to OM1, and a total occlusion of the dominant RCA. This is the angiogram. The RCA, which was ungrafted, is totally occluded. But if you can see, there were indicators that this was possibly a SCAD which had healed and probably resulted in a total occlusion subsequently. The Lima graft to LAD is patent. So is the Y-Rima graft to the OM. So the indication was to go ahead and do a PCI for the RCA. No catheter would fit. So an aggressive guide catheter that like the AL1 was chosen. The AL1 is a very notorious catheter. It gives you fantastic support, but it is nasty to handle. The CTO was crossed using our wires over a Caravelle microcatheter. The sequence of wires that were used was a Xion wire, followed by Fielder XTA and a Gaia Next 1 series catheter over a Caravelle microcatheter. Now this happens. You can make it out, but you have no flow here. So how do you fix it? And if you can figure it out, you're forcing through a 1-5 Uri, and the catheter is bumping in and out. It's an aggressive guide catheter, and there is simultaneously injection that has been given. So injection with aggressive use of the guide catheter, and you end up getting a dissection at the ostium of the RCA, which is involving the aortic root. Since there was no flow and no position, no place to even place a stent by now, a quick pre-dilatation with an NC212 balloon was done. Now that you have a flow, it keeps on increasing. So how do you fix this? Quick thinking and taking a stent and fixing the entry point. If you don't fix the entry point quickly, this will keep on dissecting further and you will end up having an aortic dissection. So just fix the entry. If you can make out, there's the stent coming. Inflated, and you get sealing of the dissection. You get flow. You're still scared because you have produced a big aorto-ostial dissection. And therefore, you wait in the cath lab till everything is okay, the patient's hemodynamically stable, and you end up with this. After 10 minutes, you have this big, nasty-looking dissection in the aortic root. We had imaging. We are an IVUS center, so we did an IVUS interrogation. It confirmed that the ostium of the RCA was sealed, and it was not expanding further. We had echocardiogram in the lab, and it demonstrated we could see a flap coming right up to the right brachiocephalic, but it wasn't expanding any further. So Dunning has classified iatrogenic aorto-coronary dissections into 3 categories. The first category is when you have only a localized dissection, which you can fix with a stent. The second one is a little larger, but you can still fix it with a stent. We tended to have this Dunning class 3 here, which had extended more than 4 centimeters beyond the aortic ostium, beyond the coronary ostium. This usually requires surgery. However, in our case, serial echo was done. The right radial artery continuously was monitored. There was no expansion of the dissection. A CT aortogram was done to confirm whether we had sealed it or not after 48 hours. It actually did not see any dissection. So there was no dissection on the CT aortogram. The patient was discharged home after 72 hours. 6 months follow-up has been achieved. So quick thinking and real fast time. All this procedure, the time that we are discussing here and talking here, 5 minutes, this whole procedure had to be executed. Coronary perforation, again, fortunately, a rare complication of PCI. The most common perforation usually happens in a CTO procedure with guide wire tips, which are aggressive guide wires. It also can happen if you oversize your balloon or stent or overexpand your stents. Atherectomies, which are becoming very popular now, especially orbital and rotational atherectomy, can predispose to perforations. And stent deployments in calcific nodules, particularly, can result in a perforation. It's been classified by Ellis into 4 broad categories. Class 1 is when the crater extends only outside the lumen. This is very similar to type C of dissection. Or class 2, wherein you have a small rent which is less than 1 millimeter and it only enters into the pericardial or produces a myocardial blush. You can also have a big rent, more than 1 millimeter, which ejects into either the pericardium, or if it's opening into a cavity like the ventricle or into the coronary sinus, it's type 3C. But it's more useful to have location-based classifications. You could have a perforation in the main vessel, which could be more catastrophic. Or you could have a perforation only in a branch where aggressive use of a CTO wire resulted in the wire tip perforation. So this classification is more practical in a sense. It delineates what kind of management you're going to do in the next few steps. You could have perforations with collaterals, particularly if you have a septal collateral perforation wherein a retrograde approach has been attempted, or an epicardial collateral perforation. Again, quick diagnosis is key. The angiographic appearance is very typical. You have extravasation or pericardial blush. You can have signs of cardiac tamponade, immediately get an echo machine inside, look for the cardiac tamponade and tap the pericardial effusion. The step, keep the wire in place, balloon tamponade first, and then think. It will give you those extra minutes to think and approach the case. Reverse anticoagulation should be the last step because you're going to use a lot of instrumentation to fix the perforation in the first place. Pericardiocentesis, and then think whether you want to do some coilings or you want to inject something or you want to use a covered stent. This is a universal algorithm. The first step is to inflate the balloon at the site of perforation. This will give you at least a few minutes to think. Use whatever means are needed to get hemodynamic instability, that is either fluids or vasopressors, pericardiocentesis if there is hypotension, and call up the surgical team. If you have a distal tip wire perforation, you can use embolization material in the form of fats or coil, or you can, if you have a small perforation in a side branch, you can use a covered stent to just cover it off and knock it off. So controlled myocardial infarction of a small branch. If you have a large vessel perforation, your best bet is to fix it in the cath lab itself. Yes, you have called the surgeon, but by the time the surgical team comes in, your best chances are using a covered stent and fixing the perforation there and there. Once you have done it, only then think of anticoagulation reversal with protamine. Distal perforation, cardiac tamponade may not develop with a wire perforation until many hours later, and therefore high index of suspicion should be maintained, especially if you are doing a CTO, PCI, because you're using very, very hostile wires. High index of suspicion and surveillance is needed. Sometimes do not overdo the overcollimation. Keep a watch on the wire tip, especially if you are doing a CTO PCI. Wire tip perforations can be managed with microcoils, fat, or glue embolization, or a novel technique that I just recently came to know of, a cut balloon technique. Side branch perforation management can be done, you can just use a covered stent and knock off the side branch. Fat is the most easy to obtain. It's also something that is easily available to an interventional cardiologist. It's just take out using an artery forceps, fat around the puncture site, crush it into a contrast media, and then use it to be injected with a microcatheter. Coils, there are extraordinary coils, particularly the neurointerventionists and the vascular surgeons use it more often. We as cardiologists are not very, conversant with these coils, and therefore I tend to avoid it because these are emergencies. You have to act fast, either learn one of those coils that are available in your cath lab or try and make your own coils. These are the coils that are available. I have no experience of using them. Probably Dr. Trehan, the superstar of managing these things, he is more conversant with it. But you can make your own coils. These are easy to make. A reverse wire put into a needle. This is something I've had two cases where I've used it. Cut it in between. Once you have it in the catheter, you can just inject into the microcatheter and use the reverse end of the wire or the remaining part of the wire to push the coil into the place. So here's how you can use it. Microcatheter in place. It's just the guide wire. We are used to these guide wires. Just pull it off. This is the kind we can coil it up. Or you can use fat, which is in a particularly obese patient, around the puncture site, remove a piece of fat, crush it with the artery forceps, put it in contrast. You put it in a microcatheter. Usually fat floats up. So it's useful to use the microcatheter upside down, and then you can flush it with your normal saline. This is a novel technique. I've never had fortunately never needed to use it, but this seems extremely easy. It's been recently reported. You have these balloons, and that balloon can be cut in between. So you have two parts of the balloon, the distal balloon, which can be loaded over the same guide wire from behind. And then you can use a new simple balloon and use it to push this broken piece of balloon to the wire tip where you have produced the perforation. So this is how it would look. This is a cartoon. This is how it would look. The broken balloon is down here. And then you use your standard balloon up there to just push the broken piece of the balloon distally. And once you have done it, you can just remove the remaining thing outside. And this would act like a coil distally. Because we are not so used to these specialized coils, this seems like an easy thing to do for wire tip perforations. Another technique that we can do is, most people would, experienced operators like to have control over the whole case. They would like to block the perforation first, think, and then do the procedure. So the block and deliver techniques are in vogue. Unfortunately, they require bigger guide catheters. And most perforations happen when you are least prepared for it and you're using your standard 6 French catheters. If you're using a 7 French guide catheters, you can block it, think, and once you have think, you can momentarily deflate the blocking balloon, put a wire across into the perforated vessel, put the microcatheter over the at the site of the perforation, inflate the balloon again, prepare all the embolization material while you have the vessel blocked, inject it. This will do two things. One, it gives you time and it prevents the embolizing material from coming into the main vessel. So this is something that you can do if you have a bigger guide catheter around. We can also do this for while using a covered stent. Same principle, block the vessel. You have angina, you have ischemia ongoing, but it gives you time to think. Again, use the guide wire by momentarily deflating the blocking balloon into the perforated vessel. Deflate the balloon, get the covered stent, and inflate it into the main vessel, blocking the side branch altogether. So controlled infarction is better than uncontrolled perforation. More and more people are doing retrograde CTO PCIs, and there is a problem of perforation of the epicardial collaterals. These are notorious because it's not that collateral is being supplied by both sides. So if you want to completely occlude the perforation of the collateral artery, you would require to coil it or embolize it from both sides. This position is not very suitable for using covered stent. So you will require microcatheters coming from both sides and embolization from both sides. One case, again, complex case, a CABG case, recurrent ACS, critical atherosclerotic left main to LAD stenosis. The graft to LAD, the Lima graft to LAD had cocked off. And the plan was to do a higher risk PCI to left main LAD. We were ready with an IVUS, rotablation, IVL, and IBP. This is a case of a colleague of mine. I need to acknowledge him. So this is the case. Nasty looking disease, old man. They could not even, they found it very difficult wiring it with a BMW wire and could not use a microcatheter to go down. So they needed a 1.5 Ruri balloon to make way for the microcatheter to go down, exchanged it with a rota wire. Rotablation done. And post-rotablation, reasonable tract is made. Aggressive predilatation with a 2.5 12 NC balloon done. Multiple predilatations aggressively done till they had a reasonable result. Now, an IVUS run was attempted, but the IVUS could not be delivered. If you can make out, the IVUS catheter wouldn't go. The guide catheter kept on being pushed out. But the operator was confident that he could deliver. He had delivered the balloons and he could deliver it with a guide extension catheter. So a GuideZilla catheter on this is a balloon assisted delivery of the guide extension catheter. And if you can make out, these are all fluoro safe, so the quality of the imaging may not be great. If you can make out, the first stent was taken, deployed. The second stent, an overlapping stent, was deployed. And fair result was obtained after the stenting. Now the post-dilatation was, so they had some idea, they had already pre-dilated with an NC balloon. An OPN 3.5 15 NC was chosen. I'll skip through this. They had this, and this is what they found. Now the patient starts complaining of chest pain and the blood pressure starts to drop and the blood pressure of the operators start to go up. So quickly pick it up. You should have this thing in your lab. Immediate positioning and deployment of a covered stent at that site saves you. Again, pick it up quickly, have this hardware with you, be conversant with it and deploy it quickly. 5 minutes later, reasonable sealing of the perf. An IVUS was done. I am short of time. So post PCI, again, these patients are not just on the table. They trouble you later also. So the patient had a little drop in his EF. There were multiple issues, but on post day 18, he was discharged. One must be conversant with the covered stents and every cath lab should have it. We used to have the papyrus, we no longer have it. It was a much more deliverable stent as compared to the graft master that we have. The graft master is basically 2 layers of stent, which has a plastic in between. It's very bulky, and therefore it very often is not easy to deliver. You may require even a guide extension catheter sometimes to deliver it. The most commonly used sizes that are the 2.8, 3.5, and 4 can be delivered through a 6 French catheter, but the bigger sizes may require a 7 French guide catheter. Again, the block and deliver technique can be used. You can block it while you prepare the graft master and deliver it. Again, as I told you, the problem with the block and deliver technique is you require upsizing of the guide catheters. And usually these complications happen when you're least prepared for it. So you rarely use an 8 French guide catheter for block and deliver techniques. Usually you have a 6 French or 7 French guide catheter, and then you would require to use something called as a dual guide catheter technique. This is a technique wherein you would require, you use the first guide catheter that you already have in place, a wire there, you use a balloon to inflate at the site of the perforation, seal it off. You have time now to think. Get access to the other femoral artery, use another guide catheter and go to the coronary lumen. Disengage your first guide catheter, re-engage it, and now you have your another catheter pass a wire when you deflate the first occluding balloon, and then position your covered stent there. So in case you have to use this block and deliver technique, very often you would be operating with a 6 French or 7 French guide catheter. You would require this technique with two guide catheters. It's also referred to as the ping pong technique. My take home message is here. Coronary perforation and dissections are rare. They are potentially lethal complications. One has to recognize them early. Only if your mind is clear, you would have a calm and structured response to it. And this calm and structured response does not come only from the operator. The second operator needs to be as calm, and the whole team needs to know what you're ending up doing here. One must prevent these, one must be careful with your hardware, respect the vessel anatomy, careful wiring, careful stent selection, careful hardware selection, avoid over-aggressive sizing and post-dilatations, and avoid unnecessary contrast injections. Ensure that the lab is prepared. This requires preparation in terms of inventory that you have in the lab, as well as team training. And this team training needs to be done again and again and repeatedly every year, because these complications are rare and memory is volatile. I end here. I know there is a superstar waiting who has seen much more complications and scenarios than anybody else, I suppose, in the room right now. Yeah.
Thank you so much, Dr. Mishra. Next, moving on to the next session, we have with us a distinguished faculty in the form of Dr. Vijay Trehan, who doesn't need any introduction, and he would be taking us through the session on this complications.
I'm so sorry.
Can we have
there
the
is a
ceiling
lot
slide,
of
please?
hodgepodge as far as responsibility is concerned. Initially, I was told to pick up whichever I want. I thought I'll talk about.
But we should be extremely thankful. All the
so,
students should be thankful for your
since
interest.
I have some responsibility tomorrow morning, I had to just rush from Delhi, and
He came all
missed
the way
the
only
ride.
to deliver this talk. Thank you very much, sir. And he has to go back again for his commitments tomorrow morning. Thank you.
So, like I attended the last session, and I knew that most of the attendees are really interested in learning. So I was asked to talk about basics. So I think all of you must have seen this. And this Netter diagram, most of us see, but if you have to interpret a 3D moving structure on a 2D flat, you may see as many number of diagrams. Once it comes to reality, it will be almost impossible for you, and you'll be totally confused. One of the simpler ways is to have an exposure to an angiogram like this. Anybody can tell what is this angiogram like? Anybody? What is this way of angiography? This is a panoramic view. This is also known as rotational angiogram. If you see it, what is happening? You are rotating your C-arm like this, right, left, and you're going like this, cranial caudal. So if same arterial tree, if you try to see what happens to the vessels as you turn the eye from right to left, and what happens to their relation as you turn it craniocaudal, that is probably the best way to learn as to how to interpret the angiograms. You will see some lesion now. You don't see that lesion in the circumflex. Again, you start seeing the lesion here. So that tells you that some of the lesion may be missed in some views, but may be picked up in other views. A flavor of the same. And we know that for most part, the coronary lesions are not concentric. They are eccentric, and if they are eccentric, the shadows are also eccentric. Let me just poll. Anybody can tell what is proximal RCA, mid RCA, and distal RCA? What is proximal LAD, mid LAD, and distal LAD? What is proximal circumflex, mid circumflex, and distal circumflex? And a huge number of classifications. They only do what is confuse you. Just remember this thing. Right coronary artery, before it supplies the right ventricle, is prox. After it has supplied the right ventricle, it is distal. And whatever is left is mid. You can click a photograph. What do we say nowadays? If I say prox right coronary artery, what does it mean? Means so, despite syntax, you will still have all the reports like this. It is like Medina classification trying to tell you nothing, but still it is there. So, for right coronary, before it gives any branch, it is any right ventricle branch, it is proximal, and after it has supplied the right ventricle, it is distal. Rest is mid. Similarly, in the left anterior descending artery, before giving any branch is prox, and after giving two major branches, it becomes distal, and rest is mid. And in the circumflex, generally it is non-dominant, and if it is non-dominant, before giving any branch is prox, and rest is distal. But if you have, it's a left dominant system, then barring the last branch, just short of the last branch, we call it a mid, and the last branch is considered as distal. So that was just because often there is a lot of confusion, and it is difficult to remember. So you can remember this thing, which will be applicable everywhere. So if I ask anybody, what is this view like? Can anybody tell what is this view? I don't know whether this is dextrocardia or levocardia, but what is the view like? What do you say, aracaudal? Because left coronary, left stem is going to the right of the screen, and LAD is going horizontal, and the circumflex going vertical. That's what it is. If that is the answer, then you are absolutely wrong. Because if you have to tell somebody that come to my home, and where is my home, if you tell him लाल गाड़ी खड़ी थी उससे अगले जाके, then you turn to the left side, or there is a hawker and you turn from the hawker to the left side. No, you always have to talk about solid and rigid parameters. And this, like, you can talk about a tree, you can talk about a building, you can talk about a pole. So to say that this is catheter in the descending aorta, which is posterior, and right side of the screen is anterior. And most of the projections which you take for coronary angiogram are all obliques. So if the right side of the screen is anterior, this is RAO. And if there is no diaphragm, it is either no cranial or caudal. Now what is this view? Spine is on the right side, so this is posterior. Left side of the screen is anterior, so this is LAO. Left side is anterior. Right side of the screen is spine is posterior. So this is LAO because left is anterior. And if you see it, this is the diaphragm. If you see the diaphragm coming on the heart itself, you can see diaphragm only if you are seeing from above. If you are seeing from in front, you don't see diaphragm because the heart is above the diaphragm. So if you see from above and you see the diaphragm, in fact, you see the diaphragm even above. This is not working. and you see the diaphragm even above the origin of the coronary artery, so it has to be cranial view. What is this view? If you see, this catheter is more or less central. If you see descending aorta is more or less central, and then you have some part of the heart on this side, some part of the heart on the other side, majority of the heart on the left side, some part on the right side. So what is this view? AP view. Is it cranial or caudal? At least you don't see diaphragm, so it is not cranial. I don't know whether caudal or not. What is this view? Anybody, what is this view? You have a spine there. So this is right. The spine is on the right side. This is anterior. So what is anterior? Left. Left is anterior, so this is left anterior oblique. And what is this view? This is posterior, and this is anterior. This anterior is right side of the screen. So this is right anterior oblique view. Now, a word about, see, if you take this RA caudal, then you're usually focusing at left main and proximal LAD and circumflex. They can also be seen, but very often you will have more of overlap there. If you take PA cranial, then what you are talking about mainly left main stem and proximal part of the LAD. If you go to iliocranial, that means you're seeing LAD prox mid, you usually don't see the distal part. You have a lot of foreshortening here, and also see the terminal part of the circumflex. Iliocaudal, you see left main and prox circumflex and LAD. And PA caudal, you also see bifurcation of the circumflex. In the right coronary artery, the LA view try to tell you about the proximal right coronary artery. The right anterior oblique view tells about the AV groove very well, and then the branches which are supplying the ventricle. But near the crux, you don't see things well. This is a lot of foreshortening at the crux. If you want to see the crux, then you have to go cranial. And if you go cranial, then you start seeing the AV groove on the left side and the ventricular branches very well. So this is how you should be able to interpret the vessels. How about dominance? Anybody? Simplest way is the right coronary artery, if it reaches the crux and goes beyond the crux, so it is dominant. And if it gives 2 or 3 branches, it is hyperdominant. If it gives just one additional branch beyond PD, means it is dominant, like small dominant. If it is giving only a PD, then this is codominant. And if the PD is coming from the left, then this is a left dominant system. Now, anybody, what is this angiogram? Whole of the hall. What is this? What is this vessel and what are the view? So here is a spine. If spine is here and this is posterior, so this is anterior. If this is anterior, so what is the view like? This is very good. So this is right anterior. This is RA view. This is not working. Can somebody give me? So this is RA view. And second is you are able to see the diaphragm with an overlap of the heart. So this is RAO with cranial. So what is this vessel like? RCA. Have you ever seen it like this? Never seen it like this. We always keep seeing it like this. So this patient had a dextrocardiacitis inversus, and the angiogram was done like this, and everybody was confused. So then all what was done was just ask the technician that you reverse left, right, and do the way you are doing an angiogram. And in doing the coronary angiography, what you have to do, rather than doing a clock, you try to do a counterclockwise rotation. So having talked about all this, can anybody tell me, is it a good angiogram or a lousy angiogram? Anybody? You see, it is supposed to be inside, but what is happening? It is going in and getting out. That is what a catheter is not supposed to do. Also, it is losing a lot of dye in the aortic sinus, and if it is losing a lot of dye on the aortic sinus, which is overlapping onto the LM and the bifurcation, you are likely to miss things. So if you are doing an angiogram, a lot of people you must have seen, they will be doing an angiogram, one view, then the other view, and then finished. You must always engage the catheter again. All what is required is just push the catheter there and do a clockwise rotation. The moment you push the catheter, do a clockwise rotation, the catheter stays there. It doesn't get out. So if it doesn't get out, it tries to show you what it is supposed to show. Now it is showing you only half the thing. And what rest is supposed to be done by it, it is not doing. So the operator did was inserted the catheter in, pushed it a little bit, did a little clockwise rotation, changed the angulation, and you start seeing something tight disease at the circumflex ostium, which was not seen. So if you're doing an angiogram in which you're just shooting dye, which half of it is getting lost in aorta, it's a useless angiogram. Here you are able to see almost everything. Now, what about circumflex osteoproximal area here? So we are not able to really comment on it because there is a lot of crowding. If you see it, the catheter is in, it is not jumping out. Most of the dye is going in. So as far as technical part is concerned, that is correct. However, the angulation is not very good. So you have to change the angulation. See, the operator changed the angulation and he started to see something here. Can you see? Something at the circos. And if you change the angle further, then you start seeing, you see the branches are so big and the circos is so small. So many times to do a good quality angiogram, you should be able to engage the catheter well in so that you don't lose dye in the aorta. And then sometimes the standard angulation do not show you things. So you might have to change the angulations to make things clear. Everybody can easily point out that this is a very tight left main disease. So we have made these mistakes and think some of you will also make some of these mistakes. Such patients are often sent for surgery straight off. It's very difficult to handle left pain. And after surgery, not this patient, one of my patients who was like this, and angio was done by one of my professors. And I think about a year later, Dr. Kaul gives me a call. अरे तेहान तुमने क्या किया? देखो एक पेशेंट का तुमने सर्जरी करा दी है. After that, this patient is again symptomatic, and we've got his angio done, we've got his CT angio done, and coronary arteries are normal. So these mistakes we keep making. So this kind of a LM osteal disease, only a little bit of vasodilators are given. If you see that what is happening, this os has become pretty large. You give little more vasodilator, wait for a time, it's possible. Even this by itself will not ask for surgery, because if you look at the MLA will be pretty large here, about 10 millimeters square plus. So if you have any narrowing at the ostium, often we know right coronary, but left coronary we don't know. And sometimes we are scared to give vasodilator, especially if a patient has a BP of 80, 90. If a BP is less, just try to bring up the BP by giving pressors, and then shoot vasodilators, not 1, but 2, 3, 4, 5, not small dose, but hyper doses, so that you finally settle that there is no vasospasm. And if possible, you should be able to do an intravascular imaging before you really send these patients to surgery. Now this patient, again, left main osteal disease. Little later, I realized that this is not left main, it is LAD again, but the disease was at the os. Dilators were given, and this is how you see the os of the LAD is pretty wide. So all what is required is you treat this part, you don't need to treat here. So remember, if you are doing an angiogram, especially anything close to the tip of the catheters, not right at the osteum, it may be even a centimeter or so, or even beyond that, you must always try and engage and give as much vasodilators as is permitted by patient's hemodynamics. The reverse is also true. It is possible that some disease was there at the osteoproximal area, not a terrible disease, but you missed it. Why did you miss it? Your catheter was out, so your pressure was fine. Or you took small catheters, you took a 5 French, and that is also tapering, and you were not in, so your pressure never told you. And in this patient, again, the disease was missed, but you still see that some disease is there. So that may be important if you're trying to handle a LAD D1 bifurcation through a moderate disease at the LAD os. So it is very, very important if you're doing an angiogram, don't miss even a mild to moderate disease, especially if you have to do an intervention lower down, because a complex intervention requiring lower down might require a bigger guiding catheter. And then if you're doing a, let's say in this case, there was a big LAD-D1 disease and you didn't pick up the disease at the LMOS, it is possible you create complication during the procedure. You try to be rough at the os when things are not going and you dissect the left main. So very important both ways, not to miss and not to overdiagnose the ostial disease. This is one case which was, I think, one of our hospital employees' brother was there. He came with the inferior MI and that was a focal lesion which was stented, and a couple of hours later the patient come back with severe chest pain, ST elevation, AV blocks. So we thought RC is occluded, but to our surprise, RC was flowing, stented. This was a stented area. This was a PLB was stented area. That was all fine. And it looked as if it is a dissection there. This could be dissection here, dissection there. I don't know what it is. It could be a thrombus formation a couple of hours down the line. It could be a intramural hematoma. Anybody? What should we do? Somebody very softly said imaging. We didn't have imaging with us at that time. So it looks that whatever was looking dissection, if you see carefully, there were two branches. They were close to each other. So that was looking as dissection. So that's not a dissection. One should always remember that sometimes tiny branches are overlapping and they give you a false impression that this is a dissection. It could be an intramural hematoma. So we thought, whatever, at least this is what it was post-stenting and this is what it was now. If you very carefully look at this part is much narrower than this part. So problem has probably started here. And if you look at it, even down the line, this part is much smaller. This part is also much smaller. The magnification is same. And this part stays more or less the same. And this unstented area is much smaller. So whatever other intramural hematoma has spread everywhere or dissection has spread everywhere, unlikely to be a thrombus. So wired it, despite wiring. So if it is a dissection, fundamentally, if you wire a dissection and if you are a true lumen and if you are able to take a wire for sufficient length, not that 3 centimeter soft radiopaque part, but if you're able to walk with the wire for another 4 or 5 centimeters, then usually that part of the wire which has some support, if that support is there, it will take up the dissection. And suddenly a vessel which was closed will be temporarily stented and the flow will start. So the best way to distinguish between all these things, especially if you want to differentially diagnose a dissection from others, the moment you wire, and especially if your wire is at a little distance, not that soft wire, suddenly the flow will improve. And the moment the flow improves, it tells you that stent is. Because this is a temporary stent, it has brought a good flow, put a permanent stent. So there was no improvement after wiring. What should be done? So we gave vasodilators as we normally do. But in this case, I think I must have given at least 30, 40 times the dose of the vasodilators. And why I was giving? Because for me, it was very difficult to explain all other things. And it possibly looked like a dissection, but then, and dissection could have, it is possible that dissection spiral goes there and closes it and spreads into the other division also. But once the wire is there and it's not improving, it's very unlikely to be dissection. And that, of course, will immediately pick up with this imaging. So this is after super doses of vasodilators. So here, in continuation of my vasospasm, I try to tell you is even much away from your catheter tip, much away from the instrumentation, much away in time. This is 2 hours down the line. It is possible that diseased vessels can get into spasm. And vasodilators are very easily available in the cath lab. All what is required is if you give a vasodilator, double the dose, 4 times, 10 times the dose. Just try to raise the central aortic pressure by giving a vasopressor intravenously, which will not go so much into the coronary artery. So IC you give vasodilator, so very high dose of vasodilator IC and a vasopressor systemically. This is what has happened in this case. So you can go from here at least with one message that in case you have anything where there is a possibility or suspicion of spasm, which should be there, then you should always try and use vasodilators in super recommended doses. So this is a LED which was occluded, and we tried to handle it with a long stent. And following stenting, the flow was not very good. So we thought probably something is wrong. We pulled the wire and tried to see it. Some flow is there, not very clear. Now the wire is deep, the flow becomes better. Looks like a dissection. And now the flow is somewhat better. Some vasodilators have also been given. So that's a way. This also shows you that there is a disease here. But if you see, the question is to read the angiogram properly. If you see it carefully here, this disease is milking. Can you see it? If you are not careful, what under the whole circumstances, the interpretation was that there is a dissection distal to the stent, so put one more stent. And initially flow was not there, the wire brought the flow. So very high chance that the dissection was there. So as I told you that if wire brings the flow, that means it's a dissection. In this case, the wire brought the flow and the vessel started to grow distally also. But another projection tells you that this part is milking. If this part is milking, so this is not a dissection. This is a myocardial bridge which is at the edge of distal edge of the stent. See, if I show you myocardial bridge simply, probably that will not help you in management of your cases. But if I show you that if you have a myocardial bridge at the distal edge of the stent, then this can masquerade like a dissection or a thrombus or IMH. Now see it carefully. Can you see it? This is milking well during systole. And if you see it, this is a diastolic picture. This is the distal end of the stent and vessel. Now see that this is a part which is fully milked. This is under the bridge. This part is under the bridge. Another projection. Now you see it. Now you can see it carefully. In fact, I'll give another view. Focus here. Can you see here milking well? In fact, if you see, this is a systolic frame. LED is almost not seen. And here diastolic frame, here you see the LED. So, very simple thing. Mid LED, if there is something distal to the stent, it is looking to be something which is not acceptable and you want to put a stent, resist. Because stenting into the myocardial bridge segment is not like stenting into the rest of the vessel. A bridge segment is generally a segment in which you do not have enough muscle in the vessel wall, but you have a lot of muscle outside. So if there is not enough muscle in the vessel wall, media is relatively small, adventitia is also very small. And in fact, if you try to scan LED perforations, let's say if you look at 100 LED perforations, vast majority of the LED perforation will be in the mid segment. And this mid segment is typically a segment where vessel is bridged, where the support outside is very good, but the vessel was weak. So always be careful. If there is a stent which is going, the distal edge is going in the middle of the LED, then, and if there is something after stenting, then be very careful. Try to think that is it a bridge? And for looking for a bridge, you might have to sometime give intracornal epinephrine, which will make the contractility more, by which you will see the bridge segment much better, and might have to take different angulations. Whenever you're doing an angiogram, always keep a very careful watch on the pressures, which sometimes we have seen it here and then we are injecting. But by the time you are injecting, it is possible things have gone there. So be very careful, because if you find either dampening or ventriculation, I think pull out the catheter. It is almost never an emergency to inject if the pressures have, you see, it is not too much of dampening or too much of ventriculation, but even this is enough to create a catastrophe from which you may not be able to get out. This artery looked all right. This catheter, everything is fine. But many times the vessel goes into spasm, the RC goes into spasm after the catheter is there. You go into a wedge position, then you inject. Sometimes you are taken the view in the LA view, now you're going to the RAO, and in that shift of 10-15 seconds, when the technician is trying to adjust, some stool ad gaya, kuch ho gaya, and then it takes few seconds. By that time, now the operator is totally off the pressure. Wrong. You may be off the pressure, but just before injection, you should always be on pressures. It is like you're driving a vehicle, you're driving a two-wheeler, your clutch should be pressed only at the time when you're changing a gear. Otherwise, your clutch should always be on. Same is your clutch of your pressure should always be there. It is only when you want to inject, you should defeat that clutch and go ahead. Just see what happened. Will anybody suspect that this kind of a artery can dissect and go off? In fact, it dissected, patient arrested, and then there was a lot of hue and cry. Finally, it was some senior operator came and salvaged the patient. But remember, if you're not able to find the right coronary artery in the right sinus, then you should try to look for it in the left sinus. But if you're trying to hook the right with a emplatch, sometime right may not be wedging into the right coronary artery. It may be wedging into a conus branch. If you look at it, you have wedge injected into the conus and conus has got perforated distally. See it? Just an injection. No wire, no balloon. He showed wires and balloons causing perforations, but here you see just an injection. And you're injecting to the right coronary artery, but you're perforating a conus branch. See here? It's got worsened. Because you did not realize that the emplatch catheter is hooking the right, but it is wedging into the conus. So, and these are one of those things which your pressure waveform will also not tell you. Because you are wedging into the conus, but you are free into the main right coronary artery. So we should be very, very careful with those catheters which are aggressively hooking the vessels, and otherwise you will get into situation like this. And my friend just showed one. This is another one. And the only thing you should just see them here. And according to me, you should never ever create them with you, because if you create once, it will be very, very difficult problem for you, because it will not be here. It can go down in the form of AR, it can go up in the form of arch vessels involvement, rupture of aorta, pericardial effusions, and whatnot. I mean, left coronary artery could be involved. So try and avoid. And single Guru Mantra for avoiding this thing is, anybody? How can you avoid this thing? Single Guru Mantra. Always be on pressures. Okay? And don't, you can use guide extension and don't rely on kind of side holes. Even they can produce catastrophes. See, this was a vein graft, and the vein graft got evulsed. Coils were put, and again the injection was powerful. So even through the coils, the perforation is worsening. So don't ever inject. In fact, this is a catheter which was supposed to go into the, see, this is a your standard catheter which you use from the radial, and a lot of people try to slip it into the left ventricle to take a shoot. And why this happened? Simple thing. You are not on pressures. This catheter is used for doing right-left. You daily do the radial through radial right and left, but the operator slipped it into the ventricle and did not realize that you are not free into the ventricle. He did not suck it, did not push it to the pressures. So leave aside vessels, you can even dissect the ventricle. So be very, very careful. And sometime while you are handling tortuous vessels, you can have pseudo lesions, you must remember. And some of those lesions could be ghastly like this. The moment you pull out the wire, they start looking very good. If you don't see left main, you're trying to see left main on angiogram, what will you do? If it is a young person, it is possible. If you're dealing with L-kappa and everything is going from left to right. But if it is an adult, then great chances that LM was occluded at the beginning and you probably didn't hook it. It was still possibly going to show you some remains, but whole of the rest left system may be filling from the other side. Or it is possible that you are having an anomalous left, which could be either a single left or could be a both LAD and circumflex coming anomalously. Now this patient came to us, and patient came with chest pain and some ECG changes. There was some lesion here. We're not very sure whether this can account for a rest pain. Did the left, then did the right. So what's the diagnosis? Anybody? Where is the circumflex? So the only thing is you just have to pull your catheter a little bit and see that circumflex is originating close to the origin of the left anterior descending artery, short left main. Now here, we don't see any additional LAD. This is LAD or LAD is blocked, and the patient came with significant STT changes at rest. Right was normal. It is only if you see the iliocranial, you see separate origin and a tight lesion there. So must always disengage a catheter and take a shoot. Where is the circumflex here? Can anybody tell? Open question. It is not coming from here, or it is this circumflex, I don't know. Maybe this small tiny circumflex, unlikely, is not coming from here. What should we do? Anybody? And if nobody is saying, then the answer is just pull out the catheter and see. Circ is going from the right sinus. So whenever a vessel is missing at the os and you are trying to look for it, your only responsibility, just pull out the catheter a little bit and shoot. A vessel having a close bioregion will be very easily seen. And as I told you that if right is not coming from right, go to the left, shoot from there, you'll see the right there. Anybody, what's the diagnosis there? This is right, which is coming from the LAD. RA view, LA view, and lateral view. And this so right. Sometimes the right is coming from the LAD, and the picture is like this. This PD-os is not seen very well. Only what is required is just go a little cranial, decrease LO, and you're able to see. This is what tells you as to how this patient came with chest pain. Can anybody point out what is the problem here? This was a tiny diagonal which was missed. This is one of my friends. He stented his diagonal. He had a all frank picture of anterior MI. Similarly, this patient came with a rest pain, positive troponin, and near normal ECG. ECGs are not showing us any clear-cut MI. And that thing usually happens in circumflex. See, right coronary artery is fine. If you try to see here, this area is bare. And these OMs are very notorious that the ECG will be kind of fine. So we wired it. And so whenever a patient has come with chest pain and you find some area is bare, just try to relocate it from different angles. Dr. Srinivas, test your skills. What is this going down? What is this coming here? What is this going here? That was just to break the sleep. Look at this. What is this angiogram? So you have a right here, you have a circumflex there, you have a septal separately originating from the right sinus itself. So sometimes septals can come directly from the right sinus and circ may be going there. And so you must know this is septal which was directly hooked. And how about this? And I stop my talk here. All of you can interpret this angiogram, what it is.
Thank you so much, sir. Once again, a loud round of applause for Dr. Trehan, sir. So this was the last topic of our today's session. And I would request Mr. Rohit Mandro, and also I would request Dr. Naresh Trehan to please be on the stage for felicitation. So Mr. Rohit Mandro will felicitate Dr. Vijay Trehan. Thank you so much, sir. I would now invite also Dr. Prashant Mishra. I would invite Mr. Neeraj Nashine to felicitate Dr. Mishra. Thank you so much.
How many? Advantage for right now.
9 o'clock.
The session start. We here. Tomorrow we have. मैं बोल दूँ.
I think, hope all of you liked today's proceedings, and highlight of at the end was again by Dr. Vijay Trehan, sir. Thank you, sir, for coming only for this and in spite of your busy schedule. And it helps a lot of residents to learn a lot of new things. That's why I particularly requested him. Tomorrow again, we would have two international guest speakers coming. Dr. Megha Prasad will share her experiences in Zoom regarding CTOs. And then you also have Dr. Ramesh Daggupati sharing his experiences on structural interventions. So I request all of you to have early breakfast and be in the hall by maybe 8:50, 8:55, 9 o'clock sharp. We'll start tomorrow's proceedings. We have interesting, today's was focused on coronary interventions. Tomorrow it will be structural heart interventions and newer innovations coming up. We'll also have some interesting sessions on newer innovations like stroke interventions, renal denervation, and many other structural interventions, interesting complications. And thank you all for a good interactive discussion today. And hope all of you will be back in the hall tomorrow by 8:55. Thank you. Any final words from Lupin?
Thank you so much, sir. So we end today's day, and I would invite all of you for dinner, which is served at the back. Thank you.